Dr. Sana, good afternoon. Am I audible to you? Can you unmute and check the, that whether the setup is working well? Dr. Sana, am I audible? Can you unmute and check whether it's functioning or not?
Hello, sir. Assalamu alaikum.
Walaikum salam. Is it working?
Yes, sir, it is
Am
working.
I audible?
Yes, you are completely audible, sir.
Yes, yeah. You are also audible too. Okay, just wait for a while. Dr. Nina, am I audible? Dr. Nina, could you unmute and let us know that whether, can you please do the slide share once to check whether it's functioning or not? Are you there, Dr. Nina? Dr. Nina, you can share your slide once whether it's functioning or not. Can you unmute and share your slide once if you are having any slide? Yeah, it's visible. It's visible. Take it. Okay, you can stop screen share and let Dr. Sana start the program, and then you reshare the screen. Dr. Nina, could you stop sharing the slide and you can share it again. Let Dr. Sana Shadab start the program. She will talk the inaugural talk, and then she will invite you for the talk. Thanks, Dr. Nina. Dr. Shadab, are you there?
Yes, sir, I'm there. Hello?
I'm not able to see you. Can you,
Yes.
open your camera and unmute? Yes. So now it's 2:55. I think it's live on MedSkill portal as well, medskill.in. It's also, the participants can directly come into the Zoom meeting room, as well as they can watch it on medskill.in portal. So it's available both the places. And over to you, Dr. Dr. Sana Shadab, to
Yes.
start your inaugural talk, as well as start the show. Thank you.
Oh. Shall I start?
Yeah, it's your show. You can start.
Okay. Okay.
Hello, can you just allow me to share screen? I want to share Dr. Nina's presentation.
No. You can share after the talk of Dr. Sana. You just
Okay.
leave it for 3-4 minutes. You start, Dr. Sana.
Okay. Hello, everyone. I would like to say, शहर का तब्दील होना, शहर का तब्दील होना, शाद रहना और उदास, रौनकें जितनी यहाँ हैं, औरतों के दम से हैं. Absolutely. The power of women gathering is immeasurable. Assalamu alaikum and a very good afternoon to one and all. I'm Dr. Sana Shadab, working as senior resident in Department of Conservative Dentistry and Endodontics at Ziauddin Ahmed Dental College, AMU. And it's my pleasure to welcome you all to the second Pink Dental Congress 2022. I would also like to congratulate the pioneering team as a whole for taking this beautiful and bold initiative to organize a women-centric conferences. And I personally feel that I'm very lucky and blessed to brought up in an era where we are witnessing a remarkable progress of women in every sector of society, whether it's education, health, sports. But deep inside, we all do know that a lot more needs to be done on a ground level, isn't it? As Malala Yousafzai said, I raise up my voice not so that I can shout, but so that those without a voice can be heard. We are all cannot succeed when half of us are held back. And the beauty of this conference is that we are going to deal with every niche of women related issues, whether it is personal or professional, through the enlightening seminars, through renowned speakers. And this thought is what brings us today together. We share a common future, and we are here to find a common ground so that we may help to bring new ideas, knowledge, and can share our experiences, whether it's good or bad, with each other. Because when we boost the participation of women, we boost the growth potential of the country. And so we all are here for our country. So on this note, and taking our program further, I would like to call our first speaker. But before I will say that the best jewelry a woman can wear is her confidence. And our next speaker, Dr. Neena Moitra ma'am, has tons of that. She's working as a consultant orthodontics in New Delhi, and she did her graduation in dental surgery, followed by masters in orthodontics from Government Dental College, Ahmedabad, Gujarat in 1987. She was a consultant to the Max Group of Hospital at Noida and Patparganj. She has also been the president of IDA East Delhi. She is an eloquent speaker, stylish, polite, humble, and accomplished doctor. Thus, who's better to speak about personality development than her? Let us welcome this warm and dynamic personality to enlighten us. Please, ma'am.
Thank you, Dr. Sana. That was so nice, and you spoke so well. And the share was, all the women just love you for saying that share for us.
Thank you so much, ma'am. And you're looking really very beautiful. I can't control.
Thank you so much. Thank you so much. So my presentation today is improvement begins with I. Till we improve, nothing else will improve. So most of the times, I have to introduce Dr. Akanksha. She is a fellow orthodontist, and she is going to be asking me questions. So it becomes a little more interactive.
Can you please allow us to share screen?
Dr. Nurul, can you allow us to share screen?
Just. Neena, Dr. Neena, what name you are logged in?
Akanksha.
Just, yes.
AKA.
Got it.
Yes.
Yes. Now you can share the slide. Yes.
Yes.
Sorry for the delay. Just getting there. Yeah, it's fine.
Yes.
Yeah.
Yes. So we begin today, and I would like to ask our very successful woman in business and an esteemed personality, what denotes a personality?
So most of the times when we think of personality of a person, we think about their hairstyle, how they look. As women, we see what is the nose looking like, what is the eye color. But actually, personality is much more than that. It is what is inside of us, not only the outside, the exterior surface. And the example that comes to me right now is of Guneet Monga, who's just made us proud by winning the Oscar. And I know of Guneet's journey. You know, she lost her parents when she was just 22 years old, went to Bombay when she was 28, and today she's about 38 years old and holding an Oscar in her hand. She is a complete personality, I would say, and makes us all Indian women so proud of being an Indian woman.
What, according to you, does a personality include?
So personality has all these things: extraversion, introversion, warmth, creativity, openness to new experiences, and so on and so forth. But the main thing I would say is self-awareness. You should be aware of what you are, and it comes from deep-seated experiences which you have gathered all your life.
So, ma'am, how is personality formed?
So as we know, see, personality is formed by many factors. It's got genetic factors. You're born with certain genes. You come into a family which is an extrovert family. Some genes are there. And then rest of this happens with your school experience, your college experience, your cultural experiences, your peer pressure. So personality is a wholesome thing of your genes and your environment. So it's a nature and nurture, both the things develop your personality.
And when do you think is personality formed?
So personality starts forming right from the time you are born. But as you grow up, as you get into your teens, you develop a certain personality. But by the time you're in your 20s, the frontal cortex is developed, and that results in a stable personality. So by the time you reach your 20s, you have a definite personality. Although with general experiences of life, lows and highs that we face, personality gets adapted to it.
Dr. Akansha, sorry to interrupt you. Dr. Akansha, could you please slides show mode? Could you put your slide? It's not visible. Could you make your presentation in slides?
The slides are not visible?
No, it's visible, but it's not in slideshow mode.
Oh, it's not in slideshow mode.
It is, but I'll try again.
But now it will be better because I think you must have shown faster right now.
Yes, yes.
Okay, continue then, carry on. Okay.
Yes. Can you see now?
Can you see, Dr.
No, it's visible, but it's not in slideshow. It's not coming on full screen.
Oh, it's not coming on full screen.
Mm-hmm.
Yeah, it is on full screen, but
If you are facing problem, you can continue with the same.
It's okay. It's okay.
Yeah, please.
These slides actually it's just to show at the back. And I think I'm speaking more than that. The slides are showing. So okay.
So the next question is: we are all women dentists, so why should we bother about personality?
This is such an important thing, you know, that women as dentists today we are almost ruling the world. In any dental college, out of 50 students, 40 are women, 10 are men. So actually, and I see all around me, all successful, very successful women dentists. So what sets us apart from the other people? So personality plays a big role in how you're going to navigate this profession. It's an extremely difficult profession. You know, everyone wants to become a dentist. All our patients want to become dentists because they think, oh, there's a lot of glamour, there's a lot of happening things because they see us. But the point is, it is a very difficult and a tedious profession. And you really need to love your profession, and you should know how to balance professional and personal life.
And how do you think can we improve the doctor-patient relationship?
Before going to that question, I would like to say that as women, we play many roles. We play, we are a mother, we are a sister, we are a daughter, and we are a professional. So all these roles have to be balanced very well. So if you are not happy from within yourself, how can you make your children happy, or you can make your patient happy? So the balance is very important. Now coming to a question about doctor-patient relationship. So what I would like to say is that there are two doctors, though there are two dentists. They have the same qualification, they have the same expertise, they have gone to best of dental colleges, yet they are different. One is very empathetic, one is kind, one is compassionate, one listens to your patients. This is very important. Listen to your patients. Half the time we are talking over the patients. We have to listen to our patients, and we have to have a certain personality. We have to look a certain way also. And I would go further. We have to smell also good, because as dentists, we are very close to the patient. We have to. I remember an incident where a friend of mine who was a tobacco chewer himself, and he was a dentist. And every time I would meet him, I would tell him, listen, which patient comes to you? Because, you know, you can't be chewing tobacco and then telling your patient, don't chew tobacco. So as I was saying that If you have a patient, a doctor who's empathetic, honest, good to you, and you have another doctor who's arrogant, rude, he's not talking to you properly, he's not communicating properly, which patient will go to which doctor? Naturally, the doctor who's empathetic, honest, compassionate towards the patient, and also looks good. Here, I'm not saying that your professional capabilities will not overshadow your personal traits. But what I'm trying to say is that your professional abilities have to be the best. But please hone your personal skills. When a patient comes to you, he should always remember how well you looked after him. What you did, he'll forget. You did a root canal, he'll forget. You corrected his teeth very well. He'll forget you gave him a good smile. What he'll never forget is how you treated him. He will remember after 20 years also and tell people, you know, go to that doctor. She is very empathetic. And as women, we are more empathetic, I would say. We are more compassionate. God made us like that. So we should naturally, our nature is like that, to be compassionate. So we can do it even better than our male counterparts.
We have seen generations of patients coming to you. What is your secret mantra?
My secret mantra is only that I just love my patients. I adore my patients. I always feel that a patient is not merely someone who's going to come and pay me. A patient is someone who is going to have a lifelong relationship with me. And how will that happen? If I listen to the patient, I address their problems. Besides giving them a beautiful smile, half the time I am doing counseling to the patients, because my patients as an orthodontist are all teenagers, and God has given me the ability to have a calm mind to listen to them. So half the time they're telling me about their boyfriend-girlfriend problems also, and I'm trying to sort out. I have had mothers coming to me and saying that, Dr. Neena, he only listens to you. So please, so half the time I'm doing professional counseling also, side by side doing dentistry. So yesterday only, Dr. Akanksha knows, a patient came to us. Not a patient, my patient is in America for last 16 years. But now her child is going to get treated by an orthodontist in America. So her father came with all the records. And he said, Dr. Neena, she will not start her treatment, the child's treatment, till you say that the treatment is proper. What more can you want? This is, I think, is the biggest achievement. This is the earning that we as dentists get for a lifelong commitment to our patients.
Please explain to us, what can we do at a personal level?
So as I said, dentistry is a very demanding profession, but you cannot pour from an empty can. You know, you have to have something within you to give others. So if you are not satisfied with your profession, if you're not happy with doing dentistry right now, I am surrounded by young dentists who, after doing BDS, are not happy to do that. So I keep telling them, see, it's a difficult profession. If you do not love this profession, if you do not love the challenges of this profession, then it is very difficult. So you need to love your profession. If you are happy, then only you will make your patient happy. Then only you will make your peers happy, your colleagues happy. So it is very important to be a happy person from within. So emotional stability is very important to become a good dentist.
What about at the professional level?
So at a professional level, when I passed out 37 years back, my God, 37 years back, we were doing BEGS practice in orthodontics. Today's children don't even know what BEGS practitioners are all about. We would have been extinct by now. So what happened was, after 15 years of my practice, I realized that everything is changing. The technology is completely changing, and it became important for me to learn a new technique after 15 years of practice. I could have easily said, okay, I'm fairly all right, I'm doing okay, why should I learn a new technique now? But, you know, I made such a big effort. I went all the way to down south, did courses, not one course, I did at least 4 to 5 courses. And then I started the straight wire technique, which nowadays is the only technique which is being practiced most of the time. So I would say that at professional level, attend all CDEs, learn from your seniors, learn from your juniors, learn the new latest technologies. So, and for that, now we have so much easier. We used to read books. Now you have a Google and everything is on Google. But practical skills only you can get if you attend conferences, if you attend CDEs, if you attend hands-on courses. So keep abreast with the latest technology, not to become redundant.
So please tell us, ma'am, what are the challenges that you have faced as a woman dentist?
Man, really, this is something very interesting. So I was in college and I was in my third year and we had to take out teeth. So I was in Gujarat. So this one of the tribal guys had come and he had to get his tooth extracted. So he had a big mustache and he asked me in Gujarati, he asked me, and in Hindi it is like, तुम दांत निकाल सकती हो, लड़की हो, पतली सी हो, तुम कैसे दांत निकालोगी? So my professor came and he said, ये तो इंदिरा गांधी के डेंटिस्ट है, इनको दिल्ली से बुलाया है. And that fellow literally allowed me. When I started my practice, I was 28 years old and I was half what I am today, half my size. And I never used to wear a white apron because my theory was that patients get scared and I was doing exclusive orthodontics. So I came in my reception and this gentleman was sitting there and he said, Munni, Dr. Saab kahan hai? So I went in, I wore my white coat and I said, हाँ जी बताइए, मैं हूँ Dr. Saab. And he said, आप doctor हैं. So, and as Akanksha, now she is so much junior to me, she was telling me that in our college, everyone thought we were nurses because it is difficult for our patients to believe that a woman can be a dentist and that to a successful dentist. Scenario has changed a lot, but still we have to prove it. I'm sure you know that, Sana.
Yes, ma'am. We are being called sister for a long time.
Can you imagine in Gujarat, I was called Ben because sisters are called Ben. So then Nina Ben. So I said, listen, I am Dr. Nina, not Nina Ben. I had to tell people that I am not. At 35 years back, they could not even imagine that a woman can be a dentist.
So ma'am, now what can we do to develop our personality?
So I would say, can you change your personality? From within, it is very difficult. You cannot change your personality, but you can always develop your personality. First and foremost, why should you change your personality? So if you're a fish, you're not supposed to fly. And if you're a bird, you're not supposed to swim. So you have to find out what is your forte, what are your strengths, what are your weaknesses, and work on your strengths. Don't keep harping about my weakness. You know, I remember हमारे टाइम में foot engine होता था. There are many of my contemporaries will know. And I could not cut a cavity on that foot engine. I would go to my hostel every day and say, I'm a failure. I don't know because my foot and hand coordination was not proper. So I could not do it. So now I look back and laugh about it. But yes, and then I realized that, you know, I have to get over this fear. So you have to look at your strengths and work on it very, very genuinely.
And what are the general things that can be done for a well-rounded personality?
Do not compare yourself with others. Like I said, a fish and a bird will always be different. So if you are good, like in our field, if you're good in orthodontics, doesn't mean that I can be a good endodontist also. It's not possible. I cannot. In fact, I would say that in 35 years, I've not done any general dentistry. So today I might not be able to do a filling also. The technology has changed. The fillings we did, silver fillings are, I had one patient came one day and said, can you do a composite filling? And I'm like thinking, where are the line angles and where will I put an undercut? Because we were taught like that. So now I can't even do it. So I have to look at my strengths. Okay, I'm an orthodontist. I should hone my skills. I should become the best orthodontist possible. So whoever you are, maybe I'm not even talking about dentists, whoever you are, you have to look at your strengths and try to, you know, work on it. Rather than आजकल मैं यही देखती हूँ, half the time people are saying, oh ma'am, we are very depressed. We can't do this. Arey, you have so many, God has made you a unique personality. Just you have to find your inner awareness, inner strength. That is very important. And if you hone your own skills, and polish your own soul, you will become a much better personality than anyone else. And there are certain general things that you can develop, you can do to develop a well-rounded personality. Yes. First thing is be a good listener. So 75% you should listen and only 25% talk. Although in this kind of a thing, I'm only talking and you people are listening, I'm sorry. But in a general thing, I have realized that, most of the time we are only talking. We are not even listening. When a patient comes to us, he's saying, Doctor Saab, mere daant mein dard hai. Acha, theek hai, baitho. X-ray lo aur isko dekh lo. Are, pooch to lo aur kya hai. Kis daant mein dard hai. You are only looking at one tooth. First thing, you have to realize the patient is not a tooth. You have to see the entire personality, entire thing of the patient. बेचारा किस लिए आया है? वो आपको कह रहा है मेरे दांत में दर्द है, आप उसको कह रहे हो अलाइनर लगवा लो, दांत सीधे करवा लो. अरे, he is not come for alignment treatment to you. He's come for a toothache. So you have to listen to him. And another tendency that we all have is that if a person is talking, we are waiting to pounce on him. ये खत्म करे और हम बोलना शुरू करें. Please refrain from that. Let him finish. Take a pause and then please अपनी टिप्पणी बाद में दो, बाद में बोलो जो बोलना है, but उस वक्त उसको सुनो. Then I would say that in today's day and scenario, just get a lot of exposure, roam around, do lots of holidays, have experiences. No point in being a कुएं का मेंढक. कुएं का मेंढक तो खत्म ही हो जाएगा ना, उसको दुनिया भर के बारे में पता ही नहीं है, वो सोच रहा मेरा कुआं ही बहुत अच्छा है, which is not true. So if you don't read, you have to do a lot of reading. Besides dentistry, you have to have another life also. So do a lot of reading, roam around, have a lot of friends, talk to people, listen to people. All these things help in making a well-rounded personality. Yeah, play sports. That is very important. Some kind of sport one should play. Why playing a sport is important? One is that, okay, you feel physically fit, the endorphins are released, you're feeling happy. But another thing is that you will realize that one failure does not mean that you're a failure in life. One failed root canal does not mean you're a bad dentist. One botched up ortho case does not mean that you cannot do ortho now. People, do these days feel so stressed about these things. हमारे टाइम में हम सोचते थे कि रूट कैनाल अब खराब हो गई, चलो we'll go and talk to our senior, क्या करना चाहिए. अब तो इतना इजी हो गया है कि आप टेक्नोलॉजी से भी सीख सकते हो, पर दिल में लगाने की जरूरत नहीं है. You should not feel so bad कि one failure and I'm a failure. No, you are much beyond one failure. You are your own self. You have your own destiny, and destiny के साथ कुछ नहीं हो सकता. Wherever the destiny wants to take you, you will go there, but you have to work hard for it. So like I said, sports will keep you healthy. It will develop a sportsman spirit in you and make you a better person. Another thing I would say, be a compassionate human being. So I will give you an example of Sonu Sood. So he's an actor, right? But what he did in COVID times, he has stolen my heart. He might not be a Shah Rukh Khan for me, but yeah, what Sonu has done is amazing. How much compassion, how much seva, seva is such a big thing. As dentists, we are doing seva, but beyond that also, we will do that. If we do that, we'll be far superior human beings. Andar se bhi you will feel happy from within that you have done something. Another thing is practice an attitude of gratitude. Do not keep harping on, I don't have this, I don't have a big car. I've seen these young children today come and say, ma'am, when will we buy a Mercedes? Come on, you're just starting your life. You have to work hard. Do not, just because you've seen an Insta story of someone posing with a Merc and you feel that you should have it, do not let that hamper your own this thing. So attitude of gratitude is very, very important. Do your best and leave the rest to the universe. Universe is there to help you out. And always remember, glass is not half empty, it is half full. And it can be refilled. ये पुरानी saying थी कि refill नहीं कर सकते थे, हम refill भी कर सकते हैं. So have that attitude that we can conquer everything. And another thing, please develop lots of patience. Life can never be all the time fair to you. It can sometimes become very, very difficult, but if you have that right amount of patience, ये भी चला जाएगा, ये वक्त भी गुजर जाएगा और सूरज तो निकलेगा निकलेगा। हर अंधेरी रात के बाद, सना आप मानेंगी इस बात को कि हर अंधेरी रात के बाद सुबह तो होती ही है, ठीक है ना? So stay, last thing I would like to say, stay emotionally healthy, talk to your friends, talk to your relatives, and if need be, please talk to your therapist. Mental health is very, very, very important. So sometimes we feel that life is not being fair and we try to do addictions, bad things. I mean, you resort to alcohol, this and that. It's better that you talk to people, talk to a therapist. If the people are not there so much, because sometimes you can't open up to your friends. So it's better that you then talk to a professional therapist. So I would like to end this by telling you a very nice story. Do I have time? Sana, do I have time?
Yes, ma'am. Sure, ma'am.
Okay. So I would there's a story that a plant was growing underwater and there were insects under the root of that plant, and whoever went up never came back. So then they had a conference. They said, we will send one guy and he'll go up and come and tell us. So this guy went up and ऊपर गया and he found these lotus flowers. He just started resting on those flowers and enjoying the sunlight. So by evening, he started developing wings. So now the problem was that he had to fly. He could not get back into water. So he's looking down and he wants to go back to his old habits, but now he's got wings and he has to fly. So the moral of the story is that you can reach the top and you can have the wings. But once you reach the top, there is no place for relaxation at the top. You still have to keep working. You still have to keep flying. So I will like to end this by do not compare yourself with others. Run your own race at your own pace and at your own space. And remember, wherever you go, no matter what the weather is, bring your own sunshine with you. Thank you so much for having me here.
Thank you so much, ma'am. And it was such a beautiful talk. Unfortunately, I listened you for the first time, and I'm so much impressed how you explain all the little details. And it was literally, I'm just fan of you. I'm not a fan of Shah Rukh Khan. I'm fan of Dr. Neem.
Thank you. Come and meet me whenever. I'm in Delhi, and you are not very far. You're in Aligarh Muslim University.
Yes, ma'am. I'm in Aligarh.
Very nice. Thank you so much for having me here. Thank you, Dr. Nurul, also.
Thank you so much, ma'am. And you are a true example that a girl with a dream become a woman with a vision.
So absolutely, absolutely. I look forward to seeing you grow also.
Thank you so
much.
God
bless you. Bye-bye.
So moving our program further, I would like to now call Dr. Pratibha Rani, ma'am, and she's working as Associate Professor in Department of Pediatric and Preventive Dentistry in DAP Memorial RV Dental College. She has presented several papers at national conferences and won best prize at PG convention held at Savita Dental College, Chennai. She has also got several publications to her credit and has done observership at Arthur Divini School of Dentistry of Pacific University at San Francisco. So, ma'am, it's all yours now.
Thank you so much. Are you able to hear me, Dr. Sana?
Yes, ma'am.
Yeah, it's indeed my privilege and honor to be in this, only meant for women conference. It is so nice of you people to organize this and recognize our expertise or whatever, and call us for being a part of this say conference. So, and it would be also my pleasure to introduce Dr. Nandini Devi, today's speaker on oral pathological conditions in pediatric population. So I would be very happy to introduce her today. Dr. Nandini, to tell you, is my very close friend, and she's like a soul sister to me since our childhood. And this is my personal introduction as such. And then regarding the professional introduction, Dr. Nandini is presently working as a professor and head of department in the Department of Oral and Maxillofacial Pathology, Microbiology, Delhi College, Regional Institute of Medical Sciences, Impal, Manipur, India. She has graduated from Bapuji Dental College and Hospital and did her post-graduation from the College of Dental Sciences, Davanagere, Karnataka, India. And she has experience of more than 20 years, during which she has been an undergraduate and a postgraduate teacher, examiner for various universities, and also been actively guiding students for scientific poster and paper presentations. She has more than 70 publications in various international and national and state journals for her credit, and also has been a scientific reviewer and an editorial board member for various journals. She has delivered guest lectures and has chaired many scientific posters and papers in national and international events, and area of interest being pediatric pathology, developmental disorders, odontogenic lesions, skin and salivary gland diseases. So it is indeed a honor and pleasure to introduce my closest friend, Dr. Nandini DB, and over to her now for her presentation, which of course I know that she'll do the best of her, knowledge, and she'll be able to, enlighten us with many of the pediatric conditions. Over to you, Dr. Nandini.
Thank you so much, Dr. Pratibha. As rightly said, you are my soul sister. Okay, thank you so much for the kind words also. Okay, so I will start sharing my screen now.
Yes.
Just give me a second.
Yes.
Is my screen visible now?
Yes, yes, Dr. Nandini, it's visible.
I'll put it on the slideshow.
Yes, yes.
Is it on the slideshow?
Yeah,
Yes,
yeah, we're able to see. Yes.
So, greetings from Dental College in Impal, Manipur. Myself, Dr. Nandini. I'm an oral pathologist by profession. So, the topic of my presentation today is pediatric oral pathology and ovals. So, normally we have so many lesions occurring in pediatric population. They may affect either the hard tissues or the soft tissues. They may occur either as primary lesions or secondary lesions, secondary to any systemic manifestation or adverse effects of treatment. So it's very important to diagnose them at an early stage. Otherwise, it will lead to a lot of morbidity in the children. So because of the developing structure. So an alert parent and alert clinician is very, very important. Now, the age groups according to WHO has been divided into various periods. They include neonatal period, post-neonatal period, infancy, older children called as toddlers, young adolescents, older adolescents, and young adults. So, are these pediatric lesions different from adults? Yes, they have some difference. What are those differences? Unique exposure pattern is there. They consume more air, food, water, fluid compared to their body weight. Then they have specific behavioral patterns such as hand to mouth, object to mouth, crawling or outdoor exposure, and different nutritional patterns. They have inadequate absorption and distribution based on the various physiology, rapid rate of growth and cell division, immature metabolic pathways, detoxifying systems and immune systems, and remaining life expectancy is more. And they also have some critical sensitive windows of development, which are not seen in the adult. So, and further on, if they do not, the screening and awareness is not done in children normally. Further, they inherit the mutations from the parents, and involuntary exposure is there. They are powerless. If we take them to the doctors, then only they can go. Otherwise, they cannot go by their own. So they rely on the adults. And physiologically also, they have more lymphoid tissue or something like that. Examples. And pre-malignant stage is not seen. Like in adults, we have pre-malignant lesions and conditions, right? So such things are not there. And in children, it is mostly the cancers may occur due to inherited mutations rather than life habits, right? Lifestyle habits. And the symptoms will be usually non-specific, so there will be a delay in diagnosis. And there are so many ill effects on the other tissues. Now, outcome also, they respond well to therapy. Okay, and pharmacokinetics is different compared to adults. And as I said, long latency period, so chance of recurrence is more, and ill effects on other parts of the oral cavity there. And in case of cancer survivors, they will be immunologically suppressed permanently. Now, what are the various pediatric oral pathologies which can occur? Based on the etiology, they are classified into developmental lesions, which can affect either the teeth, the jaws, or the soft tissues. So I shall not go into detail of this. We have read it in our undergraduation, right? So there can be inflammatory or reactive or infections. Most common being your dental caries and pulpitis, right? Osteomyelitis, then periodontitis, infections which could be either bacterial, fungal, or viral infections. Then you may have odontogenic cysts, the most common being your mucocele and the radicular cysts. And there are so many cysts which occur in the pediatric population. Then there are some odontogenic tumors, most common being your odontomas, right? Ameloblastic fibroma, ameloblastic fibrodentinoma, fibroodontomas, then unicystic ameloblastomas, and your AOT, that is adenomatoid odontogenic tumors. Then apart from this, bone disorders such as osteogenesis imperfecta or fibroosseous disorders such as fibrous dysplasia. Then you also see skin or mucocutaneous disorders. Example is like ectodermal dysplasia. Then you have benign lesions, benign tumors such as squamous papilloma, lymphangioma, hemangioma, and so on. And you have a whole list of benign lesions. You also see some malignant tumors which can be like osteosarcoma, rhabdomyosarcoma, mucoepidermoid sarcoma. Then you see hematological disorders which could be malignant or it could be like life-threatening like hemophilia, thrombocytopenia purpura. Leukemia and lymphomas are the most common blood sarcomas which can be. So I have put a chart here which shows that in the first decade of life, that 0 to 10 years, some tumors are more common, while in the adolescent age group, some tumors are more common. Then you also have allergic metabolic disorders, and you have chemical and physical injuries like this. So traumatic ulcer, bruxism, and so on is more common in the adolescent. Now, classification of this pediatric oral pathology can also be based on the clinical presentation. So it can be seen as a growth, example pyogenic granuloma, or a swelling, mucocele, or a white lesion such as candidiasis, or some red lesions such as thrombocytopenia purpura or leukemia. It can occur as pigmentary macule or pigmentary lesions such as a nevus or an amalgam tattoo or even dangerous malignant melanoma. It could be an ulcer such as traumatic ulcer or abscess ulcer, or it could be like a vesicle or a bulla as seen in viral infections such as herpes, right? And what is the way how you have to diagnose? The first thing is you have to take a family history. Then you also have to have the history. The history is mostly elicited from the parents, either the mother or the father, right? So they should, you have to have medical history, habit history, routine, any frequent illness or something like that. Then thorough clinical examination. Before clinical examination, you should check the overall behavior, any deviation in the overall normal behavior. Okay, and you have to check the lesion proper as such. Okay. So no clinical test replaces a good clinical history or a careful physical examination. So certain basic investigations have to be done, such as radiograph, blood test, and so on, right? And now I will be discussing some cases. I'll just show you, run across various cases we came across. So here is a case with a 9-year-old girl with a swelling in the anterior maxilla. So you can see that the tooth, the lateral incisor is a slightly offbeat. It's not looking quite normal. There is a discoloration. So when the radiograph and aspiration was done, we got a straw-colored fluid. So when you see in the radiograph, you can see a periapical radiolucency, and the tooth doesn't look normal, right? It looks like a barrel shape with a wide open apex. So you could see that also that the canine, the permanent canine was superficially pushed. Okay, so this was a picture. When we did a biopsy, we saw that it was a radicular cyst. You can see the arcading pattern of the cystic lining. So this was radicular cyst associated with type C dense invaginatus. What is dense invaginatus? It is a deep fissure lined by epithelium, enamel, lined by enamel, which it reaches different depths. So if it reaches the apex, it is called as DP. Understood? So what is the importance here? There is a direct communication between the oral cavity and the periapical region. So it leads to here peri-pulp pathology and periapical pathology. So if only the cyst is treated, in this case, if you do not recognize the tooth is abnormal, then again and again the recurrence can occur. So you have to treat both the pathology. So that is the very important take-home message from this. Next case, a 13-year-old female patient came with a complaint of toothache. So there was caries, of course, and it was treated, but incidental finding was bilaterally on the buccal mucosa. There was thickened, corrugated, folded white plaques which were non-scrapable bilaterally. And when history was taken, even her father as well as brother had the same lesions, but they were not as much as seen in this particular patient. So what we have a differential diagnosis when we see white lesions, right? They can be scraped off or cannot be scraped off. When it is not scrapable, then you can think of various things such as leukoplakia or carcinoma, but they are habit related, and this small girl doesn't have any habit. So all these were ruled out, and we thought of some genetic lesions because the lesions were present since birth. So what are the genodermatosis? Like these are whole sort of genodermatosis. We checked her nails, skin, and all the palmar surfaces, okay, plantar surfaces, everything was normal. And we also referred her to a physician to rule out similar lesions on her vaginal mucosa or anal mucosa, and nothing was found. So final diagnosis was, and we also did a histopathology, and we got to see this particular histopathology, that is nuclear eosinophilic condensation. So these are nothing but your tangled keratin tonophyllum, right? So this was a case of white spontaneous. Why we should know this? Because this case is similar to other pre-malignant lesions or conditions, right? So there you'll have to treat it aggressively, but if this condition doesn't require any treatment at all. It is a harmless condition. So that is why we should know when to treat and when not to treat the patient. Next case, you see here, a 16-year-old female patient came with the anterior crowding. When observed, there was a missing mandibular lateral incisor. We took the OPG, and this was what was seen. So you can see that such as so many multiple small miniature tooth-like structures are present there, and the mandibular lateral incisor was impacted, right? So when we received the biopsies, you could see here so many tiny teeth are there. When histopathology was done, this was the picture. The lower part, the upper part, I have taken it from a textbook. So this was the case of compound odontoma, wherein the enamel, dentine, and pulp are arranged in proper order. Now, similar case like a 6-year-old girl came with a swollen gums and mild pain. When you see intraorally, we could see that, right? So, and there was a missing deciduous molar there. Second molar was missing. And previously, this case, a biopsy was done, and it was thought to be amyloblastic fibroma. Now, when the radiograph was taken, you can see in that circle, mixed radiolucency with multiple radio-opaque foci are there, and your permanent molar and the deciduous molars have been pushed superiorly. Okay, and even the CT scans or 3D reconstruction also showed a similar feature. Now, when we did a biopsy, we got to see this picture, that is, you see dentine, enamel space, cementoid-like tissue, dental papilla-like tissue, and odontogenic epithelium. So this was a case of amyloblastic fibro-odontoma or complex odontoma. So now, what is odontoma? It's the most common odontogenic tumor, right? So it is thought to be a hamartoma, and it is called composite because many tissues are present. There are two types, compound and composite. I showed you both. The compound shows miniature tooth-like structures, while the complex, there is no, the tissues, the enamel, dentine, and cementum are arranged haphazardly. And compound odontoma is more common in anterior, while complex is more common in the posterior region. So what is the complication? What do they cause here? They will prevent the permanent teeth or the other deciduous teeth from erupting, right? So this was the case here. So it is very important to note. If there is a missing tooth, then try to get a radiograph and get checked. Then further, it can lead to dentigerous cyst. which is very dangerous. Okay, and it can also lead to various other odontogenic tumors. Now, ameloblastoma fibrodontoma, just a note on it, because it was classified previously as complex odontoma. It is clubbed with odontomas in the recent classification, that is 2017 classification. Initially, 2005 was separate. They say that probably ameloblastic fibroma matures gradually into fibrodentinoma, then fibrodontoma, and then your odontoma. That is the concept of continuum concept of maturation given by Calm and Blum. Okay, so but why is it important to know? Because some incidents, some cases have transformed into malignancy as sarcoma. Okay, so that is why it is very important. We should not neglect these. And how can you do that? Biopsy has to be done. In that, we will come to know whether it is turning into a sarcoma or not. What is the treatment? Treatment, it requires surgical excision of the entire lesion, along with some people have proposed preservation, while some have proposed removal of the impacted tooth. And large tumors, of course, require partial maxillectomy or mandibulectomy. Now, case number 5. Here is a 4-year-old male patient. The patient came with a cauliflower-like growth in the mandibular, in the maxillary anterior region. Along with that cauliflower-like growth, you can see that the patient has multiple carious lesions with pulp polyps, right? So this is a rampant caries, case of rampant caries, again very common in pediatric population. Now, this case was, we diagnosed it as squamous papilloma based on the histopathological diagnosis. Okay, and why is it important to know some lesions, even though this particular case did not show coilocytic change in the epithelium, you might see coilocytic changes if there is a HPV infection. Understood? So this is the picture I've given on the right side. So it is very important. Because human papilloma virus, you know, it can cause cancer as well, right? So it is very, very important because high risk types usually cause human papilloma virus infection. Understood? Cancer. And multiple lesions are very common in pediatric compared to the adult. And further, in children, why can it occur? It can occur due to vertical transmission. The HPV can be transmitted either from the mother through vaginal delivery occurs, or postnasal transmission due to auto or hetero inoculation, or you should suspect some sex abuse, right? So that also is there, or you can suspect whether the child is immunocompromised. Okay, so these are the things which you have to keep in mind as a clinician. So what is the treatment? It's simple excision. Now coming to case number 6. So a 6-year-old male patient came with a complaint of swelling, short duration, just 2 days back. Why is it very important to know? It is a swelling which has occurred immediately, right? So if it is long standing, then you could have thought of probably something else, right? Such as salivary gland tumors, such as mucoepidermoid carcinoma. They also look the same, but here it is 2 days duration and there is a history of trauma. So we thought of it, this could be a mucosis. We did a biopsy, and biopsy showed confirmed the mucosis. So there are 2 types of mucosis. One is retention type, retention cyst, and one is escape phenomenon. In retention type, the mucus is collected within the duct. So it is not spilled into the connective tissue. While in the extravasation type, it's spilled into the connective tissue. So it generates a giant cell reaction with the foreign body, giant cells, and so on, inflammatory cells, and so on. Okay, and it is a pseudocyst. So the mucus escape phenomenon is the most common type. It's the most common cystic lesion occurring in pediatric population. Now, case number 7. So in a 10-year-old infant, okay, came with an erupted tooth in the mandibular anterior region, and there was a tongue ulcer, and it had also called injury to the breast as per the information given by the parent. So this is a Riga-Fedi disease. Riga-Fedi disease is a ulceration on the tongue of the ventral surface of the tongue, which is associated with either natal tooth or neonatal tooth. We know natal tooth is present since birth. Neonatal tooth will erupt 30 days after birth. Why is it important to know? These teeth are said to be probably early erupted deciduous teeth, and sometimes they can be extra teeth, and sometimes they are very loosely attached to gingiva, and they can be aspirated. So risk of aspiration is there. That's why you need to take care. Understood? So you need to extract it. So that is one important take-home message there. Then case number 8 here, a 15-year-old female patient, there is a swelling in the right mandibular region. Intraorally, when you saw that there is a cavity like lesion there, right? So when we took the radiograph, you could see that there is a huge cystic lesion there, and the molar is impacted. It is pushed to the ramus. right? The third molar is impacted. So these were the pictures, the 3D reconstruction and the CT images. And when we did the histopathological investigation, we saw a very thin lining. Okay, so this is usually a dentigerous. Why is it important to know about dentigeresis? We know in dentigeresis is almost always associated with the impacted tooth, and it is occurring due to fluid collection between the reduced enamel epithelium and the tooth crown, right? And why is it important to know what is the most important take-home message from this? The dentigeresis lining is very dangerous because it can get converted into ameloblastoma, squamous cell carcinoma, and mucoepidermoid carcinoma. So that is why you have to follow up this patient on a long term, and while removing, you have to remove the cyst in toto. Complete surgical excision is very, very important. Now, this is one more case where you can see a 16-year-old female patient swelling in the right mandibular region. This was an intraoral picture. You can see a lot of crowding, vestibular obliteration, the growth of the alveolar ridge. This was the CT reconstruction, 3D reconstruction. You can see here what is it? It is a huge lesion, right? And it has caused the resorption of the anterior teeth, the mandible, right? So, and there is a perforation. You can see here there is a perforation of the buccal cortical plate. Okay, so this was a case of plexiform ameloblastoma with lot of hemorrhagic components. So, what is ameloblastoma? We know this is the second most common benign odontogenic tumor. First is odontome, and the second one is ameloblastoma. So, ameloblastomas normally occur in the elder age group, 40 years of age, right? Most common mandible, molar angle and ramus area. But unicystic ameloblastomas are very commonly reported in the adolescents because it occurs in the second decade. Okay? And radiographically, when you see, it will give you a hint. If it is a multicystic, multilocular variant of soapable appearance is there, it is usually a solid variant or a multicystic variant. If it's a unilocular variant, it is a unicystic ameloblastoma, which we may get confused with our dentigerous cyst. And one more variety is there, peripheral variety, which occurs only on the soft tissues with no bony involvement as well. So that also has to be taken care of. Now, histopathology, as we know, with numerous histologic variants are there, follicular, plexiform, right? You can see here the follicular, plexiform, okay, acanthomatous, keratin forming ameloblastoma, basal cell form, granular form, desmoplastic, where the dense bundles of collagen are there. Then new entities which are added are your adenoid ameloblastoma, where you have some duct-like structure, and hemangiomatous ameloblastoma, where you see lot of blood vessels. Now, unicystic ameloblastoma itself, you can see in the lower part, the lower row, there are three variants: the luminal, intraluminal, and the mural part. The mural part is very, very important because it behaves in an aggressive manner, and it has to be aggressively treated. Now, the next case is a 19-year-old female patient with a discolored teeth, yellowish teeth, and she has a lot of sensitivity. There are multiple pulp exposures, carious teeth, and similar finding was seen even in her sister. And her brothers were quite normal. So this is the picture of her sister. She is 13 years old and she has the same manifestation, right? So what is this? So we took a radiograph, and you can see that in the radiograph, the enamel is lost, right? Enamel is chipped off. And all the second molars, you can see all the second molars are showing taurodontism. So this was a case of amelogenesis imperfecta, hypoplastic or hypomaturity type with mild taurodontism. You can see this. The lower part is showing the types of taurodont, mild, moderate, and severe taurodont. So this is showing the some amount of mild amount of taurodont. Why is it important to know this? You know that amelogenesis imperfecta is a sex linked, or it can be autosomal dominant, autosomal recessive, right? So you have multiple lesions on your tooth. The tooth, multiple lesions are there, caries, pulp involvement, right? So you need a teamwork here, endodontist and prosthodontist, right? So everybody have to set it. So what is taurodontism? There is a wide pulse chamber, so you have to take care. When you cannot do it the same way. RCTs have to be done in a different way. You require more amount of the filling material, right? And what are the complications? As I told you, there are a lot of psychological trauma also, right? You have to pay attention to that as well. And the full restoration, crowns and prosthetic replacements have to be done. So The last case which I want to show here is this one. It's very important, which it had come recently. So the patient had the gingival enlarged, okay, and he had got it treated elsewhere, and the biopsy was done, and the biopsy, it came as non-specific chronic inflammatory lesion. That is what they had given, but the lesion started to grow again. That is why she reported to our department, okay, our college. So now when you can see here, this is before and this is after biopsy, again there is growth, right? So when we did the biopsy, this was the picture. You took a radiograph also, you could see multiple radiolution areas, both in the mandibular anterior and maxillary anterior area, right? And we had sheets and sheets of diffuse, large, round blue cells lesion. So this was a case of non-Hodgkin's lymphoma in a HIV positive patient. So this was a non-Hodgkin's lymphoma in a HIV positive patient. We know that in a HIV positive patient, one of the very common lymphomas is your non-Hodgkin's lymphoma and Burkitt's lymphoma, right? Now, what is a lymphoma? Lymphoma is a malignant proliferation of lymphocytes. Either it could be B lymphocytes or T lymphocytes, right? So there is, if they occur in the nodal node, it's called nodal disease. If it occurs extranodally, then it is called as extranodal disease, where it can occur in the MALT, that is mucosa-associated lymphoid tissue in the Waldier-Ling area, right? So in that area. So in the oral cavity, they are very, very rare. Okay, so that is why it is very important. And the most common, I told you, in HIV patient, it is non-Hodgkin's lymphoma, but in children, it is Burkitt's lymphoma. Okay, and the primary site, if it is, I told you, it is usually the site is the Waldier-Ling area, right? The tonsil or the palatal area. But if the bone is involved, then you will have alveolar bone loss, you have tooth mobility, as seen in our case, there was gingival enlargement also, right? So it may result in pain, numbness, and pathologic fracture. Okay, so that is very important. Now there are two types, nodular type and diffuse type. The nodular type has a favorable prognosis, however, diffuse type has a worse prognosis. And most of these lymphomas are of B cell origin. Okay. And the most common type is histiocytic diffuse large cell lymphoma. Okay. So in our case, it was probably this. We don't have, we referred this patient to a higher center since we didn't have the ISC panel, which was required for an exact accurate diagnosis. But basically, it was a non-Hodgkin's lymphoma. So what was the treatment? Radiotherapy, chemotherapy, and stem cell transplant can be done in this case. So what is the take-home message? See, oral health is a mirror of general health. We know now that the patient has HIV, the patient, why? Because we came to know that there is gingival enlargement, right? So oral health is a mirror of general health, and early diagnosis is crucial, right? Otherwise, it can lead to very serious complications. So that is why an alert parent followed by an alert clinician plays an important role, so does an oral pathologist. Okay, so we always say, as is our pathology, so is our practice. So we should be good enough to diagnose the condition early and refer them if it is not, it's not always caries or not always your RCTs, right? So you also come across. So don't just see the patient only for that particular tooth, but look around the entire oral cavity as a whole. So we have to, the entire professional core team should be there, and that is how we can improve the quality of life for our kids. So in conclusion, I would like to say that a child is a unique individual, right? He is not a miniature adult or not a little man or a woman. They have specific lesions, okay, but the symptoms are non-specific. They can be very, very non-specific, right? And they vary in many aspects compared to the adult lesions. So early diagnosis and management is the need of the hour. So I would like to say that we hold our future in our hands, and it is our children. So we have to take care of the future generation. So thank you for a patient listening. And before I end, I would like to thank my teachers, my family, my parents, my support system, the entire colleagues, and my director, our principal, and my clinicians, and lastly, more importantly, my patients. And I again thank the organizing team, Dr. Narul, Dr. Pratibha. Okay, thank you so much.
Thank you so much for that enriching this thing's presentation, Dr. Nandini, and it's been really very, enlightening, I can say. And many of these conditions, we usually are being pedodontists, we are exposed to so many cases like this, and the parents usually have the thing of they get usually like anxious for a smaller tooth eruption not happening, and forget about a big lesion in the oral cavity. As you very well said, riga fede disease, as simple as it may look, but it can cause lot of distress for the parent and the child as well, So thank you once again. Thank you very much for a very beautiful presentation, I can say, and very good cases lined up, and nicely done, madam. And also you explained about the treatment, not only the pathological aspect of it, you also explained to us about the the treatment aspect of it, which is like which completes our treatment planning and the outcome of the treatment. Thank you very much once again. And our moving on with the next presentation for today. Our next presenter is Dr. Shali Mahajan. She is staff and Department of Dentistry and Ram Vilas Mohan Institute of Medical Sciences, and now today she will be presenting on lasers in dentistry. And over to you, madam. Thank you for for being present. Yes, ma'am.
Thank you so much, Dr. Pratibha. I would like to share my screen. Yeah, I think the screen is visible to all.
Yes, madam, it is visible.
Okay. Very warm welcome to all of you. Thank you, Dr. Nurul, and especially for the event of this kind, like Pink Dental Congress. As the name only indicates, it's for the generation, like, which is miles apart. Right now we have G20 and all that, which is going on and all, going for the women empowerment and just women's liberation and all that. So as dentists, like what all we can incorporate, in our daily day-to-day clinical practice, which can make our life easier. Because as a female, I think it's more of like what all roles you play. You have to be a doctor because that is what we have studied for, but you cannot also delineate the factors that you are a mother, you are a sister, a daughter, and various other roles what you are playing. So coming to a latest thing which has been there from around like 2-3 decades is my topic, the lasers in dentistry. So first, to introduce myself, I'm Dr. Shali Mahajan. I'm professor in the Department of Dentistry, already an orthodontist actually, with having like around 20 years of clinical experience. I retired as a professor from my previous dental colleges, and now I'm heading the Department of Dentistry at Dr. Ram Manohar Lohia Institute of Medical Sciences, which is situated in Lucknow. So coming to like, I would like to start like, what are the current trends in dentistry? We have been talking about dentistry, like how the dentistry has evolved, and like right now we had Nandini ma'am, who was speaking about, various trends in how to cure cancers and what all various adenomas and all those oral cancers are there. So there is dentistry is also going, many folds, like it is now progressing. So the recent trends are moving now to the diagnosis, that they should be early diagnosed, be it oral cancers or be it any lesion for that matter, be it small cavity also. So the importance is given for early diagnosis, and also that the treatment should be minimum invasive as possible. So we had like GV Black's, extension for prevention type of cavity preparations, which have been now replaced by different kind of like composites, which is now not on like physical bonding, but it is more on the chemical bonding and all that. And now there are some indirect bonding and other things which are included. Same way, it should be also aesthetic. So as an orthodontist, we were first banding, and then came the bonding with the introduction of various composites and all that. And now we are moving to aligners and all. So dentistry is also having like many folds, and the treatment is expected to be for the early diagnosis, minimum invasive, as well as aesthetic. So coming to the topic, which is all in one, I would believe, is lasers. So it is what? Light amplification by stimulated emission of radiation. So what is exactly light? Light has always been fascinating, it has always fascinated mankind. And not only like dental or medical, but even other spaces as well. Like we go in for spiritualism, and we have this thing of like Surya Namaskars. When we have to start, we start offering water to the sun. So this has been not just the current one, but it has been quite documented also previously. And we are just researching like what it was already searched. So this is laser. Laser is what? A light which is just amplified and stimulated, So we all know that the light consists of photons, and the whole of electromagnetic spectrum is comprising of various wavelengths which are moving from invisible to ionizing radiation, to the radiations which are actually visible to our human eye, and also invisible thermal radiations which we have, like microwave and other we have these TV, microwave, our transistors and all that. So invisible or ionizing are the ones which are like having radiographs like X-rays and all, which causes some mutations. But there are some, and moving on to the thermal and all, and they're all radiations. So actually there is a concept like radiation. When the word radiation is associated, people might find that, okay, this is a radiation. So it may be very harmful, but there are certain radiations like thermal radiations and all that. So this laser, what we talk about, comes in visible to infrared area, from starting from 400 to 10,600 nanometers. So it has got various wavelengths and amplitude. So the lasers currently what we talk about is around 450 nanometers, which is like even for the diagnosis and all. Then there is diode lasers, low level laser therapies, then Nd:YAG lasers. So these are all the various lasers, and they have been classified also differently, which I'll be coming to the next slides. And then there are some hard tissue lasers, and like erbium family and carbon dioxide lasers. So going back a little, brushing towards the history, because the time is a little stringent. So it was Albert Einstein, whom we would regard, he established the theory background of like quantum theory of radiation, which is very well documented. And then there were Jordan Gold. He was the one who published this term as laser. So before it was maser, but then it was named as laser. And there was Theodore Maiman in 1960. He was the first one who had produced, ruby laser, and he was the one who is known as, the father of like production of ruby laser and all that. And then came the Nd:YAG and so and so. So the only problem with ruby laser was that when the heat generation was thought, then it was found that in enamel and dentine, the heat production was more. So it may lead to the pulpal damage and all. So that's why then it led to, but so definitely it was one of the main starts, like how the laser was, incorporated in our dentistry. Before, it was mainly the surgical aspects of lasers were studied, but definitely then there was other aspects also in dental fraternity, which were well elicited and well documented. So coming to how the laser light is different from an ordinary light. We all know that ordinary light, we can just look into in and around, even a bulb, tube light for that matter. So what it has, a different wavelengths, it is different, having different colors, and it is it is multi-directional. It is not concentrated in one direction. So you can see the flare, it is like multiply flaring here and there. So whereas the laser light, how is it different from the normal light, is like it is monochromatic. It is having single color, be it red or blue or green. So it will always have single color. So the intensity is like, its absorption is more deeper. Then it is collimated. It is very directional. It is not like multi-directional as we had seen during the light which was coming from bulb. So it can be very much focused, and also coherent, like coherent in like it always moves in a synchronized way. like an army, when you see them march past and all that. So it is all in a synchronized way. So that is how it is, like, so they all travel in, all together. So they are parallel to each other. And also some of the terminologies are like amplitude and wavelength. So amplitude is basically the height of the wavelength, and the height of the light what is traveling. And wavelength is any 2 points which is in between the amplitudes. Okay, so wavelength is usually measured in nanometers. It is 10 raised to the power minus 9. So every laser has got a different wavelength. So you would have thought about what is diode laser and what is KTP, what I'm talking about, and even the other lasers for that matter, like the carbon dioxide and Nd:YAG and erbium YAG. So they are basically having different wavelengths, and these are the wavelengths which have different interaction with the tissues. So what all usually when a light falls, it is a simple fundamental which is usually seen. When a light falls on the tissue, it can be easily absorbed either, or it can be transmitted back, like we project a light on a glass. So what it has done, it transmits. Okay, or it can be reflected back. Okay, or it can be scattered, like we that scattering process we use it for our light curing machine. So in those processes, the scattering is the one which is actually seen. So in most of the lasers, it is basically the photochemical and photothermal aspects which are seen. So this was the classification. Before it was classified as hard tissue and soft tissue laser. So this was a classification which we got published in one of the laser books. So this is internationally blamed, and we thought that lasers cannot be hard tissue and soft tissue, but depending on what they use as a clinician is, it can be either surgical or a non-surgical laser. So surgical, where we have like hard tissue laser and soft tissue laser. So hard tissue is the one which can be, acted on bone and, soft tissue, and also your tooth. So soft tissue is the one which is actually dealing with the soft tissue. So soft tissue, hard tissue can be used as a soft tissue laser, but soft tissue laser cannot be used as a hard tissue laser. So this is one fundamental we have to be little clear about. And non-surgical category is basically the diagnostic and the low-level laser therapy. Also, the miscellaneous we'll be talking about. So coming to the hard tissue family, it is basically erbium YAG and erbium YSDG, and also carbon dioxide. Then soft tissue is diode laser and Nd:YAG laser. And there's a company known as Sulia who's been also producing now carbon dioxide. But the only thing was the variability or the cost of it was so high that, basically now diode and Nd:YAG and carbon dioxide, they are the ones which are actually functioning for the soft tissue laser. So coming to diagnostic, we have carbodiagonodent, which is mainly used for diagnosis of the caries. Then there is laser Doppler fluorometry, which we can see about the pulpal pressure and all that. And then there is photoactivated disinfection, which we see for the people like when we have like periodontal problems and all. And also our light curing machine, which we already are using in our current day-to-day clinical practice. So I told you that how laser light actually works. So basically a body has, chromophores. So these chromophores can be in the form of melanin, hemoglobin, and other melanocytes and all. So they are the ones which are actually, quite attracted to the laser wavelength. So these are the ones then when it is absorbed, the laser energy is absorbed by these chromophores. So what happens is there is either a physical, mechanical, or chemical, interaction between the chromophores and the laser energy, and that leads to the temperature changes which occurs, and this can, hit the target tissue and can lead to desired results. So this was in nutshell about what is the physical background of lasers. So coming to the clinical applications of lasers, basically from the diagnosis to the treatment, I would say everywhere we can apply. Diagnosis, like diagnosis of pulp vitality, we had laser Doppler fluorometry, and even for the laser fluorescence, like we have this diagonodent, which is like basically based on fluorescence and the area where the caries is there, it becomes like, because the light is absorbed and it becomes darker in shade. So you can find out the difference between a healthy tooth and a diseased tooth. Then hard tissue applications can be like either, bone cutting or mainly tooth. So it can be caries removal, recontouring of the bone if you have any osseous osseous inflammation or something like that, that can also be taken care of. Then endodontic for the root canal preparation, laser etching for, like me, I am being an orthodontist, I would can go for etching and all that with lasers, and caries resistance for that matter. And also for the soft tissue applications, it is basically curettage, right from like, decontamination to any surgical process like your gingivectomy, gingivoplasty, implant exposure, fibroma removal, a biopsy tissue or apocolectomy, you name it and you have it, even for incision and drainage and all that. And laser induced analgesia, we have done quite a lot of work with hypersensitivity, and lasers have been used for relieving patients from hypersensitivity. Then also for the laser reactivation of like bleaching agents, so basically they are used for tooth whitening and all, and others can be like softening gutta-percha and all that, they are miscellaneous. And for the removal of fractured root canal materials and all. So coming to the advantages, like why lasers is more, in, and why not like the other things. So advantages are there is less pain. So basically I would categorize that three. Like there is no cut, no sew, no pain dentistry. That's what is relevance at. Because when laser is actually cutting, so there is analgesia which is there, and we require very less amount of LA, local anesthesia, or sometimes even topical anesthesia is well enough, it can be mastered with that. There is minimum bleeding because as and when the laser is cutting, so there is anastomosis of the blood vessels, so there is high photocoagulation which takes place, and there is like very less swelling. So basically laser actually heals with secondary intention. In primary intention, we have all read about, the Ruber Kellogg, which was tried, like we had Ruber Kellogg, Delor, loss of function and all that. But in lasers, it is basically replaced by all these inflammatory signs. So there are no neutrophils and no blood cells and all that. They get cauterized. So when they get cauterized, so it becomes bactericidal as well. So there is less use of, antibiotics and anti-inflammatories, what we have to administer to the patients. So what about the lasers, so there it has been documented in dentalcompare.com that rarely in dentistry does a clinical tool emerge with so many possibilities for the treatment. So coming to that, we will have some clinical applications also for lasers in dentistry. How it is, I told you, this is one of the DiagnoDent tool, which is used for the caries detection. So it has a red wavelength, red diode laser. So it reflects, a different wavelength with two compared. So there is actually, if you see, there is a calibration, which is there. So when the light penetration occurs, so there is a particular amount of reading. So if it exceeds more than that, then it becomes like it's a diseased tissue. Then also for lichen planus, there has been many white and red lesions, and I am really thankful that my lecture came after, when malignancies and others were dealt with. So it was more important because when we talk about, what exactly is malignancy, we also talk about some pre-malignant lesions. So when the patient comes, like we can easily treat them. So lichen planus also is very well treated. And also we have treated certain cases of, so treating lichen planus is actually, very easy. So it has been documented also. Coming to the leukoplakia, where we have like people having, keratotic patches and other places. So this is very nicely, done, but only the thing is like we should be able to diagnose it well. So, and also for the mucocele removal, we have done like if these are the things which are actually hampering the tissues also, when you have like people who are basically tobacco chewers, which we are having in this belt of the region. So there, most of the teeth become very sharp, and all these soft tissue, they get imbibed in it, and then they become like mucoseals. And also fibroma removal, razor is very excellent when we are removing fibromas, because the patients are apprehensive. We don't have to give them any sutures, and there is less amount of bleeding. It's more predictable. We can see like what exactly where we are cutting. And especially like people like me who are not a surgeon, and they feel apprehensive when they see blood, so it becomes like a difficult situation, that I have to like master, a certain thing. So it becomes very handy for me. And these tissues, we can easily give it to biopsy for their histological evaluation. Lot of gingival growths, like some of the periapical granulomas, or maybe pyogenic granulomas, as we can see here. So these are one of them, for polyps for that matter, when we see. So it becomes very difficult actually to do uh, the root canal treatment or any kind of treatment in the first sitting. Suppose if I have to, if this tooth is carious, I have to like really, bond it today. So it would not be, if I go by a conventional manner, so what will happen? There'll be a lot of bleeding and all that, and I wouldn't be able to, my surface would get decontaminated. So I might have to recall the patient again. So rather than that, I can just, excise it with laser and see the nicely curated area, and I can easily go for restoring the tooth. Then I told you, like, there are a lot of things, like sometimes when the patient comes to us, so there's a lot of bonding and banding which is occurring, and all that orthodontic treatment is going on. So patient cannot maintain his or her oral hygiene, or sometimes the patient is little compromised also, and on these nifedipine and all anticonvulsant drugs, or maybe it perpetuates in the in during the treatment, and the patient, you cannot make the patient stop the treatment. Or during pregnancy, suppose if the patient has come to you, before marriage, and because it continues for 1.5 year 2 years, ortho treatment. So during the time she got married, and she comes and becomes pregnant and all that, and then there is gingival hypoplasia. So a lot of things are there which are administered, patient is not well, or maybe mentally challenged. In those kind of patients also, this becomes very handy tool, that I can predict the amount of like crown length, and can maintain the oral hygiene well in my patients. Patients with operculectomy, when we see that this operculum is there and all, so in those kind of cases also, laser is the one handy machine. Then also for implant uncovering, when we are dealing with implants and all, I'm sure a lot of oral surgeons and periodontists and others are there who are doing oral implantology. So in those kind of patients, like when we see this site, and when the patient usually comes for the second sitting, which is around 3 to 6 months, that time we have to see this and uncover it. And the beauty of soft tissue lasers is that, when we are touching this the implant and all, so it hardly, because it doesn't recognize, the implant, it's just the hard tissue which recognizes, and the soft tissue actually does not recognize. I told you, hard tissue can operate on soft tissue laser, but soft tissue laser cannot operate as a hard tissue laser. So the implant uncovering is beautiful, and you can take, the impression right away. Then coming to the tooth exposure, in so many of the pedo patients who come, the parents are very apprehensive about, a cut being made, on the mucosa. So more than the child, it is the parents actually we are trying to, pacify. So in those kind of patients also, laser plays a very important role. And mind it, in most of the cases, we are not even giving a local anesthesia. Topical anesthesia works excellent in those cases, and there is minor cut which is like allowed, and then the tooth starts erupting in its own way. So coming to some of the functional issues, since we are talking about pedodontics, the pediatric specialty is such that, you have to see children from the infancy stage. So now lot more things are given for prevention and all that. So this is one common condition, that is frenum. So attachment of the frenal thing, and it has been well documented also that patients or the children like who have frenal issues, like, there is high attachment of the frenum, and those patients have a difficulty in breastfeeding. So there is sometimes it can be the labial frenum or the lingual frenum as well. So crown exposures and frenectomy have been done. This is the case by Dr. Lawrence Kotlow. He's one of the pediatricians, and he does excellent work with children and all. So this is the case shared by him. So this is immediate post-op. So even the parents are happy. You can see the incisal exposure also, which has been done with the laser. So in the normal conventional one, actually what happens is there is a lot of sutures or anesthesia. First of all, the syringe what we inject in the patient, the parents are only apprehensive, forget about the child, being operated on. So lot those issues are tackled, so this is after a week. And this is ankyloglossia, which we had treated in one of our clinics. So this was the patient, like she had to undergo orthodontic treatment, and she had speech issues and all. So I was like, the tongue should be freed, before we initiating that. So this was immediately with our 450 nanometer, one of the diode lasers we had done. And this was a blue laser. And this is the immediate post-op which was there. This is we were doing, and this is after the healing. This so beautifully the patient was going in for a speech therapy also, and along with this. And then the things got mattered, and after that we had now she's got married also, and she's children also. So it's beautiful feedback when we hear from, because as a dentist we are not just doing one tooth or two teeth, but as an orthodontist I feel it's my duty to give the best of the lifestyles which we can provide to the patient. So similarly, lingual frenectomy, this has also been performed in one of the patients. So imagine, like, see the amount of cut, which has been administered, so this was done by hard tissue laser. So coming for in such kind of patients, like when the crown eruption has not been taken place and we can't bond. So earlier what we used to do is we used to bond it on the incisal or wherever surface we are getting the space. And after the tooth, gets, in occlusion, then we would be able to bond. But with laser, I can just make, contour it and can place the bracket right away. Vestibuloplasty in such patients, like we have seen gingival recession in such kind of patients. So in those patients, it has also been elicited that the vestibule plays a very important role. So if the patient has shallow vestibule, so it leads to a lot of gingival recession. There has been a lot of documentation also which has been there. So in those kind of patients also, when we go for deepening of the vestibule, so laser plays a very important role, and we have done some of the cases. Okay, and similarly, if we go for the upper, they can be lip lengthening procedures as well. So one of the prime problem is oral submucous fibrosis. We all have been dealing with aajkal gali nukkad mein kuch bhi milega, but you can get pan masala everywhere. So now even government has been very adamant about it and all. So there are a number of displays which has been taken place, in cinema halls and all that, where people are made to talk about what is the importance of, gutka chewing and the hazardous uh, problems what it can elicit in and alcohol as well. So in this belt, when I am talking about Uttar Pradesh and Bihar, we have like all of patients who are taking more of gutka and all that. So they have trismus, which is followed because of the mucus bands which are replaced by submucous mucosa. So there is fibrosis of that, and that can lead to limited mouth opening, and the patient is having difficulty. In these kind of patients also, what we were administering before was that there were conventional therapy where we would make an incision, and then either a buccal pad of fat or maybe as some or the other tissue were seen as grafts were placed. But when we started with lasers and all that, it was one of the challenges that we had to come up with. So we had come with one of the incisions that was like Y-shaped incision. Now it is very well circulated worldwide. So it was like from the retromolar area we take an incision, and then we go for Y, which extends up till the upper commissure and the lower commissure. And this is the healing which has been there for the 7th day. And after that 10th day, you can see how much of the mouth opening is there. And with lasers, it is like immediately you can see like, how much of the mouth opening occurs. So it is not that after a few days when the patient will come, then we will see, because sometimes in such case patients, the patient has to do exercise, and you see the patient after a week or so, and the patient is not maintaining his oral hygiene well, and the patient is not exercising and all that. So your treatment goes for a toss. So in these kind of patients, it's very easy to take their acceptance, their for the treatment, and they can eat right away. There is no need for hospitalizations. So we found that we could work wonderfully with this machine. Also, we have pockets and all coming to the periodontal department. So there has been pockets and all. So there is a LANA procedure, which is like laser assisted new attachment procedure. So this is also done with lasers. And especially we have patients like who have like either a stress ulcer, or they may have a systemic diseases, or maybe herpes and all that. So they are also like, treated chair side. We have seen, we will not be removing the underlying cause. If it is if the etiology is viral, it will go for acyclovir or any antiviral therapy, but it can be symptomatically treated on the chair side, so you can provide immediate relief to the patient. And also post-operative instructions are also bare minimum, that the patient has to refrain from eating soft diet and all that. And in so many patients surgically, I don't prefer giving them antibiotics until unless it's absolute necessity and they are infected with bacterial. Otherwise, some NSAIDs which are there for 3 days is more than enough, and they have to obviously maintain their oral hygiene well, and with warm saline gargles and all that rinses, which is very much equal to what we give the post-operative instructions after the tooth extraction. So if you would say that, laser versus scalpel and electrocautery, first of all, I would like to make it clear that, if I have incorporated laser in my specialty, doesn't mean that I have to throw away my scalpel, I have to throw away my electrocautery, or I have to throw away my aerator. No, it doesn't mean that. It's just an added adjunct to my, treatment, where I can make, patient's life better and my life better. So if I have to give an incision, I will use, a scalpel. I will use an electrocautery. I will use my aerator and all. They will be absolutely there in my clinic. But if we talk about like what all advantages are there when we had incorporated, so anesthesia in scalpel you give, in electrosurgery also you have to give, in laser may or may not be. Sometimes we do for topical anesthesia as well. So bleeding is predictably yes in scalpel, electrosurgery no, and in laser also it's absolutely no bleeding and all, because we go for the cauterization of the blood vessels. Suturing, in both the cases, scalpel as well as electrosurgery, it is required. In lasers, mostly 80% we do not go for sutures. Healing time is, because it is less in scalpel, because it heals by first primary intention, as I've already told you. In electrosurgery, it is moderate, and in lasers, it is less to moderate. And in patient comfort, definitely laser scores more. I told you that and also the collateral damage is one thing which has not been talked about in this. So when we go for scalpel, see, we are not able to see, so we are just predicting with how much ever we can, cut. It also depends upon the clinician's, skill also. I'm not an oral surgeon, or I'm not that skilled, so it works best for me. In electrocautery, it has been the collateral damage has been well documented. But in lasers, if you keep on moving and all that, it becomes more comfortable, and it is like less damage to the collaterals which have been documented. So coming to every instrument for that matter, so you have to use, that, and also with safety procedures. So if it would be just like, a knife which is given to a butcher and also to a chef. So what difference it would make? You give knife to a butcher and you give them, a vegetable, so it will make, different, it will just chop and give you like it has been chopping of a mutton. But if you give it to a chef, it can create wonders. We all have seen in most of the functions and all that, how the decoration and all that, they can just make, nothing out of so much is there. So it is just like that. So usually lasers come in class 4 category. So there has to be safety protocols which have to be followed. So proper signs and other there are other stickers which are there on that, so which are displaying, that it is danger. And there are various goggles which are specifically made for those kind of wavelengths which have to be utilized by the surgeon and the patient as well as the assistant. So most of the machines, they are giving 3 goggles with the laser machine. And every laser whosoever has got typical wavelength, those kind of glasses are only to be used. So if it is the carbon dioxide, so it has to be having a wavelength of 10600. So if it is diode laser, so if it is 810, 860, 980, 940, 455, so those kind of wavelengths will be there, so that the eyes, it can just reflect. And also high volume suctions are to be used, because there is a production of something known as laser plume, and it has been said that whenever it goes and reaches your lungs and all that, it can lead to a lot of fibrosis and all. And also we can't just go in for that. There is definitely specializations. We need to certify ourselves first, and then only I think we should incorporate, because otherwise it's not that you would not be able to use it, but you would not be able to make the best use of it. So that's why there are some introductory courses by various academies, various universities, like ALD is one of them, that is American Laser Dentistry, and also University of San Francisco, which hold courses and all that. There is WCLI. There are other academies also which are holding, some hands-on demonstrations, and there are two days courses on standard proficiency, standard competency, and advanced proficiencies. So I would say that, because they are very well segregated, and they are very well documented, where you have, not just the lecture part of it, but they also emphasize on giving exam. So it is both clinically as well as theoretically, and theoretically is just multiple choice based questions. So I would suggest all of you to take, so that we can make the best use of our gadget. So this is one of the courses which we get conducted and all that. So there are some animal tissues and all. First we talk about the vegetables, how laser energy interacts with the vegetables, and then we move on to the animal tissues and all, how the various wavelengths, they act on various tissues. So status of laser dentistry education, why is it so important? It's not important just to, show to the patient, but it is definitely a bang on to my specialty, that I would feel good, when I do a patient, and it's more predictable. I can see what all I can give to my patient. And also in an era where there are so many multitaskings which are there now. A female is not doing their part of work, but they are also counteracting with other things also. So in those kind of diverse fields, I think we should have armamentarium, which is like, making our life more easier, more predictable, and making our patients also smile in a better way. So my take home message would be like 5 essentials about lasers. So it is like there are many wavelengths, and each laser has got, a different wavelength, and different wavelengths interact with the tissue components in a different way. They all produce thermal interaction in the tissue, and different temperatures produce different interaction. So if it is a low level laser therapy, it will go for biostimulation. If it is a high level laser therapy, then it will go for cutting and all. So, and it can be emitted either continuously or in a pulse mode. So, and laser safety is essential. So in this nutshell, actually, because the time allotted to me was half an hour, which is, I think, a very less time to cover this whole vast topic, which is of like, multiple decades and also, since we have been into this from, I was in this from 2012. So from 2012 to 2023, I've been just working with them and finding out various other possibilities what we can explore. So the topic is still untouched. So what is important is that we have to realize that it is not, like I said, like it is an adjunct and sometimes not the only solution. So it cannot replace, my scalpel, neither it would replace my aerator, nor it would replace any of the armamentarium which is there conventionally in my clinic. But it would definitely provide, professionalism and perfectionism. So where I can make my life and my patient's life easier. And I don't know whether we have a little time.
Please be a lifelong student. When we are kids, we ask questions like, why is the sky blue? Why is the bird flying so high?
So this is Mrs. Indra or Nurani, and she's like talking about, like we should be learning lifelong. So it should not just stop like that. As Socrates had said that I don't know anything, but I am still like, searcher, and we are in science. So science is ever evolving. So we can never say that, okay, today what is there will not be there tomorrow. Like we said, like Nokia was there before, now is like other brands also, but Apple is still there. So you need to, explore yourself, you need to rationalize yourself, you need to create various measures for yourself, read, and be in an era where you can question much. So with that, I would like to conclude, and thank you so much, Dr. Nurul, and other people also of the fraternity who have taken such an initiative of, talking about this and making this forum lively. Thank you so much. If you have any questions, you can please put it in chat section, or I can share you my mobile number, or you can take it from Dr. Nurul also, and you can ask about anything. Thank you so much. Jai Hind.
Thank you so much for that wonderful presentation, madam. It was indeed a very enlightening and enriching experience for all of us. And as you very well said, a knife given to a butcher and a chef makes a lot of difference. And you ended with a high note of you should never stop learning. So that is the best thing about all of it. And ma'am, thank you very much. And would move on to the next presentation. Can we have the next speaker for today, sir? Dr. Nymphia Pandit. To introduce Dr. Nymphia Pandit, Madam is a graduate from SCB Medical College, Cuttack, and she completed her MDS in periodontics in 1998 from Government Dental College, Ahmedabad. She has received the Best Graduate Award by ICDRO in the year 1993. She is also the recipient of Colgate Palmolive Award and ISPPD in 1993 and Guidant Award in 2011. She is presently working as the professor and head Department of Periodontology, DAV Dental College and Hospital, Yamuna Nagar. Madam has 50 international and more than 100 national publications and has been a keynote speaker at more than 80 forums at international and national and state levels. She has conducted 6 workshops on piezosurgery in periodontics at Yamuna Nagar, Chandigarh, and Nepal, and Gurugram, and Alipurdar, West Bengal. She has organized many national level academic programs as a part of ISP events, including the conference chairperson at annual National ISP Conference in 2018. She has authored a book titled Concise Periodontics and written a chapter in the implant course book conducted by IGNOU, as well as chapter in book on bone regeneration, and has introduced a new classification for recession related to malocclusion. She is the past president of Indian Society of Periodontology and in the editorial board of the Journal of Indian Society of Periodontology and many other national journals. She has been at different posts in IDA, Yamuna Nagar branch, including president in the year 2012. We welcome you for this session, madam, and we are happy to have you here. And next, over to you for the presentation, madam.
Dr. Nymphia, your voice is not coming. Could you please unmute? We are not able to hear you. There's a problem in your system of PC. Could you please disconnect and connect again, if possible?
Oops.
Hello, can you hear me now? Hello? Hello?
Yes, ma'am, you're audible.
Yeah, I can share.
Yeah, Dr. Nindya, your voice is coming now. You carry
Just
on.
a second. I'm sorry for the delay. I just
Not at all. Yeah, your voice is very much audible now. Yes, you share your slide.
Yeah, slides I'm sharing just now.
Mhm.
Thank you. Meanwhile, thank you so much for your kind introduction. And I am very thankful to Dr. Nurul and my friend Dr. Afsham Bey. She's here. It's a pleasure seeing her on the same platform and all. Thank you so much. And I am so happy that somebody is honoring women on this in this month of this Women's Day. And I would like to share some experiences of what I have done with the microsurgery. For a long time, I had been working for the piezo surgery, but then you tend to, as Dr. Shelley said, you tend to explore more and more in what you're doing, and I'll share some experiences about experience with the microscope. I'll be, is the screen visible to all of you?
Yes,
Hello?
visible. It's visible, ma'am.
Right.
Mhm.
Okay, so wherever microsurgery has been used in periodontal surgery, I'll be talking about that. I have this first idea about the using of microscope is that with the help of microscopes, there is nothing so small as to escape our inquiry. So if we use the microscope, there are some things which were not visible to the naked eye, and we can see them through the microscope. There was a very recent dental news. It's a news in 2021 where they say that what the eyes can't see, you cannot treat that area. So this microscope really helps in that, and it was a good quote by that. You can see the type of surgeries that have been performed with the use of microscope, and the precision you can get with the use of something which improves your vision and your accuracy. So if we talk about the field of periodontics, then there are some procedures which need a lot of precision. See, we are dealing here with the tissues which are 2 millimeter or 3 millimeter tissues. We are not dealing with a whole lot of 10 millimeter, 10 centimeters or 1 meter or something like that. We are dealing with 2 millimeter of bone, 2 millimeter of gingiva, which makes a lot of pink and white aesthetics important to the new people who are very much conscious about their aesthetics. So the precision related with that may be GTR, the guided tissue regeneration, soft and hard tissue, ridge augmentation. All these procedures that have been done with the microsurgery have really seen to be having a better healing as compared to that. If we go to the history of microscope, it was in 1964 that Leeuwenhoek first constructed the compound lens microscope, and we could see things which were not visible to the naked eye. In 1921, Carl Lane was the person who is considered to be the father of microsurgery, and he used the microscope or the binocular microscope for the air surgery. We give the credit of having this microscope in dentistry to Daniel Arke, who first introduced the microscopy. And Sir Serafin was the person who introduced it in all the specialties apart from not only the endodontics. And particularly in endodontics, we can say that is not my field, but we are dealing with root canal, and we have very small orifices which we need to locate and treat accordingly. So if anything that aids us to locate those canals properly, that would definitely help us in treating those better and having a better hermetic sealing of those canals also. The whole credit of using microscopy for the periodontology goes to Shelenek and Tibbets, who first introduced the continuing education program in the AAP, first education in the CD program in the American Academy of Periodontology. So if we are looking at an image, what is the way that we can see that image in a better way? It's either getting closer to the objects or by magnification. Now, you cannot get closer enough to a patient. You cannot just go just close to his mouth. So the only way by which we can look at the things in a better way is by the magnifications. So what are the magnifications that have been introduced which are important from the periodontal point of view, for the dentistry point of view? So these are, first is the magnification loops and the operating microscope. Now both of these models have their advantages and disadvantages. If we are talking about the examples of these, we have seen the jewelers using those clip-ons where if we are purchasing some type of a jewelry, what we see is that we want to see that hallmark, we want to see whether it's authentic and all. Those jewelers use that, and we can also have a look and they will show us that it's an authentic jewelry. Or we can have multi-lens telescopic loops. Now we need to understand some basics about how the microscope works, how we can have a better view at the things. There are many things that you need to have an idea about. First is the working distance. If we look at this, this is the working distance. This is the area where your eye and your working area is. This is the working distance. This is the object, and your eye, the magnification. This is that. The field of vision, the portion which you can see under the microscope, that is the field of the vision, and the direction of the view is in the same line, as we know that light travels in a straight line. So this working distance, the depth of the field, this is important from understanding, and the convergence angle, at the angle where the both eyes converge to a one focal point, that is the convergence angle. And width of the field, how much area we can see, what is the viewing angle, what is the angle at which we are able to see the microscope, and we have already talked about the convergence angle. So these are the various areas where we need to know. Now, if we apply the same knowledge to what we are doing under a microscope, we need to understand it in the view that if there is a good depth of field, then we can see a greater portion at the depth. If it's a shallow depth of field, we can see only a smaller portion. For example, if we can see these are all out of this and this person is out of focus, these are under the focus, so we have a better depth of field. If this is only portion that is not blurred, that is the we have a shallow depth of the field. That means the depth of the field of a microscope, if we have to buy anything, we should be concentrating on the depth of the field and the working distance. Now look at this. Working distance should be something which gives us a freedom of operating in a bigger area. So if we are having a better working distance, we will be able to concentrate at different portions in the oral cavity, which anyway has difficult access and difficult visibility. So this is another area what you should be thinking about. Now talking about the mechanism, there are two mechanisms by which these microscopes work. The basic thing what we need to understand is that the longer the light travels, the better magnification and better focus we will have. Now there is a limit to how many lenses you can put. Look at this. You can see that there are many lenses, convex, concave lenses, binocular lenses. And these are the first principle that the magnification works as is the caplanar optics, where there are two lenses which are angled to focus an object. The loops mostly work on this principle. That's what I was saying. If the longer area, the longer distance the light has to travel, the better focus we will have and better magnification we can have. Another principle on which the magnification works is the Galilean optics. It means that there's a binocular eyepiece which is joined by opposite prisms. Now we are trying to increase the length of the light that travels to the object and magnifies the object by using the prisms. The prism will have the light entrance at one area, then reflect at another area. Without increasing the distance between the eye and the object, it will have a more length of the light to travel and better magnification with not using so much of difference. And in the same way, we cannot, if we are using prisms, we don't have to converge the eyes. If the eyes are converging towards a single point and it's not a straight line axis, there are more chances that our eyes will get fatigued. If we have a straight line access to the object and there is no convergence, the eye fatigue is less because your muscles are more relaxed if you have a straight line vision. So this microscope actually works at the Galilean optics, and here the chances of eye fatigue are less. Now, what does the microscope basically help at? If we look from the surgical point of view, it is the improvement of motor skills. We can have a better approximation of wounds and we can have a passive wound closure. Passive wound closure in any surgery is important because if you have a tense wound closure, the vessels around this area, if you look at this area, the vessels around this area, they will get constricted and there will be less blood supply, which will mean delayed healing and not a good primary healing in that area. So the microscope helps us to have a passive wound closure, and because it's a precise incision, the tissue trauma is reduced. We don't have rag dents of the flaps, and the type of healing that occurs is definitely better than what we can achieve without the microscope. Now, this microsurgical triad is something which works with the three ends on it. One is that there is illumination. You can see the field of your work very nicely. There is magnification and there are instruments. These are the three things that form the microsurgical trial, and we need to concentrate on improving all three of them. It was given by Belcher in 2001. So what is illumination? If we are working in oral cavity, what happens that there are some shadow areas. But in a microscope, there is a coaxial illumination. Coaxial illumination means the way we are looking at the object, at the same line parallel to that, there is one spot of light which will not form the shadows in the oral cavities, and it will give us a better visualization. Better visualization definitely not only from the point of view of the magnification, but also from the point of view of lighting of that area, that is visualization of that area. So this gives us an upper hand and we can work in a better way. So if we have we are using loops, so those people will not have this coaxial illumination as in the microscope. So they their conditions, they sometimes use headlamps for that same line of illumination as the viewing point, or as the viewing binoculars. So what is the level of magnification that can be achieved through the loops? See, we are not here working on anastomosing the vessels. We are working on having magnification which should be relevant to our field. We are not using very small millimeter type of a measurement. We can have magnification which is which works very well with a 2.5 to 3.5. I think this is the type of magnification which works in most of the situations in whatever dental procedures we are doing. We can have better magnification with the microscope. We can have better magnification with the higher magnification resolution. But for most of our procedures, a loop should be a good armamentarium that you can add to your daily practice. So what are the magnifying loops? They are simple, these lenses, meniscus lenses. They are kept side by side and they are single. And these are the ones which are very cost effective and you can get it at a very cheap price. So what are the disadvantages? The disadvantages are the same what I was telling you in the principle also. They distort the image. You have a very narrow field. You don't have the depth of the vision, and not much practical dental application beyond 1.5 diameter. So it does not increase the field of vision, neither the depth of the vision. Now, the better way of using loops is that we use the compound loops. They have the converging multiple lenses. We do have fatigue with these, but they have an additional refracting power, magnification, and working distance and depth of field, which is a disadvantage with the simple loops. So these, some of the disadvantages of using the microscope are here, but some of the advantages are there as compared to the simple loops. Now, compound loops, they also work up to a magnification of around three points. So what we have in these, as I have already explained, that the light has to travel to a longer distances. So in those cases, we are using these compound loops whereby we increase the length of the light that is improving, and it's now. Now, these are prism telescopic loops. Here also we are improving the magnification, the field, and the depth of the vision by using prism. The eye is at the straight line. We don't have to bend our head for looking at the object. It travels at one area, and it's visual. We are able to visualize in this area the working area. That means the eye, there is no eye strain, there is no eye rotation. So natural head position, and we don't have to bend forwards. So what does this prism loop do? It has a better magnification, it has wider depth of field, it has longer working distance, it has larger fields of view than other loops. So the barrels of prism are short to be mounted on either eyeglasses or headbands. So you have to visualize it. But once we are using a lot of lenses, it increases the weight of the loops, and what we need to do is that it cannot be mounted on the glasses. It has to be mounted on a headband. So beyond 3x, we have to mount it on that. So what is the difference between a simple loop is that it's a one lens. Compound loops is a combination of lenses, and prism loop is where we increase the distance of the light that travels through the lenses by using prisms. Now the best magnification, of course, is the surgical microscope, and it can give us a magnification of around 4 to 40 times what we can see with the naked eyes. And it consists of the magnification changer, lenses, lighting units that I was talking about, the coaxial illumination, binocular tubes, and eyepieces. And it has different varieties, and we can fix it on the floor, or we can fix it on the ceiling or the wall. Now, if we have a comparison between the simple loops, compound loops, and the prism loops, we already know that the simple loops is a single meniscus lenses, compound loops is multiple lenses with intervening space so that we have more distance of light to travel, and prism loops has the light has to pass through a series of switchback mirrors, and that increases the distance. Magnification only to some extent with simple, better with the compound, and best with the microscope only, but with the prism telescopic loops also we are getting better magnification. But mostly the advantage of prism telescopic loops is that we do not get neck strain, and we do not get the eye strain. And we have a magnification of 1.5 with simple, 3x, and better magnification with the prism loops. Now this is the operating microscope. It's in our college also. It combines the magnification of loops with the magnification changer and a binocular viewing system. This is the eyepiece, this is the whole system of lenses, and then we visualize it from here. The parallel binoculars again are an advantage, because now again we have a we don't have to converge our eyes to look at an object. It's a parallel straight line vision, which decreases our neck strain as well as the eye strain. So if we, as such, compare the loops with the operating microscope, we have magnification which is around 20 with the operating microscope, and loops need another illumination. What I was telling you, they use headlights for illuminating, but the microscopes have inbuilt coaxial fiber optic illumination, which eliminates the shadows. And we have eye strain and head strain with the loops, most of them, except the prism loops. But with the operating microscope, of course, there is binoculars vision, and it has no eye strain or the neck strain. And it's easy to use. You don't have to go through a lot of process. I'll be telling you what we are talking about, some very good things about operating microscope, but I'll tell you what are the drawbacks of the microscope in a while. So here we're not using the normal instruments. Now, why do we have to use different instruments with the microscope? Is because there are two things. One is magnification. Your normal instruments are too crude to be used in that. Plus, you need non-magnetized and lighter instruments, because you are not working now with the forearms. You are working only with the wrists, that I'll show you in the further these slides. The basic requirement of the instruments that have to be used with the microsurgery is that they should be long, because now you are going from an area where you are holding the instrument and then going way beyond that area where you are working, because you have an instrument in between that area. So it has a 15 centimeter long this handle. It's a cross sectional is round, and the weight should be less, because now you are working only with your fingers and your wrists, and you're not using your forearm. And it's made of titanium, because that is the way to reduce its weight as well as prevent magnetization. Now, these are some of the properties that are exclusive to the microsurgical instrument that we have already talked about, that they are of titanium. The round handle should be there because they should be able to be precisely moved in between the fingers, and they should have a color coating so that you don't have a metallic glare under the illumination. Weight should be 15 to 20 grams, and needle holder particularly should not have a more locking force than 50 grams, because it's very refined procedure and you cannot have a larger force. With very small needles, they will break off. So that is one thing you have to take care. These are some of the microsurgical knives. These knives have been also used in ophthalmic surgery. So you can see that they are the knives which are used in very small areas of the eye. So these are some of the knives that have been used in the microsurgical instrument. These are some of the instruments that have very... Now, suturing. Now, one basic thing that I've shown you earlier also, that this is the passive wound closure. One of the main things, another thing that is important from the microsurgical point of view, that the needle here enters at 90 degrees rather than at an angle. So this is the best way of minimizing trauma to the tissues if you have a straight line axis and a 90 degrees entry point for that. And very thin needle, very thin needle and very thin thread, so that the minimum trauma is there, and that is the way that there is better healing with the microsurgical instruments. So what are we using? Normally we are using 4 to 5, but with microsurgery we can use 6 and 7 or even 8 in some cases. So you can imagine the thickness of the thread is very less. The needle entry and exit is at 90 degrees. Suture bite is approximately 1 to 5 times the tissue thickness, and equal symmetrical bites have to be taken, and needle passage has to be perpendicular, that means 90 degrees. So if we compare the these needles of used in the microsurgery 5 and 6.0, you can see the difference, how much difference is there. They are, the suture threads have been kept with a coin. You can see how thin the sutures have to be used as compared to a coin. So they have been used. And the needle holder, as we have already discussed, the force at the locking position should not be more than 50 grams, because we are working very fine things. We are working with that. If we are using more force, that will reduce our control over the instrument. These forceps also, these are something which are special to that. These are called surgical and anatomical forceps. They are to be used under the microscope. They are used both for holding the thread as well as giving a knot. Now you cannot work in a very big field as you are working with the naked eye. You have to use only two instruments. That means the needle holder as well as this forceps for tying the knot. So knot tying is, you can use any knot, but surgeon's knot is one which will not slip away, since you are using 6770 vicryl threads. The knot holding capacity of those is not very good. So you have to use the surgeon's knot in that. Now, one of the big advantages of the microscope is that you are standing straight. Now look at the position of the surgeon. Because you can visualize something over here without bending your back, the biggest problem with dental surgeon is that they have backaches. Now you are eliminating that backache because you are able to have a position of your back which is more conducive for your spinal health. Support of the wrists is important because you have to control, you have to initiate movements from here. I'll show you some more slides of that. This is how you hold the microsurgical instruments. Hand control is by the long flexure muscles, and it's not a crude wrist movement. It's stabilized, the wrists initiate the movement, but you are actually working with the fingers. This is a pen grasp which you are using for that. And motor coordination is greatly improved when people use microsurgical instrument, and precision grip is there, which is important for doing very precise type of surgeries. So there is lesser trauma to the tissues because you are giving smaller incisions, very precise incisions. There is no dragging of tissues. It's a very sharp incision, and you can use smaller needles and suture materials. There is primary closure of wounds. So there is elimination of dead space. There is faster healing. There is no delay in the healing. There is no way that this wound can get necrosed, or you can have ragged ends and you can have a delayed healing. So before starting microscope, you can see you have to do a lot of homework. It's a very steep learning curve to use the microscope. Here we are doing exercises on the chicken legs where you are using 60 and 70 sutures. And here, if you can see, you have to stabilize your forearm. You have to initiate the movements in the wrist. You have to work with your fingers, and you should have a very controlled force, rotating force generated by your fingers. So this is what there are very symmetrical sutures that have been placed, but because we are not initiating crude movements from this. Now this is a small video. I don't know whether this will, is this playing? Can you hear me?
Yes, playing, ma'am.
So if you can look at this, this is a very frustrating video. I wanted to show you this because was one of the videos that I saw on the YouTube. This means it's a long, steep learning curve. It's very difficult to have an eye-hand coordination when you're working under a microscope, because you're used to hand-eye coordination without a microscope. When you're working, the field gets bigger, magnification is more, and it takes a lot of time to actually have this coordination where you can hold these two instruments and then do the suturing. It slips away, it goes away, you cannot hold it. You feel it's here, but it's somewhere else. So you have to have a lot of patience for this. This is one thing which I would recommend that. So we have also used microscope. So this is how we work on that. Applications are, you can have diagnosis. I think that for periodontics, we don't need microscope for diagnosis, but maybe in the endodontics, where you have to look at the canals and the orifices of the canals. You can use it there for crown lengthening, regenerative surgery, root coverage procedure, smile designing, implantology. It can be used anywhere. This another video which I would like to show you. Sorry. I don't think this is working. Yes. So this is one video which would give you an idea about how this works.
Okay, today so we're doing some alloderm grafting from number 22 to 27. You can see he's got very thin tissue there, lots of recession on the cuspids. And so we're going to be doing chronal positioning and alloderm grafting.
You can look at the type of instruments that are being used. Very small, precise instruments. They're doing the root conditioning. Tetracycline paste.
You just come for one day? Doing okay? Because New Year's.
So made those money selling those real full tickets.
Oh, yeah. You didn't go into that guy?
Either way.
A little bit of water.
You're going to feel some pushing.
This modified Orban's knife you're using over here.
Subgingival on the facial.
The whole.
So he actually had some tooth showing left when I moved the segment.
They're doing allogram grafting over here. Under this is under loops. This is not actually using, and this is the outcome of the.
27.
So this is one thing I wanted to show you, and so this was one of the studies done by Banowski. He demonstrated that if we look at the root debridement, what we use without the microscope, without magnification and big magnification, there was a lot of difference. The amount of calculus that we were able to see. So you can see better way, that better root condition is there. Application in the management of periodontal flaps, we can see that there are very precise incisions can be done, which are atraumatic and which can actually heal by the primary healing. And there is precise adaptation and easy identification of the, if there are ragged ends, we can freshen them because we are able to see better way that if there are any ragged ends. Recession coverage by the envelope procedures, we get some very beautiful results with the coronally advanced flap also. And the papilla reconstruction, you can have a comparison between the this macroscopic and the microscopic type of a surgery. There's a series of these, and you can definitely know that there will be a better healing in this type of surgery. And there was a study by Buchard in 2005 in a split mouth study where he saw that there was more anemia and more of dead space in the areas where macrosurgical procedures were done as compared to the microsurgical procedures where blood supply was very well maintained and the grafting of tissues was well taken up because of less trauma to the tissues. Fortunately and Tonetti also found that there was improved visual acuity with that, and but in 2010 there was one study which found that there was not much difference between the macrosurgical and the microsurgical procedures.
Dr. Nithya,
yes.
sorry to interrupt you. Apology for that. Could you please make it a bit fast because we have other speakers who are waiting for their turn and we are already late.
I have just 5 minutes, 7 minutes.
No, you take your time, but little bit, you can close it as.
No, this is hardly not much left now.
Okay.
So applications in the periodontology, we can use it for the reconstruction of the papilla. We can use it for the conditioning, mechanical root preparations and biological root preparations. So I wanted to study, just give an idea about 2 studies that we have done. We have used these loops in the reconstruction of papilla, and we have also used the microscope in one of the theses that we have done at our place. So this was a study that was done where the two techniques of papilla reconstruction were compared using the using the loops by Beagle's technique and Aziz technique. As you can see, this is the Aziz technique by which we got the reconstruction of the papilla. We use the connective tissue graft in that. Beagle's technique, we fold this over its own area, and we got some very good results. And there was a decrease in the pocket depth in both the groups at 3 and 6 months post-operatively, and significant improvement in the gal and contour of the interdental tissues also improved. Another study that we did under the microscope, so it was to evaluate and compare clinically the efficacy of recession coverage with the microsurgical and macrosurgical. It was a split mouth design. We evaluated different parameters in that. Mostly the most important was the recession depth and the recession width. And this is the armamentarium that we have used. We have used 6 zero-Vicryl sutures in that. And Miller's class 1 and 2 recession were taken into consideration, and we used the subepithelial connective tissue graft. You can see the microsurgical management of that. It was under the microscope, and as compared to the pre-op, very good results were obtained in that. In the macrosurgical cases, although the results were good, but you can still see that there is some ragged ends, and the healing is not that precise as compared to the microsurgical areas. Even here we can see a bulbous tissue in the macrosurgical, and microsurgical gives a very precise adaptation of the gingival margins. This is again another case. Again, some type of healing is there. And we saw that there was recession coverage was obtained with both the groups, but there was definitely statistically significant better aesthetics that was obtained with the microsurgery. So this is the publication that was the comparison of this. And I want to conclude by saying that there are some advantages. You have a better wound adaptation, you have patient acceptance is more, lesser pain is there. As a dentist also, you can feel that there are better ergometrics, net control is better. And the only limitations that are there, you can see, I showed you that video also, that it's a very steep learning curve. The cost of the microscopes is around 14 to 16 lakhs. If you can afford that, there you have to have an area to install, and the maintenance is also, if it is such a costly instrument, the maintenance is also very high. So all these things you have to remember, and it's still in its infancy. We don't have many articles that prove that it's better, but obviously if you have a better precision of the procedures that you are doing, definitely you will have a better outcome of the results. So this is where we are doing some surgical procedures. And I want to conclude by saying that it has many applications and benefits. And as a professionals, we need to really hone our skills and get better learning skills so that we can treat our patients better. Thank you so much. Thank you for giving me this opportunity.
Thank you so much, Dr. Linda. It was indeed a very enlightening session for all of us. And being a periodontist myself, it was much delight to listen to you. So good afternoon to all the dignitaries. Myself, Dr. Mansi Mehta. I am a periodontist and I've been working in Delhi NCR for the past 7 years. And I will be moderating today's next few sessions for you all. So before starting with anything, I would like to thank Dr. Nurul and the National Health Academy for conducting such a wonderful session and giving us a platform to all the female dentists to interact with each other and share knowledge and learn from each other. So next we have Dr. Sneha Devakar with us, and she would be taking or enlightening us on sports dentistry, a new horizon in dentistry. So Dr. Sneha Devakar, she is a sports dentist who is practicing in Pune for the last 15 years. She has done fellowship in aesthetic dentistry, diploma in sports science, master program in sports nutrition, and fellowship in psychology counseling. She is a consultant sports dentist at various schools, colleges, and sports clubs in Pune. She has started a course by the name of Diploma in Sports Dentistry for Indian Dentists, which is first of its kind. She has been facilitated dental speaker on sports dentistry at local, state, and national levels. She has authored a chapter as well on the same topic in a textbook of pediatric dentistry. So I would request Dr. Sneha Divakar to take on the stage from here. Thank you.
Hello, good evening, everyone. It's really an honor to be speaking on this platform where all female dentists are there. So I just want to check. First, let me just share the screen. Just a minute, huh? Let me just. Mansi, you will tell me whether you are able to see the screen or no. Huh? Just a minute. Just a minute, huh?
No worries.
No, yeah, I'll just switch it on. Okay, I am now sharing it. Just a minute. Where did the window go? Okay, just a minute. Okay, can you see it?
Yes, it's visible, ma'am.
It's visible.
Yeah. I will do the slideshow now. You just tell me whether it's going ahead or not. Can you see that the screen is moving ahead? Or is it just static?
Please move. Please move. I'll let you know.
I have moved.
No, it's not moving.
Okay, then what I will do is, I will exit the slideshow mode. I will not keep the, sometimes what happens is the slideshow mode, it does not, just a minute. Just a second. You cannot see, right?
No, it's not visible now.
Okay, just a minute. Now it is visible?
No, we are waiting. Just hold on. No, it's not visible.
It's not moving?
No.
No, it's not visible. First the slide comes to, then it will move.
Achha, it's not visible only?
No, it's not visible at all.
Okay. Okay, just let me close that window. Just a minute. Just a minute.
Please do not off the slideshow mode. You just keep without that.
Yeah, that's what I will do. Yeah, just a minute. Now I'll share again. Yeah, can you see
it's
the
visible.
first?
Yeah, it's visible. Can you
And
move
the
on
next slide?
Yeah, it's next slide. Yeah, it's moving.
Okay, let's not go for the slideshow.
Okay,
so I'll start. So let us all, find out what is sports dentistry, which is a new and very interesting topic in the field of dentistry. So I'm happy to share a few things about sports dentistry, its importance, and what all we have been doing here, and kind of my journey about the same. So the first question that I would like to ask all of you is, have you heard of sports dentistry? Basically, it is a very old field of dentistry in US, UK, Australia, and not since last 5 years, not 10 years, since last 3 decades. So is it new in India? Yes. So it is important to increase awareness regarding it. So what can we have a plan of action for that? To educate the dentist, to educate the athlete patient, and to educate the sports administration regarding this. Now, why is it important in the first place? There are many studies being done in countries like US, UK regarding dental-facial injuries in sports. And some of the common conclusions that they have is that 50% of kids participating in sports could experience a dental injury by graduation. 3 million of teeth are lost at sporting events annually, and dental injury is one of the most common type of oral and facial injury sustained during participation in sports. The majority of these dental injuries, which are definitely preventable with the use of mouth guard. So I hope you are all with me and the slides are moving. I hope everyone can hear
Yes.
me. Yeah. Okay. So I'll continue. So, is it just only about dental injury issues for the athletes? No, there are a lot of oral health issues that the athletes are facing, like severe dental erosion and decay. And these are, let me tell you, one of the worst and most neglected problems in athletes. And today we have proof about this. In there have been many surveys in various Olympics that have been done since last, 2 decades. So this one survey was done at the London 2012 Olympics, in which they have found out that 40% of the athletes were bothered by their dental health. 20% of athletes felt it impacted their training and performance, and 30% of athletes reported a loss of quality of life. Thus, dental literature contains now a lot of information from surveys taken at these kind of championships that clearly demonstrate the need for basic dental care in athletes. Yes, as I said, increase in dentofacial injuries is a big topic. More than 3 million, more than 5 million, these kind of teeth are getting lost every year. And an athlete has a 33% chance of sustaining a dental injury in sports. And we all know that, maximum of these injuries, around 80% of these injuries are going to be to the maxillary central incisors or the two front teeth. Now, these injuries are more common during contact sports, and we as dentists know that what are the physical signs and symptoms that we see, that the tooth becomes loose, the tooth becomes avulsed, there is bleeding, and so on and so forth. There can be jaw fracture, the patient might find difficulty in biting, opening the mouth, etc. But as dentists, have we really thought that what can be the psychosocial impact of these dental injuries, especially if there is an alveolar fracture or a facial fracture involved? Because see, for the athlete, he or she, they are a public figure, so for them, their face is their value, right? So the athlete is going to become depressed, they are going to have a lot of anxiety and loss of self-confidence because of these kind of injuries. And talking about the economic impact, we all know that the recovery process for these injuries can be really lengthy. Lot of money have to be spent, if there is avulsion, implants, and there are so many. If there are alveolar, mandibular, maxillary fractures are involved, then definitely the recovery process is very lengthy. So it is our duty as dentists that we have to imbibe on the athlete and the coach's mind that protective equipment like a mouth guard is definitely cheaper than rehabilitation. So let us see which are the top Indian sports where mouth guards are a must, like football, hockey, cricket, boxing, kabaddi, soccer, cycling, gymnastics, basketball, mixed martial arts, volleyball, skating, etc. So am I the only person, or are there any few handful of dentists talking about mouth guards today? No. There are different world dental associations who are recommending mouth guards. Currently, the American Dental Association recommends mouth guards to be used in 29 sports. It's a really long list. Even the Australian Dental Association has identified 20 sports played by Aussie kids in which mouth guards should be worn. They have their logo, like the a punchline, as you see, when it's game on, it's mouth guard in. So they are asking, is your sport on the list? Yes, in India, as we saw earlier, there are definitely 12 to 15 sports where we can definitely ask the athletes to use mouth guards as a part of their protective equipment. Sports in India have been on a rapid rise in the 21st century. That is why more than earlier, more than now, our athletes need dental care and trauma prevention to give them a competitive edge while playing. Not just local or district or state level sports, national and international levels. Today we see our athletes are getting so many accolades for the country. So don't we feel that as dentists, why only sports medicine physicians or sports nutritionists play the important role in the health of the athlete? Even we as dentists, we should realize our own importance, and we must tell them, we like the dental groups and associations in India, along with sports bodies at various levels, must include sports dental care or sports dentistry with the motto of not just to improve the oral health, but to improve the overall health of the athlete. So basically, just to introduce, what all does sports dentistry include? it is not just dental trauma management as some people may think. So there are a lot of angles to it. So in a nutshell, I would like to tell that it includes oral care of athlete, diet modification in regards to, if the dietary habits are causing a lot of dental erosion and dental decay, substance abuse or tobacco abuse counseling, customized mouth guards or high quality boil and bite mouth guard fabrication for the athletes. Injury prevention programs are very, very important because it is, especially in a country like ours, there is a lot of thing to do. There is so many awareness programs we have to conduct in each and every vertical, right from the local level to the national level. Everywhere we have to conduct dental care and dental injury prevention programs for not just for the athletes, for the coaches, their parents, for everyone. Okay, so this is a very important part. And of course, last but not the least, emergency and long-term dental trauma management. So the sports dentist should have knowledge about which different topics. Now, for better understanding, I have divided it into sports related topics and dental related topics. The sports related topics are sports physiology, sports medicine, sports nutrition, basic sports first aid, doping, protective equipment of head, face, neck, tobacco or drug abuse counseling in athletes, and sports psychology. And the dental related topics are prevalence, understanding the prevalence of dentofacial injuries in sports, oral care and dental treatments of athletes, dentofacial injury prevention programs, all detail about mouth guards, each and everything, emergency and long-term management of dentofacial injuries, and dental treatments of tobacco or drug abusing athletes, or athletes doing doping. Now, who all can become a sports dentist? Let us look at sports dentistry and various specialties in dentistry. Dentists of all the specialties can become a sports dentist, including the general dentist, as all types of dental treatments are needed for the athlete. So every specialist, and including the general, they have their own specific role to perform in the athlete's dental care. So it's going to be a teamwork. Like for example, in my clinic, I am the general dentist and I have done my, I have studied sports dentistry. Okay. But I alone cannot, perform dental treatments. It's a teamwork. Okay. So I, along with my team, we perform all kinds of various treatments for the athletes. So that's why I'm saying that, the forum, it's sports dentistry, this subject is welcome to one and all. So irrespective of whichever specialty, what benefits will the dentist have? Additional athlete clients and related people to the dental clinic, revenue generation through mouthguard fabrication and general dental treatments of the athletes, opportunity to associate yourself with various schools, colleges, and sports club as a consultant sports dentist, and of course, good marketing of yourself and your clinic. Let us see just few cases of various dental treatments of athletes. So as I said, dental trauma, dental oral care, there are so many things involved. So a case, this is a class 2 fracture of an 18-year-old athlete. Then this is again a Ellis class 2 fracture of a 21-year football athlete. Then this is a case of a 14-year-old athlete doing skating who fell on the face and refused to go to school till the aesthetic treatment was done. Now, I know you will say that first, this child needs, what he needs is an ortho treatment. But then, see, that's what happens in our country, that, the patient, economically, the situation was not that great. So they said that we might come for orthodontic treatment, but right now you please get this tooth treated. So it was funny doing some cosmetic work because I had to build the tooth in a tilted manner, to match the adjacent one. So along with restorations and of course endodontic treatment also needs to be done wherever pulp tissue or trauma to the pulp is involved. So along with these, general dental care and preventive treatments are also important. So this is such a simple case of doing scaling, but this is very important. Let's not forget our basic sports. While practicing sports dentistry, all these basic fundamentals of oral care, oral hygiene is very important. You have to explain the athlete. You can see in this photograph that an oral kit is prepared, and you have to tell the athlete that to whichever competitions you are going, out of home, that they would visit so many places. right? So along with their whatever other personal hygiene stuff that they carry, they must also carry these oral care kits, and they have to be explained about different types of mouth guards that are available in the market today, and we have to tell them, cater to their needs, what kind of sport that particular athlete is playing. Is it a high hardcore contact sport? Is it a light contact sport? Accordingly, we have to suggest mouth guard, and of course what kind of economical situation that the athlete is in. So here you can see taking impression for a 13-year-old boxing athlete and delivering a double-layered thermopressed mouth guard, which is the latest type of custom fabricated mouth guard, which, you know, and especially for a boxing athlete, a double-layered mouth guard, which is minimum is what is required for that, for him or her, and demonstrating in the next case how to use a high quality boil and bite mouth guard. Like for example, right now in the market, OPRO mouth guards have come. So this is I am giving to a 14-year-old athlete who didn't want a custom fabricated one due to economic reasons. So, you know, these are all the various types of cases and various things that you can do with sports dentistry. Believe me, it is a completely untapped field in our country, which you must definitely go for. And the most important thing is that along with your routine general dental practice that you are doing, whether you are in a clinic or whether you are working with someone, this is something which you can do as an add-on, which you can do along with what you are already doing. And believe me, your practice will flourish, and it becomes a very you know, interesting thing to go out to meet different people, to explain to them, create awareness, and, you know, to be, you know, so what I want to say in nutshell here is that sports dentistry is, you know, one step towards the future. Let us also be a part of the sports medicine team. Go out, tell them how important you are. See, you can see this slide as my favorite. It is explaining the players on the sports medicine team. The first is the physician and the second is the dentist. Okay, so I hope by looking at this slide, you all of you will realize that how important dental care is for the athlete, along with all the other healthcare issues that the athlete needs to take care of. So along with this, I would like to say a few things about myself. So I am a faculty at the Institute of Sports Science and Technology, Pune, where in July 2018, we started a course called Certificate in Sports Dentistry, which we continue till August 2022. And it was the first of its kind of course for Indian dentists. Have been conducting many one-day workshops on sports dentistry at ISST Pune. Also, it has been a long journey because, you know, I have to take so many dental care and dental injury programs for athletes. During COVID, everything was shut, and again we started conducting. Started taking webinars. Then we again started meeting up athletes. So there have been a lot of hurdles, and of course there has been a lot of reluctance among athletes to listen. But once they start listening, once you get in touch with their parents, people start slowly accepting that yes, this is important. I've been a local dental speaker at various places in Pune with IDA branches in local study clubs and the various dental colleges here. I have been felicitated as a regional and national dental speaker on sports dentistry. So, all these things have been very encouraging for me, because it is clearly showing that, you know, people are now slowly, when we started out 5 years back, nobody knew anything about this topic. So since even 2020, I've been conducting and will continue to conduct webinars like these on sports dentistry, because I feel it is really important to increase awareness among Indian dentists about this much neglected and untapped field in our country. I have been lucky enough to, get awarded by many organizations for, leading in sports dentistry and taking efforts for introducing sports dentistry to Indian dentists. Last year, 2022 has been a really very special year for me, because three many few things which happened for the first time have happened. So, like for example, the Indian Society of Sports and Exercise Medicine, there I gave the first time they had someone who to speak on dentistry or sports dentistry. Then I have authored a chapter in a pediatric dentistry book, Principles and Practice, and the chapter's name is Sports Dentistry for Children and Adolescents. And last year, November 2022, we conducted the first international level dental conference in India on sports dentistry, where I was the scientific chairperson, the keynote speaker, and very interesting thing, we did a multidisciplinary symposium where we had an interactive session, not just with the dentist, but with the sports physiotherapist, sports nutritionist and sports psychologist and the sports medicine physician regarding what are the interconnections between dentistry and all of these fields. So it was a very amazing session. And I'm really happy to inform everyone that after running the certificate in sports dentistry program for around 4 to 5 years, last year we launched the 6 months diploma in sports dentistry program. It is now, instead of a 3 months distance learning, now it is a 6 months distance learning program with a 1-day online and a 1-day offline component, and it has theory and practical assignment submissions as well. So, anyone interested can definitely get in touch with me. So it is said that prevention is better than cure. In the same way, sports dentistry is definitely better than avoidable dentofacial rehab of athlete. So thank you so much everyone for patient listening. I know the next speaker is waiting, so I will not take much of your time. So anyone who wants to get in touch with me or check out the course on our website, you can just take a photograph of this image. Thank you so much.
Thank you so much, Dr. Sneha. And it was a wonderful session, and thank you for widening our horizons. Thank you so much. So next we have Dr. Swati Sharma with us, and she will be presenting a lecture on surgical and endodontic management of central incisors with unusual anatomy using PRP. So Dr. Swati Sharma has completed her master's from esteemed Dr. Z.A. Dental College, Aligarh Muslim University, through All India Entrance Exam. She has been awarded fellowship by Department of Oral Rehabilitation and Regenerative Medicine, School of Dentistry at Okayama University, Japan, after extensive clinical training. She has also worked as a faculty member at Department of Conservative Dentistry and Endodontics at Dr. Z.A. Dental College, Aligarh Muslim University. She has worked as an associate professor in Department of Conservative Dentistry and Endodontics at Institute of Dental Education and Studies, Gwalior. She has several publications on her credit in various national and international journals as well. I would request Dr. Swati Sharma to take on the stage from here. Thank you.
Thank you so much, Dr. Mansi. Good evening to all the respected attendees. Being endodontist, today I would like to share. Today I would like to share one of my interesting case with all of you at this platform. This is a case of maxillary central incisor having a rare root canal anatomy. And plus, in this case, we have done periapical surgery also using PRP, which is platelet-rich plasma. Next. As we know, whenever we start the root canal treatment of maxillary incisor, we consider that we will find only one root canal. But as being endodontist, I can easily say that there is a possibility that we may find more than one root canal too, like in the cases of dents in dentate, in the cases of fusion, in the cases of germination, there is a possibility of finding more than one root canal. So, like the case which I'm going to present, in this case, I found a maxillary central incisor. Its external anatomy was somewhat different. The crown was dilacerated, so which gave me some indication that I'm going to find some variation inside it. Now, there are many cases, many cases has been reported having a 2 root canal of maxillary central incisor in the literature, but very few cases are reported with maxillary central incisor having 3 root canal. So today I'm going to discuss such case with all of you. As we know that root canal system with abnormal variation, it poses challenge to the practitioner for the success of the treatment. Here we can see the percentage of finding more than 2 root canal in maxillary central incisor is only 0.6%. And out of that 0.6%, finding 2 or more canals at the apex is only 0.3%. That is 0.3% of 0.6%. So it is very, very rare. So that is my case is. Now here, a 14-year-old male, he reported to my endodontic clinic for the treatment of his maxillary left central and lateral incisor. He complained of pain in these 2 teeth, and he also complained of having the pus discharge above those teeth for last 2 years. On clinical examination, maxillary left and lateral central incisors, they were found to be tender on percussion, and patient gave history of trauma 2.5 years back. The oral hygiene of patient was quite fair, and the medical history was irrelevant. Now here we can see the picture of the patient. In this picture, we can see that the right central incisor is quite normal, but left central incisor, it was found to be a bit dilacerated. And the sinus was also there, which is not very visible in this picture. See, this crown is dilacerated. Now this is the intraoral view of the dilacerated crown of left maxillary central incisor. So this is whenever we find some external variation in some external anatomy of the tooth, then we should get some idea. Maybe when we will open the tooth to find the root canals, we may find some variation in the internal anatomy too. Then sinus tract gutta-percha test was done, tract test was done to detect that the sinus which we saw on the periapical radiograph, which I am going to show later, is associated with which tooth. Here, it is the periapical radiograph. In this, we can very clearly see that the central incisor, left central incisor, it is having some abnormal root canal anatomy. Some variation is there. We can clearly see 3 root canals in this. And we saw one, the fractured tooth fragment is also there, which can be appreciated on this periapical radiograph. And there is a large periapical pathology associated with lateral maxillary left central incisor and the lateral incisor. On the first appointment, we isolated both the teeth with the rubber dam, and excess cavity was prepared. On opening the maxillary left central incisor, we found that pulp chamber was quite large. This unusually large size of the pulp chamber is an indication that we may find some variation inside the pulp chamber. So finally, I got it, and I found, apart from the main root canal orifice, I found 2 more root canal orifices. This is the picture of after excess opening of the pulp chamber of maxillary central incisor. Here we can clearly appreciate the opening of 3 root canal orifices. Then chemomechanical debridement of the canal was done. I prefer using K-file. I prefer using hand files in anteriors because we have to do the preparation to the larger number. So instead of rotary, I prefer going for the K-files. Enlarging the orifice, and then proper irrigation was done with sodium hypochlorite and saline. See, this is the picture which is taken. This is the picture after doing the biomechanical preparation of maxillary central incisor. This is the master cone picture, radiograph of maxillary central incisor, and BMP was done for lateral incisor 2. As it has got open apex, so we were planning to go for single visit apexification for it. So root fragment can also be seen there, but we prefer to go for conservative treatment first. And as we have to maintain the sterilization, we have to put some medicament in the canal. So we inserted calcium hydroxide in both the teeth. Calcium hydroxide dressing was given for 1 month at an interval of 7 days. But what we found that the sinus is showing no improvement. There is a continuous pus discharge over there. So hence, finally, we plan to go for the invasive procedure, which is the periapical surgery was planned. Here, as the patient was not very cooperative, so we preferred doing obturation before starting the surgery. And there is a financial constraints were there with the patient. So we went for the rolled cone technique. Rolled, like gutta-percha is customized gutta percha is used for that, and roll cone technique is used in the case of lateral central incisor because canal was pretty wide and it was open at the apex, and we obturated the central incisor with normal gutta percha. All the 3 canals. In this radiograph, you can clearly appreciate 3 root canals obturated with gutta percha. 2 are fused at the apex and 1 is separate. This is a pre-operative view before starting the surgery. Now the full mucoperiosteal flap was reflected by circular incision. Here you can see on reflecting the mucoperiosteal flap, I found that the buccal cortical plate was missing, and I can clearly see the cystic lining. There was a lot of damage created by the pathology. This is not good. After exploring further, after raising the flap, I can clearly see the tooth fragment which is found in the periapical area. Here you can see the cystic lining and the buccal cortical plate was missing, and we can see the tooth fragment too. That tooth fragment was removed, and enucleation of cyst was done, and the area was completely deprived. As in this, we can see that there is a huge pathology and there is a big bone loss. There is a large defect. So, after that, we did the episectomy followed by the root and cavity preparation by ultrasonic device using specific diamond tip. Then in the root and cavity, we filled MTA, which is a good material. As a result of series of episodes of acute exacerbation of chronic lesion, we found there is a large destruction of buccal bone plate up to the apex. So as we can see, the bony defect is very big. So we thought of filling that defect with some biomaterial so that good healing takes place, and plus to support the mucoperiosteal flap too. Now, among various biomaterials which can be used, we went for PRP, which has a autogenous growth factors. We preferred going for PRP as the patient was having financial constraints, and this is a good biomaterial to be used in case of periapical surgeries. So what is PRP? PRP is an autogenous preparation, and there is an increase in the number of platelets at the site where we put it, and which further increase the number of concentration of growth factors which are required for the good healing of the wound. Now, normal plasma has a concentration of platelet from 0.15 to 4 lakh, but platelet-rich plasma has a concentration of platelet which is more than 10 lakhs per mm². Now, we can use PRP, has many clinical applications, not only in the case of periapical surgeries. It can be used for when bone defects are created because of the removal of teeth or small cysts. It can be used in the case of bone grafting in the case of dental implants, in the sinus lift surgery, in ridge augmentation procedure, for the closure of cleft lip and palate defects, and for repair of fissulas between sinus cavities and mouth. Now, what is the advantage of having the concentrated platelet? Platelets have got various growth factors. As you can see the list of these growth factors, that like platelet-derived growth factor, transforming growth factor B, insulin-like growth factor 1, platelet-derived epidermal growth factor, platelet-derived angiogenesis factor, and platelet factor 4. These are the factors which help in the wound healing, good wound healing. And that is the advantage of having concentrated, filling the defect with the concentrated platelet plasma. Among all these factors, the PDGF, that is platelet-derived growth factor, transforming growth factor B, and the insulin-like growth factor 1, they play a very important role in wound healing and regeneration. Now, as I said, what are the benefits of putting platelet-rich plasma? Here we can see that it accelerates the endothelial, epithelial, as well as epidermal regeneration, which is required for good wound healing. It stimulates angiogenesis, which is a part of wound healing and regeneration. It enhances collagen synthesis, which is required for the strength of the wound which is healed. It promotes. It also promotes enhanced soft tissue wound healing. Along with hard tissue healing, it promotes soft tissue healing too. There is an enhanced hemostatic response, and it reverses the inhibition of wound healing, which is caused by glucocorticoid. And it also leads to the increase in the concentration of leukocyte at the wound site where that wound is created, which has an antimicrobial effect. Now, this is the armamentarium which I use for preparing PRP. Now, the PRP was prepared by the technique which was described by Kuda et al. In this, we have taken the blood of the patient by venipuncture of antecubital vein, and that blood was collected in sterile glass tube. Here, what is important that when we prepare PRP, then we mix it with anticoagulant is used in that case. Now, 2 cycles of spinning cycle are used for the preparation of PRP. The first one, it was we centrifuge the tube, that glass tube containing the blood, at 2400 RPM for 10 minutes. And what we found that the blood sample was separated into 3 layers. This is the centrifuge machine. Here we get you can centrifugation machine, and this is the armamentarium. Rest of the armamentarium. Now, first cycle of spinning and centrifugation was done. The blood was separated into 3 layers. Upper one is a platelet poor plasma. The second one is a buffy layer, which is basically the platelet-rich plasma, and then lower one is the RBC fraction. Now here you can see that that centrifugation machine we kept the blood in the centrifugation machine. And after spinning, first spin, you can clearly appreciate 3 layers. Upper one is a platelet poor plasma. Second one is a platelet rich plasma, which is sandwiched between PPP and the RBC layer. This is a buffy layer, which is of our use basically. Then we have taken we separated the upper 2 layers from the RBC fraction, and we took it into the another tube. Now see, here you can see the platelet poor plasma and platelet rich plasma were transferred to another tube. Now we did second spinning. We again spinned it. This is second cycle of centrifugation, which is done at 3600 RPM for 15 minutes. And here the PRP is settled at the bottom. Stop recording. I'm sorry for that. There was some internet problem on my side. Now, 15 minutes before the use of PRP, like while we are doing the surgery, and we clean the defect, we remove the cyst. Then 15 minutes before the use of PRP in a surgical procedure, we are supposed to mix it with some hydrogel. That is, we mix it with sodium alginate, 0.1 gram of sodium alginate, which gives us handling characteristic. Otherwise, it is very difficult to use PRP during any surgery. And it has many advantages. There are many advantages of using any kind of hydrogel to the PRP. So we obtain 0.3 ml of PRP by combining it with 0.1 gram of sodium alginate, and which was done 15 minutes before the surgery, before we are going to use PRP. Within few minutes, we obtained PRP having a sticky gel consistency. Again, it's on. Again, it's on. Yeah, here you can see the PRP which we ultimately obtained. It is having a sticky gel consistency. Now this PRP mixture was carried and it was packed into the defect to the level of the defect wall, and the mucoperiosteal flap when sutured back. Here's a picture, post-operative picture showing the suturing of the mucoperiosteal flap back on the defect after placing PRP. This is the post-operative radiograph. Here you can see episectomy was done and MTA was placed retrograde in both the central incisors, and that tooth fragment was removed. These are the follow-up radiographs after 1 month, 3 months, and 6 months. You can highly appreciate the healing of the defect. Now, before starting any endodontic procedure, we should know about what we are going to find and what is the variation which we are going to find. Like variation of root canal, internal anatomy, variation in the internal and the external anatomy of teeth is very important aspect when we talk about the root canal treatment. Whenever we find any variation in the external anatomy of the teeth, we should keep in our mind that when we will explore the root canals, we may be going to find some variation in the number of root canals or in the size of the root canals. So we are going to encounter the variation. So as we know that one of the major cause of failure of root canal treatment is the failure to locate the extra canal. As in the case of, in my case, the central incisor is having 3 root canals. So which is a good example of finding variation in number of root canals. Now there are, as I said, that we whenever we open the tooth, we have to be familiar with the clues that like if the size of the tooth is very big, or if there is some variation in the external anatomy of the tooth. As in this case, the crown was dilacerated. So it was one of the clue. I kept that clue in my mind, and from the X-ray also, correlating it with X-ray, I was quite confident while opening the tooth, after opening the tooth, I am going to find multiple canals in the maxillary central incisor. So, in this case, like for locating multiple canals, both radiographic evaluation and endodontic exploration are of great benefit. Like we can take radiograph from different angles with 5 space in the canals. And also the other radiographic aids such as CBCT, they are very helpful in such cases. And we should be aware with the relationship of the, we should be aware with the fact that relationship of the 2 canal orifices to each other is also significant. If the orifices are closer to each other, then there are chances that they will meet at some point during their path. Now we should have idea that what is PDL space and what is root canal. Sometimes while doing root canal, we get confused. We feel that we are seeing any extra canal in the tooth which we are treating, but in most of the cases that is a PDL space. So we should be able to identify what is the difference between the PDL space and what is the difference when we see the canal. So in this case, examination of pulpal floor under operating microscope and the radiograph taken with a file confirmed the existence of extra canal. I used operating microscope tool here. So although the prevalence of root canal anomalies is low, as I said, in the case of maxillary central incisor, finding 3 root canal is very rare. It is only 0.3% of 0.6%. So, but still I got it. I found 3 canals. So you should do proper radiographic examination as well as you should exploration of the pulp chamber. So the clinician should never assume, what I can conclude, that clinician should never assume that root canal systems are simple, because endodontic success is related to thorough debridement as well as locating all the root canals. Okay, failing to identify the extra root canal is one of the major cause of root canal failure, other than debridement and other factors. So thank you so much for your patient listening. I'm very happy sharing this case with you all today on this platform. And before finishing my presentation, I would like to thank the Pink Dental Congress team, organizing team, for providing me this opportunity, especially Dr. Geeta Rajput ma'am. Thank you so much.
Thank you so much, Dr. Swati Sharma. It was a very informative session that we had from you. I just want to put up a question. Like, when you placed PRP, after how many days do you used to recall the patient for a checking up of the soft tissue, or for whatever purpose it was placed? Like you said that we had evaluated after 3 months, 6 months, and so on. But after doing it, like after how many days were the patient recalled?
Like, we keep sutures for around 7 to 10 days. So we recall patient, we have packed the cavity properly with the PRP. So we call the patient after around 1 week for suture removal.
And after that, it has to be after 3 months directly.
Yeah, no, after 1 month. As
1
you can
month.
see, they are the radiographs after 1 month, after 3 months, and after 6 months.
Okay. Thank you so much. Thank you so much. Yeah. Next, we have Dr. Sonal Yatpure, and she would be enlightening us on the scope of orofacial pain and TMD in routine practice. Dr. Sonal Yatpure is she completed her bachelor's from prestigious D.Y. Patil Dental College and University, Navi Mumbai, India, in year 2003. She is the founder of Smiles Unlimited Dental Clinic, a leading multi-specialty dental setup in Thane, Mumbai, Maharashtra. She also has specialization in orofacial pain, TMD, and full mouth rehabilitation. And it has been given, the opportunity has been given to her to deal with complex orofacial pain, TMD problems, and general dental issues, and provide appropriate care to all her patients. I would request Dr. Sonal Yatpure to please start with the presentation. Thank you.
Yeah. Can you hear me? Hello?
Yes.
Yeah, am I
You're
audible?
very much audible. Yes, very much.
Okay. So is my screen visible?
Yes.
Okay. So as doctor has mentioned about me, that I'm a private practitioner, and I had never had the scope of becoming an academician up till now, and that has actually made me humble that I'm a participant of this prestigious forum, wherein most of you all are academicians or teaching in teaching profession. As a clinician, I would be enlightening about something that is a newest field in dentistry, as we call it. It is a 12th specialty, orofacial pain. And I would say, though it has achieved a specialty status now, orofacial pain practice or temporomandibular joint disorder management, we all dentists were doing it since ages. So it is not something what we are not aware of. What is the scope of orofacial pain practice? Before you understand what you can do as an orofacial pain specialist, I would like to tell you one simple thing. Orofacial pain practice will help you become a better clinician, because it will teach you what not to do. What were your mistakes up till now? What were you doing that was leading to failures in your dental practice? Now imagine a patient walking into your practice with a fractured prosthesis, often fracturing prosthesis. Only one side of the arch is in problem, like it starts with the premolar and it goes up to the molar region, and you are not aware why this patient is complaining of pain. So all these problems what we were facing up till now, orofacial pain as a specialty has designed or given us a platform which can help us and do a proper diagnosis and treat such patients. Now, what is this orofacial pain practice all about? Now, this is a very big umbrella under which is the screen visible? Is it moving?
It's not moving. It's visible.
It's not.
Okay, just a second. I think there is someone else also made as a presenter, the participant before me. Yeah. Now has the slide changed? Hello?
Yes. It
Yeah.
has changed.
So
Yeah.
for me, I would say orofacial pain specialty is a specialty that bridges the gap between dentistry and medicine. The time limit which is allocated for me to speak about such a big umbrella specialty is only 20 minutes. So I'll be just briefing you all what is orofacial pain practice and how you can incorporate it into your daily practice now. So what is the scope of orofacial pain practice? That the bigger umbrella consists of, first and foremost, most commonly seen disorder, that is a temporomandibular joint disorders, which may be myogenic or oromotor or having jaw behavioral disorders, neuropathic pain conditions, neurovascular condition, orofacial sleep disorders, or chronic orofacial head and neck pain. So we as a dentist have to understand the pathophysiology and mechanism of these disorders, so that as a clinician we can up our diagnosis and provide a forum or provide a better prognosis to all our patients. So now where do we start? The basic, what we had always learned in our dental colleges up till now was the history taking. So as a clinician, first you need to be aware of what is orofacial pain and how to diagnose it. Secondly, the history taking is the most crucial and important step, I would say, when you're practicing orofacial pain practice. So what comes under history taking? I'm sorry why the screen is getting locked again and again. Okay. The correct diagnosis of orofacial pain requires in-depth knowledge and history, and the history is taken from the patient. Ask multiple questions. At times, patient is not aware. He or she is a dentist. Why am I supposed to tell about all these points to the patient? To the dentist. I just have to tell few things that, okay, I have pain here and there. But you need to ask, where is the location of the pain? What is happening? Is anyone else also sharing the screen? Because I'm getting multiple errors here. Dr. Nurul?
I'm correcting. I'm just checking. Just hold on.
Because my screen is getting locked because of that.
No, it's okay. I think you do one thing. Could you please come out of the slideshow?
I'm not able to escape it also now. That is the whole problem, doctor.
You do one thing. Can you?
Wait a second. Okay, this is okay. Is this okay? Is
yeah,
it
it's okay. It's okay.
Perfect. Then I'll go it this way. Okay. So now we need to ask the patient the location of the pain. History taking is always as verbatim as what the patient can describe. Ask the patient to pinpoint the location of the pain. Ask about the onset, the timing, duration, associated symptoms, what increases or decreases the pain, and how the patient is describing this pain. So is it dull, throbbing, aching, burning, tingling, or pulsating? If you get answers to these questions, and you have come to a conclusion that the pain the patient is describing is non-odontogenic, you are almost sure of diagnosing the patient with orofacial pain disorders, and you're 50% sure if you have answers to all these questions. The location of the pain and duration gives you a crucial idea of the area involved, and the type of pain, like the dull, pulsating, aching, throbbing, will tell you more about the quality of the pain, and that will help you in your diagnosis. Now, once you have understood all these patterns, now you can easily translate this patient's history into 5 pathological findings or physiological findings, what we find. And you can easily term them as musculoskeletal, neuropathic, vascular, primary headaches, or mixed. So this is an in-depth study of orofacial pain. Once you do the study, then you will be able to understand how to diagnose these cases also and treat them. So as for a normal lecture of this kind, I'm just giving you all a idea how this classification works. So the central axis of classification of orofacial pain goes under 2 axes. Axis 1 is physical and axis 2 is psychological. So we'll be dealing with 2 most important factors or the conditions what we come across as oral physician. That is the musculoskeletal factors that comes under the temporomandibular joint disorders and neuropathic pain condition. Now, what is the importance of orofacial pain study? As I highlighted, it will help you to understand what not to do. It will help you to achieve an accurate diagnosis. It will help you to treat the patient systemically. give a predictable prognosis, and it will up the trust building factor in your practice. Now let's understand what neuropathic pain condition characteristics are. So hyperalgesia, allodynia, paresthesia, and dysesthesia. These terms itself are self-explanatory. And the moment you realize patient is showing any of these characteristics, so that is your red flag. Start screening the patient for neuropathic pain conditions. If you have not understood what neuropathic pain conditions are, you may also consult a orofacial pain specialist so as to give patient a proper care. Now, what does trigeminal neuralgia seem to us, or how the patient will explain it to us? It is sharp shooting pain. It is mostly unilateral, has a recurrence and remission period. Most of the patients will say that they feel the pain more in cold season or season wherein or conditions where it is very cold. They are sudden. There is no trigger. There are trigger factors for these pains when the patient feels them. Most probably the trigger factors could be as simple as combing the hair or splashing of water. I'm not very sure if we can call that idiopathic now, because pain conditions are very much, we can diagnose them very easily by doing an MRI. So in an MRI, we need to look for a neurovascular vascular compression, which is compressing the trigeminal nerve root. If the diagnosis, we have to reach to a correct diagnosis, this is very importantly crucial MRI findings. Now let's talk about temporomandibular joint disorder. These are the clinical representations of temporomandibular joint disorder patients. They will come to us with headaches, pain in the jaw while opening and closing, tender jaw muscles, jaw locking, jaw clicking or popping or sounds in the jaw, pain in and around the ear. They may complain of tinnitus or vertigo also. So these are the conditions which we as orofacial pain physicians are able to treat now, and that has up our practice. So this, what I was saying, that we have become a bridge between medicine and dentistry. This is the phase wherein temporomandibular joint disorder, if we decrease the symptoms, we are helping the patient systemically also. Now let's understand the pain of muscle origin, which is very common, and that is also our panel discussion after some time. So the pain of muscle origins are always dull. They are boring. This is the most common cause of all pains that come to us as orofacial pain. It is non-pulsating and may be variable and can include the head, neck, and face region also. So now let's talk about myofascial pain dysfunction syndrome. It is dull aching pain of variable intensity. It can decrease the range of motion of the muscle. That is the reason patient feels always weak or impaired, has impaired mood or decreased quality of life. Something very important when it comes to myofascial pain dysfunction syndrome are the trigger points. In patient with myofascial pain dysfunction syndromes, you will notice taut muscle band which are very painful or have some twitch-like response on stimulation. So this diagnosis is very important when you are treating patients with myofascial pain disorder. So as the moment you locate these points, your treatment plan is very simple, and you just have to target these points. These trigger points may occur because of overuse of any muscle trauma, or psychological stress. So in orofacial, talking about it as a dentist, we can talk about clenching of teeth or any parafunctional habit, repetitive parafunctional habit that can cause some trigger points. So as a physician, oral physician, we are supposed to identify these trigger points, and absolutely treating these points will decrease the pain in patients. So now let's understand most important factor of muscle. Yeah, are you talking something, doctor? Hello? Dr. Nooral? Yeah, I think there's some disturbance here. So let's talk about pains of muscle origin, and the most important factor, which as a orofacial pain diagnostics, is the site and the source of the pain. The site is to which the patient points out that, okay, I'm feeling the pain here. but it could be the source of the it could be the source of the pain, or it may not be the source of the pain. So as a physician, it is your responsibility to identify the source of the pain and manually or palpate the structure, and or by some other diagnostic tools reach to a conclusion whether the site to which the patient is pointing at is also the source of the pain. So this can be the most important diagnostic tool for orofacial pain practice. So these are the muscle referral patterns of all the masticatory muscles and the associated muscles of head, neck, face region. So this diagram is taken from internet. You all can also download it. The X represents the trigger points and the red area represents the area to which the pain is referred. So if a patient walks into your practice and you find that there is no odontogenic reason for the pain in the area the patient is pointing at, you as a physician should immediately look into the trigger points marked in the X region and find for a trigger point, or try to replicate the pain by stimulating those trigger points. If at all the pain is, if you are getting same pain response from the patient on stimulation of the points marked in X, those are definitely your trigger point, and that is all the area where you have to work on, and not the area to which the patient is pointing at. So here is a case. This patient walked into my practice complaining that she has pain in the upper left premolar region. But when I checked her or radiograph or intraorally also, there was absolutely no dental cause or absolutely no dental reason for which she should have had pain. So I started palpating her temporalis muscle. And the moment I reached the trigger point, she started pointing at the spot where she feels pain. Is it the same pain that you feel that you think? Where is the pain? Between these two teeth. Okay, so this is a very important, crucial diagnostic tool. This is a radiograph. Now, tips to reach to a diagnosis, like, how do we reach that you have come across a patient who has having orofacial pain problem or temporomandibular joint disorder problems. First is evaluation of TMJ and the mandibular range of motion. You can ask the patient to open and close the mouth and measure the range of motion. Check for sounds, pain, clicking, unilateral condylar movement, jaw deviation. Evaluation of muscles of mastication is most crucial. Identifying the trigger point and referral pattern, as I had mentioned earlier. All these things, points now should be into your screening. What do you call the history, whatever you take, or there must be some sheet which you maintain for screening of patients. These points are mandatorily to be considered when you're taking a history or doing a normal examination also, because if there is anything that is wrong in this zone and you do some dental procedure on the patient, you may land up having a very unsatisfactory result for both yourself and patient also. So now make it a habit of checking the temporomandibular joint as well as the muscles of mastication each and every time you check a patient. Check for parafunctional habit as well. So now another tip to diagnose, to reach to your correct diagnosis, if the patient is a orofacial pain or temporomandibular joint referred pain, patient is a diagnostic block. This is an article which I have published in Dental Reach, and there is a link given here. You can take a screenshot of the same, and you can you can easily read about the diagnostic blocks from this article. It is basically talking about how to elicit where is the source and the site of the pain. So the diagnostic block at the source of the pain will definitely keys the pain. So that is how you identify. So you all can read further about the same in this article. Now let's talk about how the clinical representation will be of pain of muscle origin. I'm going to be talking only about few things, that is protective co-contraction firstly, and myospasm or myofascial pain. Protective co-contraction, or in layman's term or in normal term, we can call it also as a trismus due to infection, trauma, or any other physiological condition which has resulted in muscle going into spasm, so much so that it has restricted the mouth opening. So what other systemic factors could be could cause more of muscle pain or myalgia pain or myofascial pain? Could be the vitamin deficiency. So supplementing these vitamins will definitely give a better result and better prognosis for the patient. Now, the role of muscle is the most important, and as a orofacial pain or TMD practitioner for the past 10 years, the most favorite muscle, if at all I have come across, is this lateral pterygoid muscle. The cause, at times, the cause and the effect and the victim is both this muscle only. And the most important, another aspect of our temporomandibular joint disorder is the articulating disc. We all know this 1 inch area just ahead of your ear is the problem creator or the victim of your sufferings. All the sufferings of temporomandibular joint disorders or orofacial pain practice are what are because of this 1 inch area, what you see here. Now, enough, I mean, as I had told you that I'm not into academics. So for me, definitions and talking boring about any stuff is very, very mundane for me. So I like to convert my topics into something that is more like funny or enjoyable, so that patients and as well as the students can understand. So now when I'm talking about mandible, so my husband is into corporate, and I have noticed that in all the corporates, they have someone that is a CEO and there are followers, this is resource team of his. So if this CEO is not happy or is attracted or diverted by some other factors or other company, or lured by other companies to go to or shift the job, most of his followers follow him. So in the temporomandibular joint disorders or orofacial pain, I call mandible as the CEO here. So this mandible, when not happy or when is lured by way of spasmodic muscle, lateral or medial pterygoid going haywire, and only unilateral pains in those or spasm in those muscles, dentition going haywire, whatever may be the cause, once this CEO, the mandible, starts moving towards one side or one side of the face, whole armamentarium, along with it, that is the masseter muscle, the mentalis muscles, or the soft tissues, or the dentition will follow the mandible. So this is what I have noticed, and this theory is very much into action, and we have done many cases just by balancing this mandible into place. That is, the CEO of this company has to be relaxed in an environment wherein he is happy. The moment mandible becomes happy, all the structures and all the followers with him will come into balance. So this picture is enough to tell you, if the mandible is shifted to one side, that is the left hand side, all the muscles, all the soft tissues, everything will be shifted towards one side. You have seen such patients. So when a patient walks into your practice and you see some amount of discrepancy or asymmetry in the face, that is your red flag. This patient has some amount of temporomandibular joint disorder, which the patient is unaware of, or you as a physician have to make the patient understand and educate him that he may land up with this and this problem in future. Now, if I talk about these were pictorial representations. So when I talk about, if you see them in the patient, now this patient, this mandible has shifted to the right hand side. So imagine there is some amount of open bite on the left hand side. Now these teeth on the left hand side will try to meet. Initially there will be some amount of open bite, that will be 1 millimeter or 2 millimeter. But over a period of time, these teeth will start on the left hand side will start extruding. The teeth on the right hand side will start intruding because overuse of the muscle and the joint is happening over there. The facial anatomy, the nasolabial fold, the nasal septum, the lip, the commissioner line, everything will shift towards the right hand side. So the CEO is not happy, the mandible is not happy, whatever may be the reason, and it has taken along with it its followers. So all the muscles, soft tissues, everything has followed this mandible and given the facial structure to this patient like this. And mind you, you may find, is it really possible? What is she talking about? But when you see the patients from tomorrow onwards, try and analyze each and every patient this way. That's what I said. I'll be converting everything in a funny way so that the diagnosis is reached very easily for you guys. So start analyzing every patient. Has everything shifted to the right or left or upward? Upward may happen as in everything will be in upward rotated case, like, the patient, all the features are as if the face is flat, only the mentalis and masseter hypertrophy is there. So start analyzing these patients in this format. You will be surprised that how this study will also help you do your FMR cases in a very correct way, because you will know how to balance these patients. You just have to balance the mandible, the muscles will follow, the soft tissues will follow, the dentition will also follow. And if you perform any orthodontic treatment on such patients also, you will never require a retainer to retain these teeth, because they will be in a balanced position. So now let's talk about if this cobweb-like effect happens on the mandible and changes the mandibular position so much, definitely all the other muscles of the body will follow suit. So this is a different topic altogether, and it requires a different kind of specialty to understand. But orofacial pain practice can give you the judgment to understand why the other body muscles can also follow the mandible. So any misalignment with the mandible will result into all the other muscles following the mandible toward the same side and causing myalgia pain all over the body. So as a clinician, we just have to balance the mandible. Muscles will be in harmony. Everything will turn out good. So now let's talk about a clinical representation. This is a case of a 21-year-old female who complained of stiff jaw, pain on the lower left jaw for the past 5 to 6 years, restricted mouth opening. She had reported habit of nighttime teeth grinding, sensitive teeth, and bulky angle of the mouth. This is what the patient has said. As I said, take the case history, or the history is always taken in patient's words. So what do we see here? Once the intraoral pictures are taken, she is a patient of deep bite. That means her mandible has already moved out of the fossa and is somewhere ahead, or maybe just at the eminence already. So when she tries opening the mouth, the muscle is already into spasm, because the mandible has already moved away or ahead of the fossa and nearing the eminence, or maybe ahead of eminence. This is the intraoral picture. If you see, she has lot of adhesion. She also said that she is a night grinder. So all her teeth are treated upper and lower arch. And this is what is her radio OPG. And you will see hello.
Yeah, you're audible.
Yeah. No, I got a message that we are starting in 5-7 minutes. So that's the reason okay, I guess maybe some other message then. Okay, so I'm sorry for this halt or pause here. So now when you see this mandible, what I was talking about, that it has already shifted or ahead of the fossa, it is already near the eminence. That is the reason this typical presentation of deep bite in this patient. So what we need to just do is balance this mandible in a way that we get for the patient to ease the habit of bruxism, as well as start her with some orthodontic treatment, and then cover the restored teeth surface. So what we need to do first is identify the trigger points and administer trigger point injection or localized pressure therapy, my favorite one actually, and appliance therapy for muscle balance and parafunctional habit, that is given for 3 weeks. So this was her earlier condition wherein the mouth opening was very restricted. Thereafter, after doing these two, that is administration of the appliance and trigger point pressure, localized pressure, and something that is called as deprogramming, that is also part of some other lectures summary. But this is what was the result, immediate result within 5 to 7 minutes of her first initial deprogramming. And then we gave her an appliance which she used for 3 weeks. After that, we started with orthodontic therapy for correction of deep bite, and then we reconstructed the lost tooth structure with composite. That was first for the test drive. This is a composite build-up case. Later on, she will be shifted to a permanent rehabilitation with ceramic or the choice of material. And then something that actually home care starts on the day one when the temporomandibular joint disorder patient comes to us. So CBT and home care is what we administer to these patients. So now this is what is the case now. What the patient walked into our practice with was mentalis hypertrophy. Pronounced mentalis hypertrophy is reduced, lip appears to be fuller, patient is free of pain and jaw stiffness, bruxism habit is ceased, occlusion is improved. Okay, now path ahead. I'm going to be talking a step beyond orofacial pain practice, what you as a dentist can achieve within a week or 2 weeks time. This case wherein you will see what I was talking about, this patient's mandible, the CEO of this whole armamentarium of temporomandibular joint, the CEO has walked away towards the left, taking with it all the muscles and the soft tissue and the dentition, compressing the eye, compressing the nasolabial fold. The commissure line is also raised high up onto the left side. By just balancing, I have not injected anything to this patient. I have not done any surgical therapy. By just balancing his mandible, by balancing his muscles, we were able to achieve this kind of result within a span of 2 to 3 weeks. So this is how you can, as a physician, change the life of the person. Not only in young patients, but patients who walk into our practice without teeth. This gentleman was very, very depressed. He came to me saying that just give me something so that I am able to swallow something. I have gastritis issue. I cannot walk properly. Once we started our therapy for temporomandibular, as you notice again, though he is a edentulous patient, all the muscles have followed the mandible towards the right hand side. So we just balanced his muscles. This was the day we gave him the denture. This was the day we started his deprogramming and giving him denture. And this is on the day 21. He came to me, a 10 person who was very dull. He was hopeless with his life, was now walking 10,000 steps, is happy that he's able to eat everything properly. But most importantly, he said he looked 10 years younger. This is all possible under the preview of orofacial pain practice. You as a clinician can become a physician by altering the patient's life and giving a better life quality to the patients. So I'm just leaving you with a thought that time has come to become from a dentist to become an oral physician now, and start doing this kind of practice. Incorporate temporomandibular joint screening into your daily practice. You will be benefited a lot, and you will benefit the community also a lot. So I conduct small courses also. I'm not very much into teaching, but if you all are interested, you can come. We can keep a small little lecture or course for or hands-on for 4 or 5 days. So this is me. I'm Dr. Sonal Yerpude, and my specialty now, I was a general practice up till now, but I plan to become a orofacial pain physician and provide therapy or help to all the patients around here. I hope this lecture was something which you will take home, some positive aspects for orofacial pain practice, and get back to me or network with me in case if there's any issue. Thank you, Dr. Nooral, for inviting me to this forum, though I'm not an academician, but I'm glad I was a part of this team because it was enlightening for me also. So thank you so much. Thanks everybody for listening to me. Thank you.
Thanks, Dr. Sonal. It was really a very enlightening session, and you have thrown a lot of light on multiple aspects of oral facial pain and all. It doesn't matter whether you are academician or you are clinician. It is depend upon how you are interacting with patients and how you are accumulating all the data from the patients, and you are analyzing, and then you are concluding something. So it's a nice presentation, and you stay with us, Dr. Sonal, because we are now moving towards our panel discussion. And because Dr. Mansi is not available, so I suppose to introduce Dr. Cheena. Dr. Cheena Singh is chairing the session of this panel discussion. Dr. Cheena, are you there? Could you please unmute? Yes.
Good evening, sir. I'm here.
Yeah. So Dr. Cheena is Associate Professor in Department of Oral Medicine and Radiology in PGIDS Rohtak. and she is a postgraduate in oral medicine. She's already done fellowship in forensic odontology, certificate and fellowship in oral facial pain, sleep medicine, and TMT disorders from Smile USA, and then pursuing PhD from Desh Bhagat University, Punjab. She is member of medical board of PG at Rohtak. She did diploma in cancer nutrition as well, treating patients with oral facial pain, TMD for past 2 years. Active in doing reporting of many cases of age estimation for forensic odontology and all. So over to you, Dr. Gina, to the panel discussion. I think we have all the panelists with us. Dr. Shaili is there. I'm just being Dr. Sonal is there. Dr. Pavani is there. I think Dr. Indra would also. I just saw that she entered in the room. Dr. Indra, are you there? Yeah, Dr. Indra is also there.
Yes, I'm there.
Yeah. Okay. So over to you, Dr. China.
Thank you, sir. First, proceeding to our main motto, I would like to thank National Health Academy and Dr. Nural sir for giving me this opportunity to be a chairperson for a panel discussion. Sir, I am very happy to say this, you all on every Women's Day you give us this golden opportunity to all the women on the dentist, my seniors, to see on the platform to see how we are working. At least we have a 1 hour to see all the seniors, my seniors here on the screen. Otherwise, we don't have time to see their faces. So, sir, thanks for that, sir. So, before proceeding to the panel discussion, I would like to introduce all the panelists. So, I'm sharing my screen, sir. So, hope slides are visible, sir.
Yes, visible.
So the discussion for today's, the topic of discussion will be myofascial pain syndrome, a multidisciplinary approach. Before proceeding, I would like to introduce Dr. Shaili ma'am. She is an academic, she is a orthodontics basically who makes our smile more beautiful. She is working more than 50 years of the time at RML Lucknow, and so she has done standard competency course in laser from University of California, San Francisco. Thank you, ma'am, for here. Then I think
Dr. Gina.
I think Dr. Sonal need not any introduction because she is. We already got an introduction from her side. She is a private practitioner and working for the TMJ and orofacial pain and treating the patients of the same specialty from a periods of 10 years. She has done the fellowship in the orofacial pain sleep medicine from Rutgers University, USA. I am very happy to introduce Dr. Indra ma'am. She is an associate professor obstetrician at All India Institute of Medical Sciences, Patna. She is serving more than 15 years to this field and have more than 40 publications with lot of the awards. Then I would like to introduce Dr. Janab ma'am. She is a professor in the oral surgery at Maulana Azad Institute of Medical Sciences, New Delhi. She is teaching for more than 14 years to the postgraduate and undergraduates in Delhi. Her area of interest is maxillofacial pathology, reconstructive surgery, trauma and lasers. Then I would like to introduce Dr. Debashri ma'am. She is an associate professor in the Department of Psychiatry at Jawaharlal Nehru Medical College, Aligarh. Then I would like to introduce Dr. Pavani. She has done her postgraduate in prosthodontics, and right now she is serving more than 6 years in the same field in Hyderabad. So we may, before proceeding, I would like to throw a little light, although it is, I don't feel any need after listening Sonal ma'am lecture, but still as orofacial pain patients come to our departments of orofacial pain, they suffer for a myofascial pain distress syndrome with or without referral. They have generalized pain in the form of fibromyalgia. Then in the preauricular region, maybe the temporomandibular joint with reduction, without reduction, trigeminal neuralgia. They suffer from headaches, burning mouth syndrome may be primary and the secondary. Here I am sharing the patients, my happy patients. So I'm sharing their video after obtaining consent from them. She suffered from preauricular tenderness. She feel very much relief from the treatment given by our department. I give her the anterior reprogrammer as she suffered from retrodiscitis for 3 weeks with NSAIDs. 3 weeks. And she got relief from this treatment. Then this is my second case with the diagnosis of masseter trigger point myalgia, left side. I gave a chair side diagnostic block to her to the trigger points. I did the dry needling basically to the trigger point, and she got relief from those. And this is a case of awake bruxism. Listen the voice of the grinding. I gave hard spleen to the patient along with carbamazepine and clonazepam, and he got relief. Then the third case of subluxation. He gave the history of subluxation. Patient need assistance to correct his mandible. And this is the case of the trigeminal neuralgia. Electric current like pain. So all the patients were relieved by the proper medication, and before that proper diagnosis is very important for treating the orofacial pain. This is the book which we all can refer for the trigger point myalgia. In this book you can get a various referral point so that you know will not confuse with the odontogenic origin of pain and myogenic origin of pain. After finishing this panel discussion, I am pretty sure we all will able to understand what is a trigger point, its etiology, dry needling, and what gauge of needle we should use, and where we should give indication and contraindication of the trigger points. Over to the panelist. Would like to start from Shali ma'am.
Okay.
Ma'am, please, ma'am, throw some light on the myofascial pain distress syndrome, ma'am.
Okay, so thank you so much, Dr. China. I think you're doing excellent work. We were supposed to meet, but due to some reasons, but we'll be meeting in future. But what lovely way of interacting like this. And I'm really in awe like the way you are doing. So I would get to learn so much from everyone in this. So coming to like orofacial pain and all that, it will be like, first, I think we can go ahead with the classification of it, like what exactly is the classification? Like you've already put forward, like it can be osseous and, it can be neuralgic also, and it can be some atypical. So usually I would like to classify them as it can be like somatic and neurogenic and also psychogenic. So it can be, superficial as well as deep if we go for somatic ones. So it can be leading to just the skin or maybe the mucogingival. And if we go into deep, it can be originating from osseous or maybe, muscles, or it can be having from the periodontal ligament, or it can be visceral also, which can be originating from the pulp gland, eye, ear, those kinds. And it can be neurogenic as well. like it can be episodic as well as continuous. In episodes, we have seen, like you mentioned right now, trigeminal neuralgia, or maybe because of herpes or Gasserian geniculate herpes, like, those kind of things, Bell's palsy for that matter. How can we forget that? And or maybe it can be just, the range is so wide, it can be some tumors also, some malignancies which will not be able to, like, make out. So it can range, it has a wide range of, so knowing etiology of each and every one is actually very important, and can range from migraine. Like the patient will just come for, pain, and you would see all the teeth and everything, but nothing is actually seen. So only when the mind doesn't know, the eyes don't see. So when you will be able to see them and you will know them, only then we can be able to, categorize them. And some of the pains can be psychogenic as well, like which do not have any etiology, but they're just psychological, like atypical for that matter. Like you just mentioned burning mouth syndrome, or maybe, this glossodynia, stomatitis, all these things are the ones which are referring to that. And the pain etiology is also like something like, it can be superficial, which can be burning, piercing, you just mentioned current like, or is it dull, aching? So depending on that, I think we can move ahead with the other etiologies as well. So this will help us in classifying that.
Yeah, well explained, ma'am. It was well explained, ma'am.
Dr. China, sorry to interrupt you. Could you please, stop sharing the slides so that all the panelists would be better visible to our spectators, those who are viewing us.
Sorry, sir.
Yes, now it's better visible to all. Yes.
Ma'am, can you please tell something about the low laser therapy? Nowadays, it is in very trend, the laser, ma'am. Low level laser therapy is there, ma'am. Triple LT, ma'am.
Okay, so actually low level lasers are actually, I just did a small presentation in the afternoon session. So basically we have surgical lasers and non-surgical lasers, and depending on hard tissue or soft tissue. So there is one more category as, low level laser therapy. So it can be like, in a non-contact, I mean, I am not sure like whether we are aware of it or not. Usually lasers operate in different wavelengths. So there is a special category of lasers, like a lot of sports people used to use that Thor laser. So it is very much mandatory in sports that a lot of them use for muscular rejuvenation and all that. So low level laser has got, either a biostimulatory, regenerative, anti-inflammatory, you may say so, or analgesic effect as well. So it just depends upon what kind of, what we are aiming at, because it can lead to acceleration of the healing. It can lead to decreased inflammation or pain alleviation. So what happens is when the laser light falls, there are photons, they're basically photons. So whatever our body has, cells have got mitochondria. So they have cisternae and all the inner lining. If I'm not going into too much of details, it will be like the energy is actually absorbed by the photons. And what happens, it leads to the generation of ATPs, so which are the powerhouse of the cell. So what happens is there is also some neural effects as well with that. So it leads to hyperpolarization of certain neurons, which leads to, liberation of vasodilators like sodium oxide, nitrous oxides, or for that matter, or maybe histamines and all. So all these leads to, vasodilation. So that is probably, and when we talk about MPDS and all orofacials, the main problem is the edema or maybe the inflammation which is there. So that is actually healed by the vasodilation effect of this. So we have to, how does it work is because of vasodilation and because of the neural depolarization, there is a certain release of, vasoactive like serotonins and histamines and endorphins. All of them are liberated, and the postgranulins and all that, they are the ones which are liberated, will lead to vasodilation. And probably like that is one of the, but still a lot of studies are still going on, for finding out where the trigger points are. So you can basically say that the trigger points and the acupressure points, they are also the ones which are actually coinciding with each other. So it can also, lead to certain anti-inflammatory effect and dilation of those vessels.
Basically, for the purpose is the vasodilation, so that all the
Yes.
algogenic products will be washed out from that area, that
Yes.
particular trigger point. Okay.
Yes.
Thank you, ma'am, for throwing the light on for today's panel. But stay with us, ma'am. You may contribute in between. Stay with us.
I am there. Yeah.
Now, I would like to put question from Sonal, ma'am. Good evening, ma'am. Sonal, ma'am, can you please put some light on the how can we treat the these things more efficiently, and what treatment can be the more convenient as a pocket friendly for the patient, ma'am? Convenient for the patient, ma'am.
Okay, so first and foremost, I would say you need to understand what is orofacial pain and what is the causative factor there, what the patient is undergoing. Now, suppose if it is a temporomandibular joint disorder and if it is myofascial, if it is of the muscle origin, you need to identify what muscles are the ones which are in contraction phase or which are we need to treat upon. Okay, so you cannot just blindly go and do something like, take an injection or do a trigger point by listening to this lecture. It is a theory by which you need to understand that it is not something that a patient will tell you that, okay, I'm having pain in this region and this is how the pain is depicting. You are the one who is going to identify these causes. So now coming to the treatment options, I am a very conservative person, money wise also and treatment wise also. So if something that has to be pocket friendly, that term you use, and I really love that term because I'm confused. So when it comes to, if I'm a person, if I am there, if I have to do treatment for myself, that treatment has to be effective as well as something that is sustainable also. I cannot give some appliance or some therapy, or I cannot suggest something to the patient which is out of the world expensive, or which is going to damage the patient or create more problems for the patient, or be so expensive that the patient denies the treatment. So our procedure has to be in accordance with the socio-economical status of the practice area where we are practicing. So most importantly, if you have understood orofacial pain, like what Dr. Shelly Mahajan was also saying about laser therapy or the acupressure point identification and all that, those are all manual acupressure point manipulation and all are, or deprogramming are all manual. They don't require any other equipment as such. Now there are scans and there are major instruments or equipments available in the market which are very expensive to help you to reach to a diagnosis. But ultimately, when you start doing the procedures on the patient, you need to identify which is the procedure which you are expert at. Don't try to attempt something from something what somebody has done. So the procedures, one thing is appliance therapy, which can give some amount of relief, but again, it is a temporary relief. Medications, of course, even the patient can take them over the counter. So what you need to identify is what medications are going to help the patient without damaging, creating further damage to the patients. And third most important thing, chart out a treatment plan which is more sustainable. The patient has to carry out this treatment plan, the exercise routine or CBT therapy, or even if we tell them hot or cold fermentation to the patient, normal therapy for muscle aches, what we start with. So those treatments have to be in accordance with the patient's understanding. And for me, I believe in non-surgical approach. If it is something to do with ankylosed joint or something which is very bad pathophysiology is involved in it, then only I would be suggesting to go for a surgical approach. Otherwise, there are various appliance therapies available. Of course, appliance therapy is a very debated term right now. Everybody has their own ways and means of designing the appliance, making or prescribing the appliance. So what needs to be done is you need to be expert at something so that you can deliver that therapy to the patients. So follow a therapy or a pattern of appliance making, or maybe a procedure or deprogramming procedure or steps wherein you are helping the patient understand the etiology behind the whole problem. so that you can plan the prognosis and ultimately plan for a treatment which is foolproof and will give you a further prognosis. The basic thing over here is prognosis of the patient. So first thing is, my take would be first and foremost relieving the patient of the pain. Appliance therapy for a while, that is again we need to and do something that some changes. I won't say you need to do every case is not an FMR case, but if you balance the muscles and give a proper dentition or give proper canine stops or give proper occlusal stops to the patient, these things also will relieve the patient of regular TMD problems or pains. And if it is a neuropathic pain conditions, then there are medications which we have to slowly titrate and prescribe to the patients. So thorough understanding about these factors is important. And if it is psychological, so now as in when I would say I'm still at the tip of the iceberg. You told me that when you told me, I understood that, okay, I've been into orofacial pain for 10 years and now clinical practice for 20 years. All these are just numbers. When you see the orofacial pain books and the kind of knowledge that is being shared, we are still at the tip of the icebergs. So the research work is still going on. So I would just say, try and understand the etiology and the patient's needs. Is first thing first is what you have understood from the course or whatever fellowships or programs you go ahead with. You need to follow that procedure. You need to follow a therapy which you will be able to deliver to the patient, because there is no standardization as of now. It is not like a root canal treatment procedure wherein we do follow certain BMP steps and we follow certain prosthetic steps. Temporomandibular joint disorder treatment plannings are still evolving. So one specialty may say, okay, you can follow this treatment and reduce the pain. You can follow the appliance therapy and reduce the pain. Some people are against appliance therapy. So there are many modalities. So one modality, choose a modality which you can practice in the area and you are able to provide better relief to the patient. There are many things available. Choose what is best for you and your patient. That is what is my take on it.
Yeah, thank you, ma'am. So treat the patient as you are treating your relatives. I think so.
Yeah, that is for everybody. That is not only for orofacial pain.
Yes, for every problem, just treat like them. They are ours.
Yes.
Until unless we don't have these feelings, we can't give our 100% to the patient.
Of course.
Okay. Thank you, ma'am. Now, just moving to the Deboshri ma'am. Ma'am is there?
Dr. China, Dr. Deoshri is not available.
She wants to get admitted. Just check.
Yeah.
Dr. China, she is not available. You can take to Dr. Indra or Dr. Pavni or Dr. Zainab.
Okay, Dr. Indra. Okay, sir. Okay.
Dr. Indra is there, I think. Yes, yeah. She has opened this camera.
Okay. A very good evening, ma'am.
Yeah,
ma'am. Ma'am, I would like to ask you, ma'am, please throw some light on the role of the OBG, ma'am, in myofascial pain syndrome, ma'am. Ma'am, how the patient, how we can relate these two things, as Sonal ma'am has told, the orofacial is between dentist and the medicine. Ma'am, now I request you to please throw some light. How can we this speciality be related to the myofascial pain, ma'am?
Actually, I was very surprised when Dr. Nurul gave me, he told me to be a part of the panel, because orofacial pain with OBG is generally not an associated thing that we normally feel like. Then I went through the literature and then found out few articles that yes, certain, because we have in our specialty, hormones are very important, because all the menstrual cycle, infertility, menopause. I mean, women throughout her years of from her menarche to adolescence to reproductive age group to the perimenopause, postmenopause. I mean, her health is actually controlled by the hormonal balance. And many of our relatives only maybe advised or told that आपको hormonal imbalance है, इसलिए this is happening or that is happening, or there is a PCOD on the ultrasound, or she is not able to conceive. So many things. So similarly, these hormonal imbalances actually causes joint pains, non-specific myalgias, and women do come. But mostly they come with backache that generally I see. It was only once I feel that she was more concerned about her myofascial pain, dental toothache, and some facial pain, for which I referred her to the dentistry department for her further evaluation. Probably I thought maybe there is some problem with her teeth and she needs to get herself evaluated. But then basically what is written in literature is that metabolic hormones that control the metabolism, especially the thyroid hormones, and metabolic syndrome like in diabetes and insulin resistance, all these conditions cause a hormonal imbalance. And mostly it is the estrogen hormone. Basically, it is a protective for for inflammation. It is anti-inflammatory. Somehow it helps in controlling the inflammation. So when estrogen levels decrease, especially in the perimenopause and postmenopause, so there will be increase in inflammation, and there will be joint pains, backache, and non-specific myalgias, and even this myofascial pain syndrome may be one of part of that. And thyroid hormone has been associated with mitochondrial, oxidative de-stressing hormone. Actually, those who have less of thyroid hormones, they will have more of oxidative stress in the body. And there is a disturbance in the glycogenolysis, increase in insulin resistance. So all these things also causes increase in inflammation in the body. So of the various joints, even this temporomandibular joint can also have this pain, and they may present with that. So generally, and yes, vitamin D deficiency, folate deficiency, and we do give a lot of folate to our pregnant women. So the reason for that folate is obviously preventing neural tooth defects in the baby. But folate deficiency and vitamin D is especially again an antioxidant hormone. So that is also associated with joint pains and orofacial pains. So basically from OBG point of view, I would say that many women will come with no specific complaints, actually generalized body ache, joint pains, of which temporomandibular joint is also sometimes a part. So we need to think that maybe estrogen supplementation for some time, if they are fit for hormone replacement therapy, giving some vitamins, especially vitamin D, supplement with folic acid, and evaluate them for diabetes and thyroid are also important. So that's all I think from OBG.
Ma'am, one question I would like to ask, ma'am. Ma'am, do estrogen similarly play as of the myofascial, ma'am, role in the premenstrual migraine, ma'am? Or there is something else is involved in that, ma'am? Perimenstrual, premenstrual migraine, ma'am. Few young ladies or few of the chronic migraineurs, ma'am, they suffer from this problem. 2 days before, 2 days after. Yes, ma'am.
Yeah, actually in premenstrual pain, the main factor is the release of prostaglandins. When so that is causing the pain, and that prostacyclin cyclooxygenase pathway that gets stimulated. So those are and especially the ovulatory cycles. Therefore, we said mostly the ovulatory cycles are painful. So and before because of the increase in the progesterone, because it's a secretory phase, the post-ovulatory phase is the progesterone, increase in the progesterone. So there is bloatedness and increase in weight, fluid retention. You feel like the weight gain ho gaya hai, and that kind. And yeah, and it is the opening of the internal os of the cervix that is painful. So once the flow begins, then generally the spasmodic dysmenorrhea will gets relaxed. However, if there is more inflammation, PID or endometriosis, other reasons for inflammation is there, so then the dysmenorrhea will continue. So that is a different reason why, because those inflammation is continuously there. But only if the menstrual cycle is responsible for dysmenorrhea, it is basically the release of the prostaglandins and these prostacyclins during that time. So not the estrogen.
Okay, ma'am, it means the prostaglandins, it doesn't play any role in anti-inflammation, ma'am. Does it have, ma'am, as the estrogen, ma'am?
No, they don't have a role. Okay. They don't have a role in anti-inflammatory. It's the estrogen which is found to be, protective. from inflammation. That is why they are important for bone health and cardiovascular health, and that is why after when we do hysterectomy at younger age, less than 50. Internationally, some guidelines say that it is around 55 or 60 that we should remove the ovaries. But in India, we generally practice 50 because our average age of menopause is around 48.5. So after 50, ovaries are already not functioning. But before 50, for any reason, we are doing the hysterectomy. So it is only the fallopian tubes are removed along with it if the ovaries are healthy. Unless and until there is an ovarian cancer or ovarian cyst or they are not healthy looking, then we are definitely removing it. Otherwise, we have to keep for any benign reason like fibroid or something. We are doing hysterectomy. Then we leave the ovaries if we are doing it because they are producing estrogen.
Ma'am, thank you, ma'am. Just giving us so much of the knowledge, because few doubts I do have been cleared now, ma'am. Thank you, ma'am.
Dr. China, one thing I would like to add here. Last year, Dr. Indra was a part of the panel discussion, and this year again, why we are calling her again and again, because her younger sister is doing her BDS final year, and sisters have a very good relation with each other. They are sharing everything to each other. So I think Dr. Indra have better pulse of what is happening in oral health and all. So that's why she is one of the panelists here. Last year we have discussed about cleft palate and cleft lip, and again this year we are talking about MPDS. So that's why I have invited Dr. Indra. Thanks, Dr. Indra, for joining.
Definitely very important, I would say, and this is one thing that because I have one patient with a growth in the lip, and he is not able to take anything, maintain dental hygiene for around 6 months. All the teeth have gone, not able to eat properly, so he's lost around 30 kg. So the growth is just a wart on the lip, no cancer, nothing. So what I mean to say is that though we may overlook over oral health and but this is a very important part, and maybe needs to be looked into with much more seriousness by all other specialties as well, and should a routine antenatal screening also, because even any problem in the oral health can cause early preterm pains and many things in obstetrics also.
Yes, ma'am. Thank you, ma'am, for telling us too much about the relation between the OBG and our facial pain, ma'am. Thanks a lot, ma'am. Now moving to the Pamni, ma'am. Pamni, ma'am, can you please tell something about the how can we relate the occlusal with this orofacial pain, ma'am?
Thank you, China. I would like to thank National Health Academy and Pink Dental Congress for putting up this program. And without a delay, I like to talk about the occlusal rehabilitation or occlusal adjustments related to the myofascial pain. There is no doubt that occlusion is utmost important in restorative and prosthetic dentistry. But the question remains as to the relationship between the TMDs to the occlusion or malocclusion, or myofascial pain to the occlusion and malocclusion. Why? Because I want to share my screen. China, can I share the screen?
Screen is not visible.
Host should disable the participant.
Dr. Noble Lindu.
It's okay, no problem. If possible, just allow me to share the screen.
Dr. Noodle.
Then I have sent the PPT to you now. You can share, I guess.
Okay.
Just place the third slide. Sorry.
Is it coming? I'm sharing now. Sharing now.
Yeah, third slide, Srina. Third.
Sure, ma'am.
Because
slide visible, ma'am?
Yeah, visible. It's not in the full screen. Just put it in the full screen. Then second and then fourth. Like.
Sure.
Yeah.
Visible, ma'am, now?
Yeah. Because the question reminds us to the relation between the TMDs and occlusion, I would say it's S. One of the most common factors for the causing myofascial pain and etiological factors for the myofascial pain dysfunction syndrome is the occlusal discrepancy. Because it's a vicious cycle, the occlusal disharmony may lead to the altered chewing patterns and contracture, that is the permanent shortening of the muscle, which can be altered with the physiotherapies, other surgeries. But even though it is a can be corrected by the surgical, even though it is a permanent shortening, and all these leading to the myofascial pain. Second slide. So we don't have any particular investigations to diagnose whether it is because of the occlusal discrepancy or any other factors. But we have one criteria that can help us to do treatment for the myofascial pain related to the occlusal discrepancies. That is the Laskin's criteria. It has two criteria, positive criteria, Laskin's slide. Two. China, second slide.
Dr. China, please.
Yeah, that is Laskin's criteria. In Laskin's criteria, we have two positive and negative signs. If patient reaches the patient full signs fulfills these criteria, either positive and negative both, then we can consider the occlusal therapies or occlusal rehabilitations to reduce that, to manage the pain. According to this, the positive inclusionary criteria are unilateral preauricular pains or muscle pains and palpation. As the Sonal ma'am said, we can consider the trigger points and joint noises and limited mouth opening cases. But negative exclusion criteria, when we want to do the occlusal therapies, is no joint tenderness when palpating through the external artery meatus, because it is related to the anatomical discrepancies. It's not related to the muscles or other than occlusal discrepancies. And other criteria is no clinical or radiographic or biochemical evidences of organic joint disease. That means no anatomical joint disease. It should be like a muscle problem due to the occlusal discrepancies. Next. The etiological factors may be occlusal disharmony, either due to the static, like in maximum intercuspation, we have single high point, like first point of contact, either due to the because of the natural teeth or any class 1 or class 2 restoration or any prosthetic restorative restorations like crowns, veneers, any onlays, inlays. That is the occlusal disharmony. And other etiological factor is parafunctional habits like bruxism. Bruxism either due to clenching or grinding or tapping. All these factors may lead to the disturbance in the stomatognathic system. Our aim is to stabilize the stomatognathic system. So all these are possible with the diagnostic mountings. First, we have to do the diagnostic mountings. Then we can come to know whether it is because of the occlusal disharmony or any other parafunctional habits. Parafunctional habits also we can diagnose with other signs like muscle tenderness, soreness, and occlusal pattern awareness also we can see in bruxism cases. But in case of occlusal disharmony also, we can see the wear facets. When it is a chronic case, then only we can see the wear facets in occlusal disharmony cases. But in case of bruxism, we can see the generalized wear facets. There is no functional and non-functional cusp. All cusp will be worn out in the case of bruxism. Now coming to the occlusal therapies. Next slide. Occlusal therapies, different treatment modalities for the occlusal therapies is RRR technique, that is triple R technique we call it, that is reduction, repositioning and restorative. We can do the reduction if the occlusal discrepancy is mild, that is, if the discrepancy is away from the central fossa, the first point of contact is away from the central fossa, then we can do the reduction, that is the mild case. If it is in between the central fossa and tip of the cusp, then we can do the repositioning, that is ortho. We can manage with the ortho, so that we can achieve the stomatognathic equilibration. But in case of the discrepancy is the first point of contact is really near to the fossa, we can't do any reduction, we can't do orthodontic corrections. In such cases, we have to go with the prosthetic correction, that is irreversible restorative procedures. Even though is ortho and reduction are irreversible, but prosthetic correction is more irreversible, more extensive, invasive process. So in such cases, we can do only prosthetic crown or onlays, inlays and veneers, so that we can achieve the occlusal equilibration. In other treatment models, but the occlusal adjustments, according to the recent published research, comprehensive reviews and clinical experiences, irreversible occlusal adjustments and rehabilitations as a treatment therapy is contraindicated. As Sonal ma'am said, most of the clinicians won't accept the occlusal reductions and irreversible occlusal therapies for the myofascial pain dysfunction syndromes. We can use it for other treatments, but not for the myofascial treatments, because it's an irreversible procedure. And also the most of the occlusal adjustment may induce pain relief, even though they induce pain relief, that means they relieve the pain also. We can't suggest the patient to get the occlusal adjustments done, because there is no evidences that there is no advantage over any other conservative and reversible therapies for the occlusal adjustments. So occlusion plays a minor role in myofascial pain, not a complete role and like major role. It has a role, but it is minor role only. So therefore, the etiology in a treatment of temporomandibular joint disorder and myofascial pain, we should consider other causes, etiologies and other treatment plans along with the occlusal adjustments by using the triple R technique. And next treatment modality is splints, occlusal splints. Whether we can give soft splint, hard splint, and other combination of the hard and soft splints. It is based on the material. And other is depending upon the function of the splint, that is stabilizing splint, which is used for the stabilization of the occlusion, that is we can maintain the equilibrization of the occlusion, and other is repositioning splints. So the exact mode of the splint is not known, but the efficacy of the splint can be a placebo effect or any anticipation effect, and possibly involving some behavioral modifying properties. The effect, the function of the splint can be a placebo or anticipation, or possibly involving some behavioral modifying properties. But recent studies suggest that splint therapy, whether high cost or laboratory process splints or chairside thermoplastic splints, nowadays we are fabricating the thermoplastic splints, and often no significant advantage over other conservative self-cares like including jaw relaxations, conservation and reduction of parafunction thermal packs, physiotherapy and stress reduction and use of analgesics. So these are all like alone we can't, alone with the occlusal rehabilitation therapies, we can't treat the myofascial pain. We need more longitudinal studies actually. Next slide. We need more longitudinal studies to pave a road for the further insight into the myofascial pain.
That's what I want to tell you. Thank you, China. We can't hear you, China.
Dr. China, unmute yourself. Please unmute.
Unmute.
Yes, yeah.
I would like to thank Dr. Pavni ma'am for telling us so much about the relation between the occlusal rehabilitation and between the oral facial pain, ma'am. Thank you, ma'am. Now I would like to invite Dr. Janib ma'am for the contribution of a oral surgeon, ma'am. Ma'am, how can be oral surgeon can be contributed in the MPDS, ma'am? Because I saw very much cases of a contracture in which, ma'am, we have to do the active mouth opening. The muscles are too rigid, we can't open them, ma'am. Please throw some light, ma'am. How can we treat these cases and the aspect of the oral surgery, ma'am?
Thank you, Dr. China, for giving me an opportunity here to speak about the surgical part of the MPDS. First of all, I like to say that in MPDS, surgery has a very minimal role because if we talk about MPDS, it can be a focal, regional, or it can be a chronic, fibromyalgia. So basically, the etiologies are too many. Although you can easily diagnose an MPDS with the trigger point, out bands, and the patient giving you a history of pain, right? But it is first of all important to know the etiology. What is the factor which is affecting, and definitely occlusion plays a very important role. If you have a micro trauma or you have a macro trauma, it is going to, cause a problem in the, it's going to fatigue the muscle. Overloading of the joint as well as the muscle fatigue can lead to further increase in the pain to the patient. So you have to go with the conservative management. The surgical management, can only be taken once the non-surgical treatment has been ineffective. You cannot take a surgical treatment for patients who are asymptomatic or who are minimally symptomatic, or you are trying to prevent or, you want to attempt to prevent the TMDs, temporomandibular disorders. You can only think of surgeries whenever the patient is in moderate or severe pain. First of all, he has dysfunction, which is disabling to the patient, right? So if we talk about MPDS, then the etiologies we can talk about is, first of all, we need to have a proper history with the patient, right? We need to know whether the patient is having a, direct trauma, because if certain times you see that focal, muscle tenderness is there. If you have an inadvertent intramuscular injection of local anesthesia given in your medial pterygoid, if you are giving an inferior alveolar nerve block, the patient comes back to you with the reduced mouth opening and he's having a pain. So the treatment modality will change. But if the patient is having pain because of some secondary myogenic cause, like maybe a internal derangement, right, which can be with reduction, without reduction, or there are adhesions between the, in the joint, between the disc and the joint, or you have the subluxation, you say, when the joint, the condyle comes out beyond the eminence, right? Can be habitual or not. So first of all, we need to know, it's a widespread topic right now. And in MPDS, you first start with the, history and the stress, and then the causative factor, and then your stretch exercises, physical exercises, then making the occlusion, balancing the occlusion. Then comes, the splint therapy. Then the other aerobic exercises come, and then the pharmacological aspect. When you give anti-anxiety drugs to the patients, painkillers, you give non-steroidal, this thing. But since my topic, is the surgical part, right? So I'll just come back to that point and would like to say, if the TMJ, the disc condyle is the reason for that myogenic pain, right? So for that muscle fatigueness, maybe because of the lateral pterygoid. If the lateral pterygoid muscle is involved, sometimes we give botulinum injections in that lateral pterygoid. That is one thing. Second thing is, if suppose you have the internal derangement with reduction, right? Then the patient is having clicking, right? At that time, open click is there when the patient opens its mouth. At that time, you do not require, any surgery for that. You will wait for some time. You'll ask the patient to have soft tights, to reduce the mouth opening, restrict the mouth opening. If he is having a, yawning with the open mouth, you need to avoid that. So you need to talk with your patient. If you're having a stress point with factor, you have to release that. So after going through that, suppose if the now patient, you're saying that the patient has without reduction. Now the disc derangement is without reduction, means the disc is placed anteromedially to the condyle and it's not coming back while opening. Well, the condyle and the disc is not coming its 12 o'clock position, right? The posterior band. Then you need to go with the surgeries. So coming back again to my topic is the minimally invasive surgery. In that you go with the arthrosynthesis. You all are aware with the arthrosynthesis, right? In which we do the lavage of the joint, upper joint cavity with the help of needles. Then nowadays we have done a thesis also on this. We are treating the patients with the platelet-rich fibrin, PRF, into the joint cavity. And also we have given growth factors, right? We centrifuge the blood, take out the growth factors, and we inject that. That is also giving us good results. So these are the minimally invasive procedure where we can inject, but I will not say steroids. If you want to give steroid, then the question arises when to give steroid, right? Certain times you must have known that you give steroids in the joint cavity for healing, but that is only when there is an acute inflammation, and that should not be more than 2 injections in a 6 months therapy. So these are the minimally invasive procedures, but in this arthroscopy also plays an important role, although we do not have arthroscope in our institute and we are not using it, but it can be used for the diagnosis as well as for the treating purpose also, where you can do the lysis, lavage, and distension of the, if there is adherence and adhesions between the disc and the condylar surface or the articular fossa, you can just remove with the help of that. And once if you have failed with all this, then only will you go for the open joint surgery. And if you want to know about the open joint surgery for the UGs as well as the PGs, there are procedures like we go for the disc, disc repair, in which we do the disc repositioning also with the help of Metec anchor sutures, we reposition this back. So once if you have a proper, disc condylar relationship, so it's a complex structure. You need to, like, mandible is the CEO, as Dr. Shelley said, right? So mandible is the CEO. Similarly, the occlusion, the muscles, the joint, everything has to be in harmonious balance. If anything is missing, it has to be brought back into position. If the disc is, the abnormal position of the disc is the problem, then we have to go back and bring that disc into position. Even if it is the last resort is going for the open surgery, we can do that. For that, we have other modified condylotomy. In modified condylotomy, we do intraoral vertical ramus osteotomy. So that changes the disc and the condyle relationship. But we cannot predict how much we are going to achieve that space. Similarly, you can go with a condylar shave. If you have a problem because of, osteoarthritic changes, then that also causes pain. Then you need to go with the, condylar shave at that time. And if finally, if there is, a permanent dislocation, suppose there is a dislocation, then you have to go with the, relocating the condyle and doing the eminence, you have to bring it down just to prevent that condyle from moving forward, or you can put a screw or a plate in that region. So there are various procedures for different, different problems. So, but we have to start with the conservative method, and we'll have to continue with the conservative method till the time the pain is, that severe that we cannot achieve, with the painkillers or splints or the occlusal therapies. And then you go with the MRIs for the diagnosis to know the real cause. Suppose it is in the disc or it's in the condylar surface, what is the real cause? And then we can go with the TMJ surgeries. But just to brief with the surgeries, we start with the minimal invasive, in which we go with the arthrosynthesis and the intra-articular injections, like we have the PRF, and then the centralized growth factors, concentrated growth factors are also being, made with the centrifuge with the patient's own blood that can be injected over there. And then low-level laser therapy, yes, low-level laser therapy, it gives a deep, deep heat inside. You say, you generally give patients that moist heat therapy or the ice pack therapy. Why do we do that? To increase the vasodilation, so that the free radicals which have accumulated there because of the muscle fatigue can be, washed out. There has to be a balance between physiologic balance between the two, between the repair and the degeneration. So it's a balance between the all of that.
Yes,
So
ma'am.
any other question which I can help?
Yes, ma'am. Ma'am, one question. May I ask ma'am one question? Okay, ma'am. Ma'am, what will be your view for the nowadays autologous blood infusion, ma'am? Ma'am, what would you like to say? Is it beneficial, or it may promote to the ankylosis or something? Because ma'am, we are is little debate is going on this, because the same process we are initiating as in case of the ankylosis, some blood bleeding, blood we are infusing into the patient preauricular region, ma'am. Ma'am, a little about that, ma'am.
I got your point, Dr. China. See, autologous blood, when we are using it, we are using for the dislocation cases when there is laxity of the capsule of the condyle. So we use hypertonic salines, or we use the autologous blood, to cause fibrosis in that region, in the capsule basically, and the ligaments, so that the condyle do not dislocate on its own, just to cause that tension in that area. But it will not cause the ankylosis. Ankylosis is basically the union between the two bones, right? And it happens when there is a trauma and there is your own blood is there, but along with the blood, there is no interposition material in between. That is a different scenario when the ankylosis occur. Suppose you have a trauma. So the reason is for ankylosis to develop over there is we do not have an interposition material over there, because the disc gets displaced in trauma. It is not there in between. There is no capsule. There is a tear of the capsule. There is a tear of, there is a total disorganization of that joint, anatomy. The capsule, the disc, this thing. That causes the ankylosis. It is not that only blood is causing that ankylosis. That is not the fact. The blood organizes into a bone. But for that to occur, there has to be different criteria also. Because if we go for the open joint therapy, what happens there? Blood is there when we are doing the surgery. So yes, ankylosis will not happen over there. If I'm doing a disc repair, suppose it's an open joint surgery. But then I'm not going to get ankylosis over there, because I'll be recreating that anatomy, normal anatomy of that joint area. Capsule, the ligaments, the disc has to be placed in the proper position. So autologous blood, if you talk about, that is used for the tightening of that capsular region in cases of the dislocations or subluxations.
Subluxation. Okay. Thank you very much, ma'am, for giving us so much knowledge about the orofacial pain and the role of the oral surgeon in the MPDS, ma'am. Thanks a ton, ma'am.
Yeah. I'm sorry, because MPDS has a very little for the role of surgery. I think it is only the last resort when you go for the surgery.
But ma'am, yes, ma'am, my many doubts has been cleared. One doubt was the ABI, ma'am. I have a doubt regarding that, ma'am. Go to clearance that, ma'am. Yeah, it plays a very much role. Yes, ma'am.
Thank you.
Thank you, ma'am. So, thus to conclude, Nurul sir, may I conclude session, sir?
Okay. Yes. It's a very, in-depth, comprehensive discussion with all our learned panelists who, discussed a lot and, taken the subject in depth. So I'm very thankful to all our panelists, Dr. Zainab, Dr. Pavni, Dr. Indra, Dr. Sonal, Dr. China. Dr. Deoshri couldn't join actually. She's a psychiatrist, so she would have also some point because, patients feeling stress and pain on that time. So, but somehow she couldn't join. So thanks to all. I'm requesting all those panelists, if they can stay with us, because there are, 8 or 10 beautiful ladies who is going to present their PG presentation. And if you'd like to judge their presentation, you can ask questions and all. There are some PGs who are from conservative dentistry. One is from perio. There is 1 or 2 from oral medicine and radiology. And there is 1 or 2 from oral surgery. So if you can stay there, you can ask questions and all. But For marking and all, Dr. Cheena is the chief judge, so she's supposed to give the marks 0 to 10 scale, and accordingly we can publish the result of who is gonna do first, second, third, and all. So I think all the participants, presenters are there in the meeting room, and I'm calling one by one. First, I call Dr. Sana Shadab. Dr. Sana, are you there? Can you unmute and share your slide? I have made you a co-host.
Yes, I am there.
Yes.
So is it visible?
That's visible. So I'm requesting all the presenters in a PG presentation that we have already lagged behind, say 90 minutes. So we're supposed to close it as soon as possible, because other there are 7-8 presenters who are supposed to present. So could you please take care of the time so that we can finish it, though we are late, but we'll try to finish it as soon as possible. Yes, Dr. Sana, please start with your presentation.
So is it visible in the slide?
Yeah, it's visible. It's not visible in slides show mode, but it's visible.
Now it's visible, right?
Mm-hmm.
Okay. So a very good evening to all. My topic for presentation is reattachment of fragment of fractured interior tooth. As you all know, coronal fractures of the interior tooth are a common form of dental fracture that mainly affect children and adolescents. Okay. The majority of dental injuries involve the anterior teeth, especially the maxillary incisors, because of its position in the arch, whereas the mandibular central incisor and maxillary lateral incisors are less frequently involved. Dental injuries usually affect only a single tooth. However, certain trauma types such as automobile accidents and sport injuries involve multiple tooth injuries. There are many factors when we come to the point of management. So first is extent of fracture. That is there any violation of the biological width? Is there any endodontic involvement, or is there any alveolar bone fracture? Second is the pattern of fracture and restorability of the fractured tooth. Is the fracture is reaching up to the root, or it is concise to the coronal part of the tooth? Secondary traumatic injury, what is the extent of the soft tissue injury? Presence, absence of fractured tooth fragment and its condition for use, occlusion, aesthetic, finances, and prognosis. Patient cooperation and understanding of the limitations of the treatment is of utmost importance for good prognosis. When there is a substantial associated periodontal injury and invasion of the biologic width, the restorative management of the coronal fracture should follow the proper management of those associated issues. Coronal fractures must be approached in a systematic way to achieve a successful restoration. Reattachment, that is what I'm going to discuss, is of a fragment to a fractured tooth can provide a good and long-lasting aesthetics because the tooth's original anatomic form, color, and surface textures are maintained. It can restore the function, can result in a positive psychological response, and is a reasonably simple procedure. In addition, tooth fragment reattachment allow the restoration of the tooth with minimal sacrifice of the remaining tooth structure. Furthermore, this technique is a less time-consuming and provides a more predictable long-term wear than when direct composite is used. Clinical trials and long-term follow-up have reported that reattachment using modern dentin bonding agents or adhesive luting systems may achieve functional and aesthetic success. Several aspects may govern the choice of reattachment techniques. Studies have reported that primary cause of fragment loss is the new dental trauma or non-physiological use of restored teeth. Therefore, most concerns about reattachment techniques have been directed towards the fracture strength of the restored tooth. Now, this is a 28-year-old male patient reported to our OPD with a chief complaint of fractured tooth along with severe pain due to trauma from fall. As you can see, there is a fracture line associated with the lateral incisor. On radiographic examination, the fracture line was quite evident, reaching up to the pulp, categorizing the fracture into LEs class 3. On examination, biologic width was intact, but fracture was reaching close to the cervical margin. So first, we only removed the fractured segment to assess the extent of the fracture line, which was found to be equigingival. So as we planned for the reattachment, gingivectomy was performed to expose few millimeter of tooth surface above gingiva for better visibility, accessibility, and isolation. Later, root canal was performed, followed by the post-space preparation. This is the clinical picture. The post-space was prepared inside the segment. After that, the fiber post was edged to increase the surface area for better adhesion. A small space was prepared in the fractured segment to receive a portion of post for reattachment. Then fractured segment was edged and primed. Tooth was edged and primed. And all the 3 units were adhered with the help of dual cure composite, and later it was light cured. Finally, the occlusion was checked and the reattachment was done.
Dr. Sana, your slide is not moving. Can you click the slide over which you are delivering the talk?
Sir, on which slide am I visible on your?
It's a slide. It's the first slide actually. Somehow I couldn't look at it.
Oh.
Just yeah.
Sir, is it now moving?
No, it's not moving.
Actually, sir, in my PC it's moving, so I'm not able how to do.
No, you come out of this slideshow mode and then you share it again. Yes, now it's moving. You are on 11th slide, I think. Post endodontic treatment clinical photograph. Yeah.
Yes, sir.
Carry on. Move on.
This is the preparation of the post. We edged the post. We prepared the fractured tooth segment. We edged it. We primed it. We edged and primed the tooth. And then later on, with the dual cure composite, we bind all the 3 units. Then it was the exactly after post treatment photograph. This patient recently came to me for a pain in different tooth, and so I took a photograph of this. So it is a 4-year follow-up photograph, and it's still intact. The patient was happy. The occlusion was good. So that's why I tried to share this this case so that we can be more confident doing these type of reattachment of detached fragments. Thank you, everyone. Hello.
Dr. Swati, you can ask question. Dr. Swati, are you there?
Yes, I'm here.
Mm-hmm.
Yes, Sana, we are not able to see the case properly as your slides were not moving. So I want to see the case again.
Yes, ma'am.
Clinical pictures, please.
Ma'am, is this visible now?
Yes, now it is visible.
Ma'am, this is the pre-operative radiograph. This is the fracture line.
Okay.
This is the pre-operative photograph. We removed only the fractured segment, but the fracture line was kind of equigingival. So we go for the gingivectomy to expose a part of the tooth so that we can adhere it properly for visibility, accessibility, and isolation. Afterward, we did the root canal treatment and prepare the post space. And this is the clinical picture of that. We put the rubber dam. Then we etched the fiber post to increase its surface roughness for the better adhesion. Then this is the tooth. We slightly put a small hole inside that so that it will take the fiber post. And this is the preparation of the fractured segment. This is the preparation of the tooth. And then finally, both 3 units were adhered with the help of the dual cures composite. And this is the reattachment. This is the 4-year follow-up. Recently, patient came to me, so I took his photo.
Now, what are the indications the reattachment of the fragment. Like case selection is very important. So what points were there in your mind while you selected?
Ma'am,
Decided to go.
yes, ma'am. The points are that there shouldn't be any violation of the biological width, and the extent of the fracture is the most important point. Actually, it basically it's quite close to the cervical area of the tooth, which is a danger sign because the most of the flexural strength, flexural forces are in the cervical area. But we took a chance, we can say, for that. And
have you checked the bite? Have you checked the bite of the patient?
Yes, ma'am. Actually, the occlusion of this tooth is slightly buccally tilted. Matlab already already it's a slightly buccally tilted tooth. So it wasn't
It's out
coming
of
into
occlusion.
contact. Yes,
You
ma'am.
say it was not in occlusion, huh?
Yes, ma'am. It wasn't in occlusion. There's a slight buccal tilt in this. As you can see, it's.
So would you advise to go for reattachment in the case of deep bite? If there is some deep bite patient.
No, ma'am.
Then what is your suggestion?
No, ma'am. If there is a deep bite, we shouldn't go for that because the post reattachment trauma is the basic cause for the failure of the reattachment, according to various studies. If there is a
Are you sure? If or the extent of fracture is important to determine in the case of deep bite. Like if fracture is in the coronal region only, then.
Ma'am, actually reattachment is somewhat depends on the patient's choice. Actually, we can go for the reattachment based on the consent of the patient. But if it's a deep bite and it's going to cause a patient problem afterwards, so it's better to avoid it and go for a treatment that will be long term for the patients, not to take a chance in these type of cases. If you
mean to say that in deep bite cases we should not go for reattachment?
Ma'am, we can go for, but based on the
prognosis
patient's
is
content,
like
patient's content.
Prognosis is doubtful. That is what you mean to say.
Yes, ma'am. Because if there is a trauma, if there is a regular trauma over that, it can result in the failure of the reattachment.
Okay, so you are not totally in favor of reattachment. Okay, as you said, finally that it's a 4-year follow-up is there. So you are recommending that we should try for reattachment. But what I feel that it is like you are a postgraduate student. Okay, you are trying everything. You are experimenting. But in clinical practice, we should think before going for a reattachment of the fractured fragment. Prognosis is very important, right?
Absolutely, ma'am. Yes.
So that should be there in your mind. What is the prognosis, especially in private practice?
Yes, ma'am. Definitely.
Okay, nice presentation.
Thank you so much.
Yes, Dr. Narul.
Yes, we are moving to the next presenter, Dr. Rashmit Minocha. Dr. Rashmit, are you there?
Yes, sir.
Okay, so you please share your slide.
Just 1 second, sir.
There is a deep bite.
Yes, it's visible now. Present precisely, yeah. Focus one, we have to save time.
Is it moving?
Yes, visible.
Greetings to all fellow dentists. I am Rashmit Minocha and I'm presenting the following paper. The paper surrounds a behavior management technique popularly known as hand over mouth or home. This method is often used for hysterical pediatric patients during bouts of tantrums that hamper dental work or its quality. The technique involves a dentist gently covering the mouth of the child with a towel or their hand, intended to control the verbal outburst of the child and calmly explain the child about the necessity of the treatment and their expected behavior during its course. The hand is removed and ideally the child is praised for calming down.
So going into a little bit of insight, how did this method come about? The method introduced by Dr. Evangeline Jordan in 1920 was widely used all over the world. The classical method of home also comes with certain variations, like hand over mouth with airway restriction, which includes by obscuring the nostrils of the child and using a towel to cover the mouth, which may be wet or dry. Before it started facing various issues raised by dentists and parents, that questions about the method's morals and its ethical issues and its associated litigations. The method gained negative attention from parents when performed incorrectly or without consent. The widespread dislike caused the AAPD to discard the method from its list of behavior management techniques very recently. If we dive a little deeper into the method itself, it is ideally advised to use this method for a child that has the ability to understand simple verbal instructions above the age of 3 years. It is only used for a child in case they are uncooperative and throw hysterical tantrums. It is fairly understood that the method shouldn't be undertaken without the parent's consent. In addition, the method isn't preferred for children under 3 years or may not be mature enough to comprehend the method as a consequence of their actions. It is discouraged in handicapped children and when the dentist is personally attached to the child. So coming up to why I took up this topic, what is the issue? The method, if performed incorrectly in the inappropriate cases, provides a good way for the if the method is performed correctly in the appropriate cases, it provides a good way for the clinician to reason with the child, but done incorrectly can lead to psychologically traumatic experience for the child as well as the family, leading to long-term phobia surrounding dental treatment. Since this is an issue that all dentists face a lot, that there's a white coat fear in the child, we don't have a lot of positive feedback from the children very often. This is why I've picked up the topic. The method may be resorted to commonly in unwarranted situations as well, due to a mere habit by the dentist, and may result in acquired white coat fear, which is previously from a previously positive child. Another reason the method seems to be dying out is because parental discontent and legal constraints are there in many countries. I seek to bring this topic to light as despite the decline of home in international practice, we still see this heavy dependency in our country. I personally feel the cons outnumber the pros of the method, and considering the sheer number of advancements that we have in the pediatric behavior management techniques, it is opportunity enough to bid this method goodbye once and for all, making the dental visits a much more pleasant experience for the patients and their families. Thank you. Noting a few methods that allow us to give them a more pleasant experience, we can consider desensitization, audiovisual aids like white noise, virtual reality, videos, live modeling or modeling through videos, tell show do method, which is very, very popular when it comes to pediatric practices.
Okay.
Thank you.
Dr. China, Dr. Swati, any question you want to ask? Dr. Swati, are you there? Dr. China, could you please unmute your...
Rashmit, right?
Yeah.
Yes, ma'am.
It was a good presentation, although informative also. For how many patients? You are a postgraduate, right?
No, ma'am, I'm an intern.
Okay, intern. How many patients you have seen that your postgraduate students are doing this technique?
Ma'am, I've seen in at least 3 patients that wherein, they were getting a pulpectomy and the patient was uncooperative, and there was a reason behind it, as the parents could say, and they were very harshly being scolded, and when it didn't work out, their method was used.
So do you think that if the patient is uncooperative, he or she will allow it to put the hand on his or her nose?
No, ma'am. But this is one of the main reasons why I'm against this method personally, since I feel that this is a very physical method wherein the ideology in a child's mind can cause a negative impact, and as well as it is physically restraining the child. Maybe we can resort to better methods.
Yes. Okay. Okay, sir.
Okay. Now we are moving to Dr. Sapna Pandey. Dr. Sapna, could you please share your slide?
Yes. Good evening, everyone.
Very good evening.
So is my screen visible to everybody?
Yes, visible.
So just a second, I'm not able to change my slides. I'll check again.
You can, yes, yeah, so,
yes.
Yeah, first slide is visible.
Yes. Okay, the topic of my presentation is recent non-invasive diagnostic advances for diagnosis of potentially malignant disorders. Potentially malignant disorders are a group of clinically suspicious conditions of which a small percentage can undergo malignant transformation. Biopsy is considered gold standard invasive diagnostic methods, but it is limited by morbidity, resource requirement, and the potential for underdiagnosis. Recently, in vivo microscopic technologies such as high-resolution microendoscopy, optical coherence tomography, reflectance, conofacial microscopy, and multiphoton imaging are helpful in diagnosing premalignant disorders, which can overcome the poor accuracy of existing adjuvants such as toluidine blue, acetovitamin, and acetofluorescence imaging. The limitations of biopsy, as and why I'm choosing this topic, is the limitations of biopsy that we have are sampling bias, trained clinician required to perform the biopsy correctly, trained pathologist for diagnosing the tissue that sample that has been sent to them, and the time-taking procedure, and inter-observer variances, and patient morbidity and discomfort. So the first the newer techniques that are available nowadays are high-resolution microendoscopy. This is an inexpensive fluorescence microscopy contained in a small box with an attached flexible probe of 0.79 millimeters diameter. You can see the probe; it's almost like a wire here. So it is completely non-invasive technique. A cotton-tipped applicator is used to apply proflavin, of vital fluorescence dye that stains cell nuclei to the tissue of interest. The probe is then placed in gentle contact with the proflavin stained mucosa to visualize the surface epithelial nuclei directly. Small, evenly spaced nuclei are seen in the HRME images of the normal mucosa and benign lesions, whereas large, crowded, and irregularly shaped nuclei are seen in the high-resolution microendoscopic images of dysplastic or cancerous lesions. So in this, you can see how a normal mucosa appears and how a dysplastic mucosa appears. Then the limitations include it is small, so a very small area we can see at a time, or 0.79 millimeters of field of vision for one time. It is a time-consuming process as we are seeing a very small area at a time. To overcome these limitations, autofluorescence imaging can be used for initial localization of the lesion. So autofluorescence imaging system has low specificity. The low specificity could be overcome by using high-resolution microendoscopic image to image the nuclei at high-risk sites identified by the autofluorescence imaging. Then in the picture, you can see how the in A, red and white ulcerated lesions is seen in white light. And then the second image, B, you can see how it appears in autofluorescence imaging. In C, you can see how an HRME probe is there on the lesion. And in the last image, you can see how it appears on the imaging site. Then optical coherence tomography. This is the second new innovative technique which is used. Optical coherence tomography produces two-dimensional tissue cross-sections of light scattering, which are stitched together to produce a three-dimensional volumetric map. The advantage of optical coherence tomography include micron level resolution with large penetration depth and field of volume of up to 1 into 1 centimeters square, compared with the most other in vitro maturation techniques. The large penetration depth allows for visualization of the full epithelial thickness and superficial connective tissue to evaluate cellular invasion. Then the next is reflectance conofacial microscopy. In reflectance conofacial microscopy, a pinhole is used to reject out of focus light that has been reflected from the sample. The pinhole improves resolution and allows for obtaining images of various depths of tissue and for potential differentiation of different gradings of dysplasia. With the exception of hypertrophic lesions, reflectant conofacial microscopy system may be configured to image the basement membrane and superficial connective tissue. So this is used for a much deeper layer. We can study each layer step by step. And this is how each depth, according to the depth, it increases. Then multiphoton microscopy. Similar to conofacial imaging, multiphoton microscopy is a type of fluorescence imaging that can obtain image cross sections at various depths of tissue at large depths of up to 1 millimeters. The large penetration depth could potentially enable evaluation of cellular invasion past the basement membrane. Autofluorescence-based multiphoton microscopy measures the same signals as existing autofluorescence imaging instrumentation, but with the added advantage of depth section visualization of microscopic features. However, multiphoton microscopy instruments can typically only image field of view of a few hundred microns in diameter and require much stronger light intensity. So this is how the depth can be visualized from the tissue surface to at least 1 millimeters inside the tissue. This is the review of literature from where I've taken this. So to conclude, improved methods of diagnosis and risk stratify pre-malignant disorders could decrease the global burden of oral cancer. Biopsy is the gold standard for diagnosis. Even still, it is considered as the gold standard for dysplasia and cancer, but it is limited by morbidity, time and resource requirement, and the risk of sampling bias. The existing diagnostic adjuvants that provide immediate feedback are limited by poor diagnostic accuracy. In vivo microscopy technologies are a promising avenue to help clinicians identify high-risk pre-malignant disorders and to select a biopsy site, which could result in improved patient care. However, additional technologies, development, and clinical studies are required to establish and validate their diagnostic accuracy and uses. Thank you.
Dr. China, do you have any question?
Dr. Sapna, right?
Yes, ma'am.
You are a postgraduate student?
Yes, ma'am.
Okay. Can you please tell me the incidence, cancer percentage, oral malignant transformation, percentage of speckle leukoplakia? Here we talk about the PMD, right? Nowadays, new words to the red and white lesion, right?
Yes, ma'am.
Okay. So can you please tell me the percentage of that speckle leukoplakia?
Ma'am, I don't know exact percentage of this. Sorry, ma'am.
Okay. Then the second question is from the white lesion. Okay. Buckets only. Can you please name the two types of candidiasis which are more predisposed to the cancer transformation and why?
Oh, sorry, ma'am, I don't have any idea about this. I did not study this.
Okay, it was a good presentation. You did this study?
No, actually, it was a review of literature. Yes, I studied all of these and collected like all the evidence.
Okay, okay. It was a good presentation. Okay, it was a good presentation.
Dr. Aparna, if you are there in the Zoom room, can you ask question if you have any questions? Dr. Aparna? So we are moving to the next participants. Dr. Tasneem Fatima. Dr. Fatima, are you there?
Yes, sir. Good evening, sir. Good evening, everyone.
Yeah, please.
I'm audible, sir?
Yeah, you are audible. Please share your slide.
Yes, sir. So is it visible?
No,
My
it's
slide?
not visible. Yes, we are waiting for that.
Okay, sir. So is it visible?
I think your internet is a bit slow. It's visible now.
Okay, sir. So may I start?
Yeah, you can.
There is my slide is moving.
Yes, visible. First slide is visible. Extraction socket preservation. Yeah. Introduction.
Second slide. Yeah. Okay. Thank you. Okay. Good. First of all, good evening, everyone. I'm Dr. Tasneem Fatma for paper presentation here, and the topic is the extraction socket preservation, a near technique to mummify the bone. So let's start with the introduction. Whenever tooth is lost, there the morphological changes take place in the hard and soft tissue around it. After there, the changes in the horizontal and vertical dimension in alveolar bone or socket. Initially, there are the 3 to 6 months post extraction are the very critical because of there's a remodeling of the alveolar bone take place during these months only. So socket preservation is a procedure which is done to reduce external resorption following the tooth extraction that enhances the bone formation within the socket. So Hammerl said 2011 revealed that more than 60% of the bone resorption occurred during the first 6 months after tooth loss. So progressive bone resorption after extraction of the tooth may lead to prosthetic driven and surgical difficulties when a dental implant has to be placed after extraction of the tooth. So here is a case report. I'm presenting one of my case. So a 31-year-old male patient with non-contributory medical history reported to the department with the chief complaint of a decayed tooth. On the basis of clinical and radiographical examination, the patient was then given the option of the immediate implant placement and the CBCT was advised. The CBCT showed the inadequate bone height present to support the implant. So here are some pre-operative photographs. 1 and 2 picture shows the pre-operative photograph of the patient. First is the extra and then the second one is the showing the decayed tooth. Picture 3 shows the radiograph picture in which the shows the decayed tooth. And the picture 4 is the picture of the pre-operative CBCT that shows the inadequate bone height to plan for the immediate implant. So after discussing the treatment option with the patient, patient agreed for the socket preservation with bone regeneration after placement of implant placement after 6 months. Informed consent was taken from the patient. At the time of the surgery, under local anesthesia, a periotome is used to detach the periodontal fiber. Then luxation of the tooth has been occurred, and then after that the tooth was then extracted with the help of the extraction forces. The periotome is used to for the atraumatic tooth extraction. So here is the procedure photograph. Picture 5 shows the extraction of the tooth 3-7. The picture 6 shows the immediate after extraction. Picture 7 shows the radiograph immediately after the extraction. So after extraction, curettage was done in the socket and remaining granulation tissue was removed and then socket was rinsed with the saline. After hemostasis, I used the BioOS graft material. It is a type of the xenogenic material and it filled into the socket. And after that, PRF membrane was prepared and it placed over the grafted socket and it is tucked between the buccal and the lingual gingiva and stabilized with the black silk suture. The suture is passed through the membrane to prevent the slippage of the PRF membrane. And here PRF membrane is used to prevent the leaching of materials. After that, there are some procedure photograph. Picture 8 shows the BioOS bone graft. Picture 9 and 10 shows the preparation of the PRF membrane. Picture 11 shows the placement of the bone graft into the socket, and picture 12 shows the placement of the membrane and suture is given. Picture 13 is the IOPR that is taken immediately after the procedure. Post-operatively, our patient were administered antibiotics and analgesics for 5 days as a standard of the care, and then patient is recalled after 8 days for suture removal. So here, after 3 months of the patient was recalled for the clinical radiographic examination. On the radiographical evaluation, it was observed that there was a radiolucency seen in the socket area and the partial bone was also seen over there. This is the radiograph after 3 months. So here's a little discussion about it. Guided bone regeneration technique in socket preservation have been approved in many studies using different materials. Vignetti 2011 and Cardoropoli T 2012 have quoted that membrane placement in socket preservation along with bone graft gives better result than no membrane placement. According to the Yip et al. 2015, the grafting material should have a certain specific attributes such as it should be biocompatible, osteoconductive, and osteoinductive. And the PRF membrane in this case acted as a cover for the graft material and act as a barrier membrane for the guided bone regeneration. So generally, membrane use is a time-consuming and expensive. So Murphy in 1995 reported exposure of the non-resorbable membrane in 87% of the cases, leading to infection, swelling, sloughing, and the recession. In my case, this complication didn't encounter, and I've used the PRF membrane to cover the graft material. So in concluding remarks, socket preserved with BIOS showed the good bone regeneration. Use of BIOS and the PRF membrane barrier can assist the healing process and provide the better bone quality while preserving the alveolar bone. These are the few references. And thank you.
Dr. China, you would like to ask any question?
Yes, Dr. Tasneem.
Yes, sir.
And Dr. Swati, it was a nice presentation. I just wanted to know one thing that you showed me you showed here the follow-up radiograph of 3 months, right?
Yes, ma'am.
During like seeing at the X-rays, I saw that there was a big cavity in adjacent tooth, molar.
Yes, ma'am.
Right?
Yes, ma'am. 6.
Did you motivate your patient to get it restored?
Yes, ma'am. I motivated the patient for the restoration because of there's no endo involvement is there over time. So I motivated and the patient is go for the endo restorative treatment.
Patient was ready to go for the restoration, or
yes,
finally
yes,
go for extraction and then bone graft in the socket and all that procedure?
Ma'am, actually 3-7 is the not.
I'm talking about the edges,
but,
the first molar.
Okay, ma'am. Okay.
There's a big cavity in that tooth. Being a doctor, it's your duty. I feel so that seeing the condition of the second molar, right? You place
yes,
you have put the graft in the second molar region.
Yes, ma'am. Yes, ma'am. Ma'am, I voted for the restorative treatment and patient there. Yes, ma'am.
Was patient ready?
Yes, ma'am. Patient was ready for the treatment.
Okay, like it was after you showed us the 3 months follow-up radiograph, and
patient
cavity there too. It was not restored.
And the actually, a patient is from the out of the city. So when the patient came after 3 months, yes, ma'am.
Okay, you did it later. Okay, thank you.
Oh, thank you.
Okay, we are moving to the next participant, Dr. Ankita Garg. Dr. Ankita, please share your presentation. Dr. Ankita, are you there? Dr. Ankita, I have made you a co-host. You can share your slide.
Good evening, everyone. Sir, is this visible? Hello.
It's not visible. Any issue in slide sharing, screen
Sir,
sharing?
I am sharing it, but
yes, it's coming now. Yes, it's visible. KD Dental College. Yes. You start with the presentation. Yes.
good evening, everyone. I am Dr. Ankita presenting a case report on restoring a raised tooth with hemisection and socket preservation by an interdisciplinary approach. In the modern era of dentistry, desire to retain the natural teeth has led to a more conservative approach. Earlier, extraction of the hopeless teeth generally followed by removal partial denture, fixed partial denture, or implant. But hemisection is one of the recent viable treatment modality to retain the natural tooth rather than complete removal of tooth to restore the proper form and the function. Yu et al. Assessed survival rates of a large number of root resected molars and reported interesting findings with respect to the demographic variables. So this case report illustrates the treatment of first mandibular molar where clinician was not able to retrieve or unable to bypass the separated instruments. So a 20-year-old female patient came to the department with a chief complaint of pain in the mandibular right back tooth region since 10 days. The patient gave a history of previous root canal treatment 1 year back. The pain was dull, aching, and intermittent, which aggravated mastication and was temporarily relieved by taking analgesics. Clinical examination revealed mild pain on percussion and palpation. Radiographic examination showed a separated instrument in the mesial root of a mandibular right first molar with a periapical radiolucency. So this case was referred from the Department of Endodontics with a motive of preservation of this tooth. Patient was systemically healthy. So these are the case pictures. So first of all, hemisection was planned for this case, and they did the root canal treatment for the distal root first. Then they sent this patient to our department where we have planned the hemisection. So with the help of a vertical fissure carbide burr, we made a vertical cut buccolingually towards the furcation area to split the tooth in the two parts. And then the mesial root was extracted from the socket. This is the picture of the extracted root. After that, we preserved the socket with the help of a bone graft and PRF. Then silk sutures were placed, followed by Copac. Then patient was prescribed antibiotic and analgesic and recalled after 7 days for the suture removal. Then the patient came after 1 month for the processes. Earlier, we planned implant for the patient, but patient opted for the fixed partial denture. So the crown preparation was done, and then finally prosthesis was given. Hemisection is a useful alternative treatment to extraction to save the multi-rooted teeth by the endodontic approach, which includes the root canal treatment of the remaining tooth and the restoring them. Suitable root restorative material followed by a fixed prosthodontic processes to maintain the occlusal balance. The literature on the distal root section is limited as compared to the mesial root in the mandibular molars because of its anatomical structure. Nevertheless, hemisection is a viable option to be considered before the extraction of the molars, especially in the presence of conditions such as severe vertical bone loss, broken instruments, furcation destruction, unfavorable proximity of the roots of the adjacent teeth, preventing the adequate hygiene in maintenance of proximal areas, and severe root exposure due to the dehiscence. Fuller in 1988 observed the 30% failure rate in hemisection cases attributed to endodontic pathology and root fracture, while other authors, they have shown greater success in the hemisection cases in the long-term studies. In the present case, a good prognosis was observed with the proper occlusion, absence of mobility, and healthy periodontal condition up to 6 months of follow-up. Thus, conservative management of extensive carious molar teeth or periodontally compromised teeth in the patients or root canal endodontically failure tooth in the patients can preserve the tooth and reduce the financial burden, psychological trauma, and occlusal dysfunction. So I'll conclude this case report with that hemisection is an alternative, effective, and conservative treatment modality over the conventional procedures for extraction of periodontally and endodontically affected tooth. These are the references. Thank you for listening. Thank you, organizing team PDCON, for giving me this opportunity on this platform. Thank you so much.
Dr. Cheena, Dr. Swati would like to ask any question. Otherwise, we will move to the next presenter.
Ankita, you're doing PG. You are right now. You're in PG. You're doing postgraduate.
I'm postgraduate, ma'am. Final year.
In final year, in which branch?
Ma'am, periodontics.
You are in periodontics. Why this patient was referred to you?
Ma'am, actually, this patient first came to the Department of Endodontics, where the patient complained of pain, and when they did the radiograph, they found a broken instrument in the middle root.
Okay.
So they referred to us with this motive, like if we can save this tooth and then we can do an implant in the missing area.
No, so they did not try for bypassing the instrument or to do retreatment in this case because bone is quite good, bone height is quite good.
Yeah, ma'am, that's what I said earlier, ma'am, in the introductory part, where they were unable to retrieve the instrument, ma'am, and they were not able to even bypass the broken instrument.
Mention that. You said directly patient was referred to periodontics because there was a broken instrument.
Ma'am,
like being endodontist and fracture instrument can be bypassed. Retreatment was tried, attempt was taken in this case, or yes or no?
Yes, ma'am, it was, ma'am, I said in the case report, I start with that, this case report illustrates the treatment of first mandibular molar, where clinician was not able to retrieve or even bypass the broken instrument.
And the root canal was done by? In half of the portion, as you said,
one of my fellow co-PGs in the Department of Endodontics, ma'am.
He did that, but he was not able to do hemisection.
Ma'am, they referred to me this case.
As patient was not ready to go for implant. I can understand that endodontists they don't do implant.
Yes, ma'am. Earlier, ma'am, patient said that they were ready for implant, but after 1 month when they came, they want an immediate replacement. So they opted for the fixed partial denture.
What I can see from the X-ray that there is a possibility that the instrument can be bypassed, but as you said, okay, case selection. See, case selection is very important. For the success of any treatment, even sometimes hemisection is not according to me. What I have experienced, I have not found hemisection to be very successful, but I'm not against it. But as being endodontist, what I can see that there was a broken instrument in the middle third, and it would be bypassed. So better to save the natural tooth. That is a good, better option always. Yes. Okay, it was a nice presentation.
Thank you.
Dr. Nurul.
Okay. So we are moving to the next presenter, Dr. Leela Lavanya. Dr. Leela, please share your screen.
Okay, sir. Sir, is my screen visible, sir?
Yes, just wait. Yes, visible now. You start your presentation.
Yes. Good evening to the respected delegates, my co-PGs who are presenting, and PDCON organizers. I am Dr. Leela Lavanya, postgraduate student from the Department of Oral Pathology. Today, my presentation, the topic of my presentation is Programmed at Ligand 1 Expression in Oral Squamous Cell Carcinoma, a pilot study. Oral squamous cell carcinoma is mostly prevalent in the South Asian countries, with rising cases of its incidence and mortality. Despite its many advancements in treatment, survival and recurrence rates are very poor. Immunotherapy is a novel therapeutic marker, and mostly now the immunotherapy is being a modality in the immune oncology. And immune checkpoint proteins are under investigation for clinical implications, among which programmed death ligand has shown a valuable results in certain malignancies. The aims and objectives of my study are to evaluate and correlate the expression of programmed death ligand 1 in different grades of oral squamous cell carcinoma by immunohistochemistry, to compare and evaluate between the different histopathological grades of oral squamous cell carcinoma and between the normal tissues by immunohistochemistry. So these are my materials and methods, wherein we have first selected the OSCC subjects and an incisional biopsy was performed. These are the instrumentation used for incisional biopsy. Then the tissue was sent for tissue processing, sectioning was done, hematoxylin and eosine staining was done, and a confirmatory diagnosis was taken. Later, we have sent for immunohistochemical staining. These are the instruments used for immunohistochemical staining, and this is the primary antibody of PDL1, and these are the secondary antibodies of PDL1. And later, after the PDL1 staining was done, results were tabulated and statistics were done. So these are my results, wherein we have seen in different grades of oral squamous cell carcinoma, there have been with an increase in the grade of oral squamous cell carcinoma, there is an increase in the staining intensity and distribution. The first 3 pictures shows This is the picture of a well-differentiated squamous cell carcinoma, HND, and these two are the pictures showing PDL1 positivity in the epithelial region and also in the keratin pearl region. And the second one, three pictures are the pictures of moderately differentiated squamous cell carcinoma, where we have seen a moderate staining in the epithelium and parts of the connective tissue. And the last three pictures are those of HND staining of the poorly differentiated, and these are the immunohistochemical staining, where they and in these pictures, if we have observed, there is an increased staining intensity from well, moderate to poorly. These are my results. Based on the staining intensity in different grades of oral squamous cell carcinoma, we have observed that there is an increased staining intensity when in compared to poorly differentiated grade, when compared to the moderately, and very less in well differentiated. And the staining distribution also has been seen to be increased in poorly differentiated when compared to well differentiated, moderately and well. And we have seen a negative expression of PDL1 in the normal tissues, which we have obtained from the buccal mucosa and the lymph node. The summary: OSCC formation and progression are heavily reliant on the immune system, and numerous mechanisms of tumor immune escape have been identified. And this can be the release of immunosuppressive mediators and alterations in the lymphocytic function. And recent advances in the cancer immunotherapy involving the immune checkpoint inhibition have significantly altered the practice of clinical oncology. Cytotoxic T cells are inhibited by the signal of PD1 activation. PD1 and PDL1 and PDL2 expressions are elevated in the number of cancers according to research, and the expression of PDL1 and PDL2 in the cancer cells have been linked to the defending against a particular immunological response. Some additional treatment options such as monoclonal anti-PD1 antibodies, that is pembrolizumab and nivolumab, have dramatically increased the overall survival rate of patients and with a metastatic or recurrent OSCC. Despite the immunological checkpoint's significance, the clinicopathological relation to PDL1 in OSCC is unclear. And based on our study, overexpression of PDL1 results in immunosuppressive tumor environment and prevents the T cells from mediating the cytolysis in solid tumors. In tumors, PDL1, it blocks the activation of T cells, exhausts the T cells, leading to apoptosis in the effector T cells, impairs the cytokine production, which leads to tumor growth. So based on the studies by Yongxi et al. And Lin et al., there is an increased PDL1 expression in the advanced histological grade with low overall survival rate, which is observed as the same in our case. And PDCON et al. Also showed that higher PDL1 expression in poorly and moderately differentiated grade showed poorer prognosis of the lesions. And this was also similar to the results of our study. There were also some studies where PDL1 has been not significantly shown in poorly differentiated and moderately, where an extensive literature has to be written. And the results of our study concluded that 84% of the cases were strongly positive for PDL1, and none of the normal tissues were tested positively for PDL1. And in the present study, there is a statistically significant correlation with respect to the intensity and staining distribution of PDL1 positivity. So to conclude, PDL1 marker can be utilized as a prognostic biomarker in detection of survival rate, and also effectively can be used as a target therapy in immuno-oncology. These are my references. Thank you to the organizers for giving me this opportunity.
Dr. Cheena, do you have any question to Dr. Leela? Dr. Aparna, do you have any question with Dr. Leela if you want to ask? Okay, so we are moving to the next presenter, Dr. Indra Priyadarshini. Dr. Indra, are you there? I think she is not available. Then Dr. Shama Parveen. Dr. Sham, no, she is also not there. Dr. Shua Akhtar. Dr. Shua, are you there? Yes. Dr. Shua, please share your screen.
Yes, sir.
This is the last but not the least presentation. After that, we finishes our first day PDCON 2023. Dr. Shiva, we are waiting for your slide to be visible. Yes, visible. Please unmute your microphone, Dr. Shiva. Yes.
Speak. Good evening, everyone. My name is Dr. Tuba Kazi, and with my co-presenter, Dr. Shiva Aftab, we are junior residents from the Department of Prosthodontics, and we are going to present a review paper on pre-surgical prosthodontic management of cleft lip and palate patients under the guidance of Professor Geeta Rajput and Dr. Pankaj Kharade.
Okay, let's move to the next slide.
Yes, so coming on to the introduction, cleft lip and palate are the fourth most common congenital malformation and the most common craniofacial anomaly. There is substantial racial variation is seen in this. The most common prevalence is seen in Native Americans with prevalence of CLCP, cleft lip and palate, that is 3.6 per 1,000 live births, followed by Asians, that is 2 per 1,000 live births, and then whites and then blacks. So the male-female ratio for cleft lip and palate is 2:1, while it is the 1:2 for cleft palate. So cleft lip associated with palate is more in males and cleft palate is more in females. So early intervention provides a positive impact on the development of the infant in this condition. Coming on to the risks. There are various risk factors that are involved with this condition, including maternal drug usage during pregnancy, infections that occur during pregnancy, especially during the first trimester, and any chemicals or smoking of the mother during the first trimester, and consanguinity. So what are the problems associated with cleft lip palate babies born? So first and foremost, there is a psychological trauma to the parents and associated family. So there are social and emotional problems. Then the second comes the diet and nutritional problems. The patient is unable to feed, and there is nasal regurgitation is seen in cases of palatal clefts. Then as the baby grows, dental and ENT like ear problems and speech problems are also seen. So why pre-surgical prosthodontics is required? So the primary goal of any treatment for cleft lip and palate patients is to restore the normal anatomy. So realignment of the malposition components prior to the surgical treatment is required to allow less extensive surgical procedures for the patient. So for that, maintaining nutritional balance is very critical for the growth and development and to prepare the infant for the corrective surgery. So to serve this purpose, feeding appliance is fabricated that closes the defect and helps the infant in feeding and seizes the neutral nasal regurgitation of the milk during feeding. So what are the available devices that we can use? Initially in 1950s, McNeil used buccal plates, then Latham device were used. It was surgically attached to the palate under general anesthesia, and it remains in place until the manipulation has been completed. Then there is lip adhesive tapes are there, known as Dynaclefts. Then lip adhesion techniques are there. Then the most commonly used techniques that is also used in our department is nasoalveolar molding that was given by Grayson et al. In 1993. In this, we can see the first picture is of Latham device that is screwed with using these bars, metal bars. It is given in surgically it is given and under general anesthesia. The second is the Dynacleft, and the third is NAM appliance. So this is the case that we did in our department. First one, the impression first. First step in the fabrication of the appliance is the impression making. We can use green stick compound or the addition silicone or the silicones we can use putty material, obviously, and then fabrication of the appliance is done on the cast, and then insertion of the appliance is done and activation of the appliance is done. This is a NAM appliance we did under the guidance of Dr. Pankaj sir. Then there is another technique that is digital technique. As we all know that this is a digital era and we are moving further towards the digitization of the dentistry. So this is a technique using digital technique. In this technique, it is a split type 3D printed pre-surgical nasoalveolar molding, in which it is divided into 8 steps, in which selective addition and removal of acrylic is done to direct the premaxilla of the greater segment inward and to direct the lesser segment and the posterior alveolus of the greater segment outwards from the cleft. So in the initial appointment, these appliances are 3D printed and they are given after 1 month or so, after 1 week interval. They are changes and they change it and then subsequently move the segments towards each other and reducing the size of the cleft. So what are the complications that are involved with this therapy is it could be soft tissue complications, which includes mucosal ulceration, hemorrhage, tissue fungal infections, and tissue irritation. So to avoid these soft tissue complications, hygiene of the appliance has to be maintained, and the caretaker has to be instructed to take good care of the appliance after feeding and so on. Then hard tissue complications are there, in which excessive rotation of the segments can occur, and that can result into uneven configuration of the segments or the face. And there are also compliance complications because parental and caregiver commitment is required for the successful therapy. Then coming on to the discussion part, pre-surgical nasoalveolar molding assisted in reduction of the cleft gap, fix the R shape, approximate lip segments, and significantly improve the appearance of the nose by straightening flattened nasal wings. NAM has, according to various studies that are shown at the end of the slide, NAM has proven to be an efficient approach to lessen the width of the cleft, that is almost 6 to 16 mm, and ameliorate the shape of the nose and upgrade the symmetry of the face. So coming on to the conclusion, I would like to conclude that NAM technique is an adjuvant procedure that tackles the nasal deformity as well as deviated alveolar segments prior to cheiloplasty. And then NAM approach is said to make primary surgical repair easier and produce better cosmetic results for the baby. And then although the advantages exceed the drawbacks, it is critical to handle the drawbacks in order to avoid any negative consequences. So these are my references. Thank you. Any questions?
Very nice presentation, Dr. Shua, Dr. Tuba rather. Dr. Swati, do you have any question for Dr. Tuba or Dr. Shua? Dr. Swati, are you there? So now we are concluding our first day sessions. Thanks to all our speakers, panelists, judges and all. And we have given the fair chance to present all PGs their presentation, though we have received more papers, but we have shortlisted 6 to 8 presentations, which we allowed them to, share their presentation. So tomorrow we have again joining by say 1 o'clock in the afternoon, and that tomorrow we would be at, apart from dentistry, we have discussed core dentistry today. Tomorrow we will discuss, different issues like legal status of women in India. We are talking about finance in dentistry, then entrepreneurship in dentistry. Then there is a one IS officer. She is joining. She is MBBS, but she joined administration. She became IAS. She's from Aligarh, so she will be one of the speakers. Then we would be talking about, there are two speakers joining from United Kingdom, England, Dr. Subui Arshad and Dr. Naila. She will be talking about the opportunities in the United Kingdom. Then we have a good panel discussion which is related to solution of legal issues. So these are all things we would be discussing tomorrow. We'll join you again at 1 o'clock in the afternoon. Till then, goodbye to everybody, and we are really thankful to all our moderators, speakers, panelists, and judges who spare their time and join with us. I, on behalf of all PDCON 2023 and from National Health Academy and from MedSkill portal, thanks to everybody. Now I'm closing the call because it is very too long. We started by say 2:50 and now it's around 9, so it's a 6-hour on stage presentation. So thanks everybody. Tomorrow we are connecting again at 1 o'clock. Anybody, if you want to ask question, they can ask question. Otherwise, we are closing. Okay. Okay, we are signing off now for today. Thanks.